Good morning to everybody. I can see some of you all are joining now. Fervent request to please mute your mics so that none of the speakers get disturbed.
We are going live in couple of minutes.
Okay, do give me a heads up, then I'll start. Okay.
Dr. Sunil, we are live now on the website as well as those who want to watch it on a website and those who want to come join Zoom room, they can welcome to join the Zoom room. So we are live now.
Great, great, great. Good morning, everybody. I'm Dr. Sonal here today, welcoming you all to International Orofacial Pain Congress 2024 in association with MedSkills and National Health Academy. We had a fantastic day one of the conference wherein our patron, Dr. Davis Thomas, and our jury, Dr. Ratin Das and Dr. Seema Rathi, along with our speaker for the day, Dr. Ramesh Selvam, were kind enough to extend their knowledge and share their insights on orofacial pain. What is orofacial pain? We as dentists, we know what pain is. We all have administered resources and treatment protocol for pain management. But why do we have to have a specialty for orofacial pain? Why do we have to give a correct thought process or a correct treatment plan or plan a strategy for these patients? Because this pain condition is debilitating, multifactorial, and the patients have already walked a lot and their journey has been very, very, very sad. I, as an orofacial pain specialist, have experienced the joy when I see a patient who has been suffering for years and multiple treatment plans have been administered to him or her, and they have not found any relief. And when I see that they are free of pain after decades, the joy and the satisfaction is totally different. So I welcome you all to dwell in this amazing world of orofacial pain practice. Your life is going to change. These coming 2 days, we have speakers who have literally who are going to handheld you into this journey and open a world which is very exciting. It is not easy for everybody to fathom what are we talking. You might think that, okay, this is very overwhelming. But mind you, once you start this journey, you will not stop. This is an amazing 2-day conference, and I'm sure you will gain a lot. And I'm sure there will be many things that you will want to unlearn and learn. With that note, I would like to begin our day 2. Yesterday was fantastic. You all can always watch the video of the previous day on YouTube on the website channels. But today we have an array of speakers who are going to literally make your life different, dentistry in a different way. So as we begin, our first speaker for the day is Dr. Salahuddin Ansari. He is a professor in Department of Anatomy, Jawaharlal Nehru Medical College, Aligarh, and he is going to be talking about the basics. Why I say it's basics? Because he's going to be talking about neuroanatomy of orofacial pain. How many of us have gone back to the books again? Let's just dwell and understand why this is multifactorial, why this is complicated a subject, and why we need to go back to our basics and learn this. Dr. Salahuddin, are you there? Can you just start your camera, doctor?
Yes. Okay. Yes.
Yes, you are the speaker for the day 2. And welcome, doctor. And I would like you to share your screen. Dr. Salahuddin, can you share your screen, sir?
Okay. Yes. I'm sharing. Okay. Is it visible to you?
Yes, sir. Your screen is visible. So with your presentation, I begin our day 2. Welcome, everybody.
Okay. Good morning to one and all. Uh, First of all, very thank you for inviting me. And as you have said that the temperature is already set, and now you have just given me to highlight the basics of the anatomy of the orofacial pain. And basically, pain, you all are knowing that it is an unpleasant sensory or emotional experience associated with potential tissue damage or actual tissue damage or described in terms of such damage. As far as the sensation of the pain of the oral cavity and the face is concerned or are concerned, basically the main nerve of this pain is the trigeminal nerve, the fifth cranial nerve, barring few area. So we can see here that the trigeminal nerve, as the name itself indicates, it is having 3 branches, and through 3 branches, ophthalmic, maxillary, and the mandibular, we can see that most of the forehead region and the bridge of the nose, pain from this area is taken by the ophthalmic nerve, division of the trigeminal nerve, and this malar prominence and the upper cheek, upper jaw, and the lip is carried by the maxillary nerve, and the mandible as a whole and the side of it, the area, pain here is carried by the mandibular division of the trigeminal nerve. And now these are the different branches we can see of this ophthalmic, maxillary, and mandibular division. I will take these nerves one by one. Now, first, the trigeminal nerve, we are aware that it is the fifth cranial nerve. It is having its cell bodies or its nucleus in the pons, and from the pons, the fibers travel and they are entering into the middle cranial fossa. And in the middle cranial fossa, there is a depression known as the Michel's cave, and there is the swelling in the trigeminal nerve that is known as the trigeminal ganglia. And from the trigeminal ganglia, this nerve divides into 3 of its branches, as we have seen the 3 branches. Ophthalmic division, which is coming out of the middle cranial, out of the cranial fossa through the orbital fissure, and the maxillary nerve, which is entering into the foramen rotundum and coming out on the face through the infraorbital foramen. And the third, the mandibular division, it is exiting the middle cranial fossa through the foramen ovale, and then it divides, and its inferior alveolar nerve is supplying the lower jaw and the associated area. Now we can see this here. We can see here that this is the ophthalmic division, and this is the lower one is the maxillary division, and this is the mandibular division. And now the different branches of the ophthalmic division are basically, it is giving 3 branches. One is the frontal, which is dividing into the supraorbital and supratrochlear branches and supplying the forehead. And then it is giving lacrimal branch to the lacrimal gland, and another branch, the nasociliary. And you can see here that the nasociliary branch is giving ganglionic branches to the ciliary ganglia, and then long ciliary nerves, posterior and anterior ethmoidal nerve, and the infratrochlear nerve. Okay. And after we can see here in green, this is the ophthalmic division and its different branches. And you can see the nose of the bridge here also, and the forehead, and the different branches which are supplying it. Then the another division is the maxillary division. And maxillary division, if you can see my arrow is, you can focus on the arrow, that is, it is entering from the trigeminal cave or trigeminal ganglia into foramen rotundum. And through the foramen rotundum, it is entering into the pterygopalatine fossa. And here you can see a swelling in it, and that is known as the pterygopalatine ganglia, which is topographically attached to this maxillary nerve. And this maxillary nerve is also giving branch before entering to the pterygopalatine fossa. You can see here that is known as the meningeal branch. And in the pterygopalatine fossa, it is giving ganglionic branches through which it is supplying the pharynx, posterior part, nasopharynx, through greater palatine, lesser palatine, orbital, and nasal branches. And then it is giving here the three superior alveolar nerves: posterior superior alveolar nerve, middle superior alveolar nerve, and anterior superior alveolar nerve are given by this maxillary nerve. You can see just entering into the orbital floor of the orbit, it is giving the superior alveolar nerve, and because it is posterior, that is known as the posterior superior alveolar nerve. And in the floor of the orbit itself, you can see it is giving two branches. The anterior one is known as the anterior superior alveolar nerve, and the middle one is known as the middle superior alveolar nerve. And the nerve itself is coming out of the floor of the orbit through the infraorbital foramen, and which is giving palpebral branches, labial branches, and branches to the upper lip. And now we can see here in another diagram the branches, the meningeal branch, and then the foramen rotundum, it is entering here, and then the black, which is the ganglia, it is supporting the ganglia, pterygopalatine ganglia, and it is also giving the ganglionic branches. And then it is giving zygomatic nerve, and this is the posterior superior alveolar nerve, middle superior alveolar nerve, anterior superior alveolar nerve, and the coming out of the infraorbital foramen as the infraorbital nerve, which is giving three branches: the palpebral branches, which is supplying the lower eyelid, and the nasal branches, which is supplying the biscaliella of the nose, and the superior labial branch, which is supplying the upper lip. And then you can see here that the molars are supplied by the posterior superior alveolar nerve, upper molars, and the premolars are supplied by the middle superior alveolar branch of the maxillary nerve, and the canines and the incisors are supplied by the anterior superior alveolar nerve. Okay, then the third division, that is the mandibular nerve, it is coming out of the middle cranial fossa through the foramen ovale, and then it is giving branches from the main trunk, and then it divides into the anterior and posterior division. Here we can see this is the foramen ovale, and this is the mandibular nerve. We can see here from the trunk, it is giving nervus spinosus, which is the meningeal branch, and another branch which is going to supply the medial pterygoid. And along with the medial pterygoid, it is also supplying tensor veli palati and tensor tympani. And then it divides into the anterior division and the posterior division. The anterior division is usually mostly motor except the buccal branch, and it is supplying the muscles of the mastications. lateral pterygoid, temporalis, and the masseter. And as we have seen that the medial pterygoid branch is direct from its main trunk. And then the posterior division is dividing into three, giving three branches. Lingual nerve, we can see here, lingual nerve, auriculotemporal nerve, and the inferior alveolar nerve. Through the inferior alveolar nerve is supplying the lower jaw through its different branches. Now you can see it is another diagram to show the inferior, basically the alveolar nerve and the mandibular nerve. We can see that the teeth of the lower jaw are supplied by the different branches of the inferior alveolar nerve, like incisive branch, dental branches, and then accordingly their basically mucosa are also supplied by it. Now, this is the overall view of the different branches of the trigeminal nerve through which the pain is carried from the facial region and the oral cavity. Now, whichever region is being stimulated of the face or the oral cavity, different branches of the trigeminal nerves are being stimulated. And then these nerves are carrying the pain sensation to the final area of the brain, that is the somatosensory area. Now, the pathway here we can see the trigeminal ganglia is a pseudo-unipolar. Here, their neurons are the pseudo-unipolar neurons. And their peripheral fibers are coming from the target organ, and the central processes are entering into the spinal nucleus of the trigeminal. Basically, here I want to highlight that the trigeminal nerve nucleus is having divided into three parts. One is known as the spinal nucleus, which is in the spinal cord, and in the brain, basically the pons and the medulla. Here, basically in the medulla, the main principal sensory nucleus, and the rest, the extending from the medulla to the midbrain, is the mesencephalic nucleus of the trigeminal nerve. Basically, pain sensation is especially carried to the spinal nucleus of the trigeminal nerve, and the mesencephalic nucleus is particularly receiving proprioceptive sensations, and the main sensory or principal nucleus is receiving the tactile or touch information. And then these are the nuclei of the thalamus. Now we can see here in the diagram that from the different part of the face of the oral cavity, pain is carried by the first order neuron. The first order neuron are having their cell bodies in the trigeminal ganglia, and the central fibers of this first order neuron are forming the spinal tract of the trigeminal nerve. And then this spinal tract of the trigeminal nerve, and from when it synapses in the spinal cord, here the second order neurons are forming a bundle, and that is known as the trigeminal lemniscus. And through the trigeminal lemniscus, these pain sensations are carried to the ventromedial nucleus of the ventro-posterior-medial nucleus of the thalamus. As we must be knowing or not knowing, then it's for revision, that basically the most of the sensation of the body, except the face and the oral cavity, are carried to the ventro-posterior-lateral nucleus of the thalamus. And the face and the oral cavity, the pain sensation from here, they are carried to the ventromedial posterior nucleus of the thalamus. And from here, the third order neuron are basically carrying this pain sensation to the post-central gyrus, which is also known as the principal somatosensory area of the brain. They are the different block. You might be knowing more than me about the block. Just I'm going to highlight the pathway of again here. Now, to summarize this whole pain process or how they are being carried, then now you can see the orofacial pain. The different parts of the face, upper jaw, lower jaw, which any of the teeth, nose, any part of the face, they are carried by the different branches of the trigeminal nerve, and then through the trigeminal nerve, their central fibers are forming the spinal tract of the trigeminal nerve, and this spinal tract is synapsing into the spinal nucleus of the spinal nucleus of the trigeminal nerve, and then from the spinal nucleus, the second order neurons are originating, and they are forming a bundle, and that bundle is known as the trigeminal lemniscus, and this trigeminal lemniscus are synapsing into the ventro-posterior-medial nucleus of the thalamus, and from the thalamus, these sensations are carried to the somatosensory cortex, that is the post-central gyrus of the cerebral cortex, and here that is being perceived as the pain. This is the whole, or in short, neuroanatomy of the orofacial pain. And now, if you are having any query, you can ask.
Thank you so much, doctor. And it was really enlightening to go back to your anatomy. Doctor, can you just highlight a little bit on convergence theory? The convergence pathway, that is the most crucial anatomical landmark that is the basic of orofacial pain. So if you can just highlight a little bit convergence theory.
Okay.
Good morning, madam. Am I permitted to ask?
No, just a second, doctor. He's answering this question. Then the next question we'll take in from you. Doctor, okay, Dr. Abhay, you can ask a question then.
Okay.
I am
Sir, good morning. Yeah,
some
good morning,
problem
sir.
Yeah, Dr. Ansari, you were saying something?
Yeah, there is some problem in connectivity problem. I'm not receiving.
Okay. Okay, Dr. Abhay has a question for you. Dr. Abhay, can you just ask your question?
Yes, sir.
Yeah.
Sir, good morning.
Good morning.
It is being said that the right side, while seeing the patient of trigeminal neuralgia, right side is more affected than left side, and the reason which was been traced for the smaller foramina on the right side. Is it true, sir? It has been documented in some of the articles, and I have presented so many journal clubs. There I had come in the review of literature. So is it true that because of that reason we are likely to get right side trigeminal neuralgia much more affected than the left side?
Basically, sir, in anatomical textbook, it is in article, but it is not come as a fact into the anatomical textbook that because of the size, the size of the foramen, we are having the right side trigeminal neuralgia more.
Okay. Okay. Anyway, thank you.
Okay, thank you.
Ansari, and Dr. Ansari, there was a question like, can you just highlight a little bit about convergence theory? I was asking about convergence theory. If you can just highlight.
It needs time to highlight on it.
Okay, fine. Maybe any other question then? Anybody else has a question? You can raise their hand. Okay, Dr. Ansari, you can stop sharing your screen.
Okay.
I'll invite our next speaker, Dr. Varun Kunthe. Hello, Dr. Varun.
Hi, good morning, Dr. Sonal. How are you?
I'm great, doctor. How are you?
Fantastic,
Thanks for being
fantastic.
a part of International Orofacial Pain Congress 2024. And as you see, the participants are still joining in. And thanks for joining in a little early for us. So he is Dr. Varun Kunthe. He needs no introduction in field of orofacial pain practice or DTR practice. He's practicing TMD specialist from Mumbai. And he was the first doctor from India to receive Fellowship of American Academy of Craniofacial Pain, and fellowship, mastership, and mentorship of disclusion time reduction, that is DTR therapy, mini residency in TMJ and sleep therapy. And he is a key opinion leader in many of the TMD forums, and a personal friend and a guide and mentor. So he's conducted almost 150 programs in TMD. I'm sure the number is much more. You have been very modest, doctor, by saying 150, because his each and every case is a mentorship case. So thanks for joining us. And Dr. Varun, the stage is all yours. Can you just share your screen, doctor? Dr. Lavina Arya, you have joined. Please switch off your camera and the mic. A fervent request to every participant to please switch off their mics. Please mute themselves. Yeah. Dr. Varun, can you share your screen, sir?
Yes. It is asking me to quit and reopen, but let me just try it. Just a minute. Okay. Is my screen visible?
It's visible, a very beautiful view of the cliff, and I can see some.
Okay.
Yes, sir. Continue.
Okay. So, good morning, everyone. Thank you, Dr. Sonal, for that introduction, but I am a humble student of TMD and Orofacial pain. I always am trying my level best to help patients and be open for all the concepts and schools of thought of TM joint disorders. So, while I was pursuing my education few years back, about 8 to 10 years back, I came across an interesting technology, which was then told to me as joint vibration analysis. And I was one of the early adopters of this technology here in India. And I started treating some of the cases, and I used joint vibration analysis not as a diagnostic tool, but maybe as something as an evaluation of my cases, my treatment outcomes, and some interesting points I saw during my practice. So I'm here to share my perspective with you. Feel free to differ, and we can always have a nice chat over it. So, uh, joint vibration analysis is something like this, which is placed on the TM joints. It is a sensor which is housed in a silicon body, and what it simply does is you just have to open and close, and it records any clicking sound that you have in the TM joints, right? So a very simple way of doing it is that the if there is no displacement of the disc, or if the joint TM joint is very smooth, then there has to be no significant friction. So if two smooth surfaces are sliding against each other, you will get a line like this. You will not get significant friction. But let's say there are now two rough surfaces here which are moving against each other. Now they are going to create a friction, and that friction can be seen as this vibration. So if you look at these vibrations, there is a particular pattern. And if you study those particular patterns, you can at least try and check whether your TMJs are into any trouble or not. Now, this is the way in which joint vibration analysis is performed. It takes hardly a few seconds to do it. So for some reason, we can't see the video. No, we can't see the video. There's some issue. Anyway, so I will try and demonstrate. You have to place the joint vibration analysis headset on the joints, and you just have to open and tap. Okay. So when you open, tap in between two tap sounds, which is created by your teeth touching each other, the vibrations from the joints are recorded. So take this case for an example. We all know this video. It is of a normal temporomandibular joint without any disc displacement. So this is the normal joint, right? So during this entire movement, there is no vibration. You can see vibrations from the right side listed here. There is no vibration. It's all relatively a straight line. Vibrations from left side are listed here. So you'll see a straight line, no significant vibration. But in the next slide now, if you see, this is the displacement, anterior displacement with reduction. So every time the disc slides off the condyle or is recaptured, it would create a vibration, something like this. Now, each vibration has its own unique identity. Like all of us have fingerprints which are unique to us. So each vibration, if you study and categorize them, perhaps you can try and find what is wrong with the joint. So next example, let's say there is a degenerative joint disease, okay, with a complete displacement and locking and etc. So it's a complete case of degenerative joint disease. The disc is displaced without reduction. It is perforated. So you can see a significant friction noted on the joint vibration analysis. Now, very, very important is what I want to tell you, that JVA, joint vibration analysis, is a diagnostic aid and it's not a diagnostic modality, meaning you cannot arrive at a diagnosis using joint vibration analysis, but you can probably understand more about TM joint situation with joint vibration analysis. It is more like a screening tool. So meaning if there is something that you see on the JVA, something that you see on your clinical examination, your history, then you can perhaps guide the patient to radiological investigations to aid your provisional diagnosis or aid your evaluation, I would say. So let me show you a few cases that came to my clinic and how JVA helped me to identify joint pathologies. So a celebrity patient came to me. This was about, I think, 1.5 year back in January 2023. Now, this fellow went to a dentist and he says that I need to get some dental treatment done. While the dental treatment is going on, the dentist notices that there is some vibration, some clicking sound coming from his left side. And dentist started asking him about this particular problem. Then he says that, yes, I do have this clicking sound, and but it doesn't cause me significant pain. Sometimes it does, sometimes it's not. So the dentist asked him to get in touch with me so that we can check if there's any problem. So he came to us, and during the first session, we did joint vibration study. Now, as I told you, a normal joint would have a vibration which is like this, which would be a complete and total straight line. But if you see his left side, you'll see that there are significant multiple vibrations which are grouped together. Now, this kind of pattern is seen when we saw that degenerative joint or we saw the displacement without reduction in that kind of this. But this patient had a mouth opening of 46 mm. So if you have a displacement without reduction, the disc is locked, you technically have a, if it is unilateral, you will have a deflection, or if it is, bilateral, you will have a reduced mouth opening. So these are the clinical parameters that we normally look at. So this fellow had an absolutely normal mouth opening, but we said, let's get the CBCT. In the CBCT, we found the right joint is fine. It's well corticated, slightly curved, but nothing much. But if you see now his left side joint, okay, it's undergoing significant wear and tear, significant osteoarthritic changes. And we thought, oh, why it is happening? So I said, my friend, you need to get one TMJ MRI to find out why your only left joint is undergoing this change and not the right side. When he went for MRI, we found that the left side disc had displaced fully and the disc was locked. It was disc displacement without reduction. So no significant pain, 46 mm of mouth opening, but disc displacement without reduction and degenerative changes or osteoarthritic changes with the left joint. So this was one case which helped me to identify this problem, and JVA kind of played a pivotal role in this. Let me tell you about a second case. Now, this lady came to me with a complaint of TMJ clickings and TMJ problems. And she said she has some jaw pain because of those clicks. Whenever she tries to eat something which is really chewy, there is jaw pain. There's sometimes headaches associated with it. She was undergoing a lot of stressful situation in the house. So they thought it is probably stress related. She was also diagnosed as migraine. So we checked her on JVA first, and we found, okay, you're right about your clicking, is that there are a lot of vibrations here, which we should normally not see. And there is a particular parameter that if there is friction, bone on bone, then typically integrals which are upward of 300 hertz vibrations with frequencies more than 300 hertz, these values are dramatically increased. Like normally we consider around, there's no thumb rule, but we consider around below 3 is somewhat of a relatively normal. But this is 11.8 and 6, so it showed significant amount of friction. So I said, okay, Delna, uh, she already had CT, so no requirement of repeat CBCT, but let's go for MRI and check if your joints are fine. Again, the mouth opening is 46 millimeters, which is absolutely normal for this particular lady. And on the MRI, we found that discs bilaterally were displaced and they were locked without reduction. Even on the left side joint, disc is displaced and locked. Now, what we did is we gave her an appliance, a simple appliance we gave her. And after giving her the appliance, we checked her JVA again with the appliance in. All the friction points now gone. The vibrations, which below 25 is normal, so everything is within normal range. There's no significant clicking now. The integral with vibrations more than 300 hertz, they have significantly gone down. And guess what? The pain, which is radiating to the jaw, going to the head, everything settled down. It's been more than 6 months now that she's wearing the appliance. This scan is of August 2024. So it's been more than 6 months since the first appliance was given to her. And since that time, there is not a single episode of jaw pain and headache and associated problems. She's functioning absolutely normal. So her problem was coming from the joint. So that's why JVA helped us to identify it. And when we gave her an appliance, it also helped us to, tell us, I mean, whether we are on the right track or not. So it's a method of evaluation. You can evaluate, it's not 100% method, but it can at least give you some information. Now, as a clinician, you can decide whether that information is relevant to you or not. Now, the case number 3, this particular lady had pain in the TMJs, there was clicking, pain was radiating to the face and some post-auricular region, neck, etc. Pain intensity was about moderate, sometimes severe. Pain was chronic and dull aching. Now, we checked her JVA and we found this kind of vibration in there. The integral below 25 we consider as normal. This was 46, 47, not too bad. But still, she already had a TM joint MRI done. And on the MRI, they had mentioned that the disc is impinged here on the lateral pole. Now, after we gave her an appliance, the impingement was gone. And once the impingement was gone, the pain also went down dramatically. And the next scan, we started at this point, right? We started with these kind of vibration. We started with total integrals of 46 and 47. And after wearing that appliance, the total integral values have come down. The vibrations have come down. I have a testimonial of all these patients, but due to the limited time, I'm not playing those videos. So everything is now much better than what it was. So significant reduction in clicking, significant reduction in pain. So this is what JVA can do to you. And the last and final case now, and this lady, young lady, she had a diastema, so she wanted to get the orthodontic treatment done. So she went to an orthodontist and she opted for Invisalign treatment. Now, before even the Invisalign treatment got started, orthodontist noticed that she already has clicking sounds. And before the aligners were delivered to her, she developed a lockjaw episode, which immediately got relieved within 15 minutes. But now the orthodontist was a little skeptical, so he said, let's get your joints evaluated. So he referred her to me. Now, when we checked her JVA, we found a lot of vibrations with both her joints. And as I'm seeing the total integral more than 300 hertz value, below 3 is normal. This is significantly higher. So we asked her to get a CBCT. So this was her CBCT. Airway was narrow, turbinate hypertrophy, mouth breathing, a lot of things. The TMJs were curved. This patient was claustrophobic, so she couldn't undergo MRI. This was the entire dentition. This was when she was planning to undergo orthodontic treatment. We gave her an appliance, okay, like this. And then after the appliance, the orthodontic treatment was completed on this particular raised bite. And now we started at this point, lot of clicking vibrations, and the integrals were high, the vibrations more than 300 hertz were high. And after completion of orthodontic treatment, okay, after about 1.5 years, look at the clicking joints, very significant reduction in clicking. Total integral values have come down. The vibrations, which are more than 300 hertz, they also have come down. So significant reduction. And ever since the orthodontic treatment is completed in May of 2023, so today we are in December of 2024, it's 1.5 years, not a single episode of locking or significant pain associated with TMJs or pain radiating to head or face, or absolutely no problem. So joint vibration analysis is an important tool in my practice, which can help me to evaluate a case rather than arrive at a diagnosis. It doesn't, it actually points me to say, okay, this patient may require TMJ MRI, and maybe that patient will benefit. So it can also avoid unnecessary, MRIs and CBCTs as well. So it is a very ingenious tool. Not only it can help in identification of the such problems, but when you do any treatment, any restorative treatment for a patient, then it can tell you whether that restorative treatment, whether the TMJs are relatively happy in that position or not. So it's a very simple and ingenious way of evaluating the TM joint vibrations. So that's what I wanted to say for today. And I thank Dr. Sonal, Dr. Nurul for inviting me here to speak to you about this at this Orofacial Pain Congress. And best wishes to all of you. If there's any questions, I would like to take them now. Thank you
Yes,
so much.
you can stop sharing your screen, and we have a couple of questions for you, as usual.
Great.
Okay. So there's a question: is what is the appliance that you have given? Was it a mandibulary or maxillary appliance?
It was a mandibular appliance, and it is an anatomic appliance which is placed on the mandible. And it basically, you can make this appliance in a way that there are various ways in which you can do it. There are some ways in which you can use centric relation and make an appliance. There are neuromuscular, bite registrations. There is phonetic bite. There are n number of ways in which you can make an appliance. And essentially, the point is that the joint vibrations, if they are kept low, and if the pain is originating from the joint, that's also very important. If the pain is originating somewhere else, there's no point in doing all that. But pain is originating from the joint, then definitely your patient is going to feel much better.
And what is the cost of this JVA device? And is there any other way to get JVA test done, like we refer patient to a CBCT or an MRI center?
That's actually a good idea, but as on today, I think I happen to be the only doctor in Mumbai to have it. I got it about 7 years back. I think the cost was around 8.5 lakh rupees that time. So I don't know today what is the cost. But in my practice, for all these patients that I've shown, we have not charged a single rupee to the patient for JVA. Our consultation fees include JVA. We don't charge patients for separately for that.
And next question is by Dr. Goel: how much IMF and arthrosynthesis treatment help in these conditions?
So yes, they can. I don't know about IMF, but arthrocentesis is definitely known to help, TM joint problems. There are thousands and thousands of articles that you can find, and I personally have seen the joint vibration analysis before arthrocentesis. Suppose if the friction is very high and after arthrocentesis, one of my friend who's lecturing here, Dr. Bohra, so he does arthroscopy and whenever he has done those level 1 and level 2 scopies, and when we have retested the patient with JVA, we have found the joints are very quiet. So yes, it helps.
Okay, and next question is by Dr. Kiran. What is the splint role in the treatment? How is it going to help the patient? The mechanism he wants to.
Well, that's actually a uh, very big. There could be a very big answer. I don't know. We have a time for that,
And we
but
have
I'll
to.
just I'll in a nutshell, your joint in most of these cases was placed posteriorly and the disc was slipped anteriorly. So what we have essentially done is we have created a decompression in the joint at a comfortable position, so that if you give an appliance to a patient, let's say for 6 months, on and off, so it doesn't have to be full time. And eventually, after 6 to 12 months, when you wean off the appliance, if the bone has adapted and the joint is fine, that's fantastic. If it is not adapted, what you can do is you can do an orthodontic treatment at that particular point and keep the joint in a stable state. But it's not that simple and it's not that organic that I can just say, oh, it's an appliance followed by an orthodontic treatment. It doesn't work like that. There's a lot of careful factors that are considered before we decide treatment.
Yeah, since the whole event is a multifactorial, the treatment plan would.
Exactly. So it's the whole TMJ disorder is not only limited to the joints. It's much more than, I mean, I think the entire Orofacial Pain Congress, you will hear so many people talk about different etiologies of pain and all that. So I don't think fixing this one joint is going to be enough. Few patients, when they come to us, they come to us as a whole and not as a clicking joint. So we need to treat patients, not only the joints. So there's no cookbook recipe. It's like each patient wise it may differ.
Okay. Dr. Kabil has a question for you. If a patient has disc displacement without reduction, is it possible to get the disc into position?
Unfortunately, I have never found it. I have never been able to do it myself. I'll be very honest. Some people believe that after an appliance or after an arthrocentesis, the mouth opening is increased and the joints are quiet and friction is gone. That means this must be recaptured. But I have never found it because we have patients MRI done before, and after the entire treatment and appliance, and after 1 year, 2 year MRI is repeated, this is still not recaptured. I don't think it can be.
Okay. I'm not sure what Dr. Lavina wants to know. She wants to know please throw some light on the cost factor. Yeah.
I understand this, but I'm not a distributor. I'm a doctor. So I can forward the numbers of distributor and all the costs and everything. You can talk it out with them. I actually don't know the exact cost. As I told you, I procured that 7 years back. So ever since I've never bought a single JV again. So I don't know what's the exact cost today. I can send you the contact details, of course.
And Dr. Monica wants to know, is it more like a deprogramming appliance?
No, not really. They call it a reprogramming appliance. Okay, it's just a difference in this philosophy. So, the idea is that on the appliance, what it does is that it allows a certain amount of muscle activations, and it doesn't allow the certain amount of muscle. For example, I mean, when you clench on it, it will cause muscle activation during the daytime, of course. And when you're moving your jaw, let's say you're chewing with the appliance on, it will all the excursive friction is eliminated. So the muscles are active when you clench, and when you do excursion, muscles are relaxed. That's what principles of occlusion tell us, that too much of excursive friction is not great for muscles. So that's what it is done. But our topic is JVA, not the appliances.
Yes, doctor. And this is a personal question, not from some audience. So if a person has to become a TMD specialist, what are the steps for it? Like, if you decide on pursuing this path or this wonderful world of orofacial pain, so can you highlight the students or can you guide them? I know it is not your topic related, but as a mentor, can you just highlight at least, because we have many students here in our forum today. So if they have to start, what would be the step one for them?
First of all, get the education. and get oriented with all schools of thought as much as possible. The more speakers that you listen to, more perspectives you are going to get. And always, as a student, I am a student of TMD myself. So whenever a speaker tells me something, oh, this is going to be, oh, you need to do this, and this is how it works, you have to critically analyze everything. So never believe anything on face value. Always do it yourself and check. So if there is somebody comes along the way and says, okay, this is the treatment methodology, that's what I treat, that's how I treat, and you're going to get results. It's better that you go learn the entire treatment methodology first, and then accordingly you decide your treatment. You get the orientation of all schools of thought and practice what appeals to your mind.
Wonderful, doctor. It was really insightful listening to something like, joint vibration, because we have been taught to actually feel the joint, and a device helping us to arrive at a conclusion. It is always welcoming. Thank you so much, Dr. Varun. And I hope there are any other further questions. We still have 1 more minute with Dr. Varun. Otherwise, we'll call in the next speaker. Yeah, I think that's all for the day, Dr. Varun, and see you soon.
Thank you so
Hello.
much, doctor. See
Hello,
you
madam.
soon.
Yeah.
Dr. Syed Manazir Hussain here. I have a question, sir.
Yes,
Yeah,
please.
go ahead, please.
Is it a diagnostic modality according to you? Then why there is a need of MRI and CBCT in
It's
TMD
not a
cases?
it's not a diagnostic modality. I'm talking about JVA. JVA is not a
Hmm.
diagnostic modality. It is a diagnostic aid. If you see the FDA clearances also, it's listed as a diagnostic aid, not a modality. So definitely not.
Okay. Okay. Thank you.
Yeah.
Yeah. Okay. So with this, we call in our next speaker, Dr. Avinash Shah. Dr. Avinash, are you there?
Yes, Dr. Sonal.
Yeah. Good morning, doctor.
Good morning.
So another specialist, a TMD specialist, mentor, and a guide for many, many years. I think the first name that everybody thinks about when they talk about splints is Dr. Avinash Shah. And his wife proudly says that when she was about to get married to him, she was told that she's going to marry a night guard. So that says it all about Dr. Avinash Shah. I need not tell anything else because his wife has summarized him very well. But with that, I would like to welcome you, Dr. Avinash Shah. He is a specialist and he has interest in treatment of occlusal problems and TMD through programmed treatment planning. And he's been a mentor for that since many, many years. And I think 200 plus sessions also he's already hosted them. And he has been invited as a guest speaker at various states and national dental conferences. He has a total clinical experience of 23 years in diagnosis and management of TMDs and an academic experience of 20 years. He has been awarded 4 national level FAMDENT awards for his clinical and research work. He has completed his mastership from prestigious GDC, Mumbai. So, Dr. Avinash Shah, welcome to International Orofacial Pain Congress 2024. And today you are going to be talking about TMD demystified, evidence-based non-surgical interventions. So, Dr. Avinash, welcome, and the stage is all yours. I can see a very cute little face there. Go ahead, doctor.
Thank you, Dr. Sonal, for such a nice introduction. And before me, there was a wonderful lecture by Dr. Varun, and with all the evidences he's shown. So the next, someone asked you about the splint and that. So in this presentation, we'll try to clarify the answer the previous participant asked. So good morning, everyone. I welcome all the delegates.
Yes, doctor, go ahead. All
Yes.
good.
So I welcome all the delegates for this International Orofacial Pain Congress. Okay. So here most of the participants are the dentists. Okay. So most of the participants are dentists, and we are not only the doctors for the teeth and the gums, but we are also the physicians of the masticatory systems. So that's why it is very important to understand. That's why it is very important to understand the TMJ and occlusion. So it required for your day-to-day clinical practice. Whatever the patients are coming to us with the problems like difficulty in achieving, opening the jaw, pain, the orofacial region. So most of the things that are related to the TMJ and the teeth. So it is very important to understand the role of TMJ, occlusion, into our clinical practice. So we are the dentist of the masticatory system, means the masticatory system consists of the teeth, jaws, joint, muscles, and the ligament. So we are the physicians of a full system. So we should know the in detail about the system, and there should be a structural balance in all this these components of the system. If the balance goes, then the problems happens. So if you see a TMJ, teeth, muscles, and the joint, okay. Am I audible? Okay. Am I audible? Okay.
Yes, doctor. Yes, doctor. Go ahead.
So teeth, muscles, and the TMJ. Now the base of this triangle is the joint. So base should be always stronger to take the load of suprastructures. Okay. So the teeth and the muscle should be stable, and if the joint is stable, it can take the load of teeth and the muscles. So the TMJ is attached to the masticatory system. And if there is any structural imbalance in this masticatory system, then it may affect the full body. So Dr. Varun told it's not only you are treating the joint. So if you are treating this masticatory system, means you are treating the full body from head to toe. Okay, is that so? The teeth or TMJ may affect the full body from head to toe. So if you see the classification of the orofacial pain, so TMD is one of the orofacial pain, and in my practice, I have seen 50 to 60% of cases of TMDs. And whenever the patients of the orofacial pain comes to in your practice, as a dentist, first we should diagnose for the, or we should check for the differential diagnosis or check for any reason for primary dental pain, then refer dental pain, and then you go to the orofacial pain. Okay, so this way you should scrutinize your patient. So again, the TMD is one of the orofacial pain of the musculoskeletal origin. Coming to the diagnosis of the TMD. So there is a DC TMD criteria is there. It is formed in 2014. Okay, according to it, depending on the which component of the masticatory apparatus is involved, if the muscles are involved, it is a myofascial pain. So it is a myofascial, FASCIL. It is not a CIL. So it is a muscle and the fascia pain. Then the disc displacement, it may be with reduction, without reduction. Without reduction, maybe with limited mouth opening, or without limited mouth opening. And if the articular bone involved, it is the osteoarthritis of the TMJ. So I'm not going to go into the detail of this. Many speakers may have covered it. So we'll go directly to the cases. So again, this RDC TMD criteria is the one more classification by the Schiffman et al. And he also include the movement disorders like orofacial dyskinesia, oromandibular dystonia, and even the fibromyalgia also. He has included in his classification. There is continuously some admission is coming. Okay.
Doctor, you ignore that. I'll handle it.
Okay, sir. So there are various modalities to treat the TMD. First is conservative, second is surgical or invasive method. Conservative, we have stabilization, splint, counseling of the patient, hypnosis, medication, physiotherapy, lasers, neuromuscular dentistry, and DTI, disocclusion time reduction. And in surgical modalities, orthocentesis, disc reposition, removal surgery, joint replacement surgery, Botox, trigger point injection, and the steroid injections are there. So I mostly focus in my practice on the stabilization splints. So types of the splint is from Dawson, permissive and the directive. Permissive are the anterior deprogramming splint, NTI suppression system, full coverage splint, and the anterior repositioning splint. If you see see here the full coverage splint, so only full coverage splint can be given for long term. You cannot give anterior repositioning splint, NTI, and anterior repositioning and anterior deprogramming splint for a long term. They have a lot of side effect if you give for the long term. So there is a limited use. So long term, you can only give full coverage occlusal splint with the periods of, you can say, interval of reprogramming. So I have done my post-graduation from prestigious GDC Government Dental College Hospital, Mumbai in 2001, and my journey of TMD started in 2001. My guide, Dr. Hemant Umarji, sir, given me a topic on TMD, that was rheumatoid arthritis and osteoarthritis CT scan. That was CBCT was not available, and my journey of the TMD started. And afterwards, I joined as an associate professor this Vasandada Pati Dental College, and many studies were completed under MUHS on the TMDs and the occlusion. So this is our TMG center at South Mumbai. There are many research I have done under me and along with my students. So this was the first study I have done in my MDS as a dissertation topic, CT scan evaluation of TMJ in localized osteoarthritis and rheumatoid arthritis. And this study is published in the journal. The second study was treatment of myofascial pain patients using full coverage occlusal splint therapy. And in this study, we found that it nearly take 3 months to come down the score, VAS score of the muscle pain from 10 to 1 or 0. And we have done a study on etiological factors on TMD. And in that, we found that occlusal interference is the most common etiological factor along with the other factors. So occlusion plays a definite role in the TMD. Then study in 2019, we completed on evaluation of dentition status and the temporomandibular joint disorders in neck and back pain. Study aimed to find out if any correlation between neck and back pain with dentition status and TMD. And we found that significant correlation between all these things. And this study is also published in the journal. And we have given a splints to many patients, and there's a significant relief in head, neck, back pain of the patient also. So next study was MRI evaluation of disc displacement pre and post occlusal splint therapy. But due to the COVID, we are not able to finish the post MRI. Very few patients we have done. And in this study, what we can see, I'll show the one MRI. This is the pre-MRI of the patient, where the disc and the head of condyle distance is 4.60 mm before the splint therapy. And after the splint therapy, you can see the distance of the head of condyle to the disc is reduced. So by maybe 0.7 millimeters. So it was changing. So definitely splint will help to reduce the disc to the original position, not 100%, but nearly close to that. So case reports, I'll share the few cases also in that. So the case reports, cases treated with the occlusal splint therapy, stabilization splint with long-term follow-up. So I have a long-term follow-up of the cases. So this is a case report, TMD to SMILE design with a program treatment planning. So Mr. David Sampson from United States of America came to our practice 4 years back, that is way back in 2013, with the chief complaint of frequent fracture of the cervical fillings. On examination and case history taking, it was revealed that he had headache, neck and back pain and tingling sensation in the upper limb, and he has a diagnosed case of cervical and lumbar spondylitis by his orthopedician. So on the basis of sign and symptom and muscle tenderness score, we have a pro forma. On that basis, we diagnosed him with the myofascial pain and suggested him the occlusal splint therapy. So this was his occlusion when he visited, and he had a complaint of frequent cervical feeling fracture, and at an interval of every 6 months, he need to do it. So I had given a solution. I'll do the feelings, but it won't come out. So I've done the feelings and given the full coverage splint. If you see his occlusion here in the, you can see, and you see here, the canine crossbite is there. Okay. So there's a canine crossbite, and due to that, canine guidances were absent, and that was the cause of the heavy forces during excursive movement on the posterior tooth and the anterior teeth. Okay. Then this was his occlusion. In anterior guidance, there was interference here. Okay. This is the right lateral and the left lateral. You can see here the interferences. In the protrusion also, there's the interference is there on the both the side. So this was the maxillary stabilization splint was given to the patient in 2013. This was the splint with the ram, anterior ram. And this is the hard splint. So patient back to India from USA, in between also he had come once. And then when he came in 2018, he got a lot of relief from all his symptoms. And he was convinced that all his problems were due to the improper occlusion. And we suggested him the final occlusal corrections, and he was willing to do the same. So now we want to change the occlusion, correct his canine guidance. So DSD planning was done by Dr. Sayogita and sent for diagnostic waxer. We got the waxer from the lab, and waxer was very nice in all the things. Canine crossbite was not there. And in waxer, we do on a semi-adjustable articulator, so we can see the anterior and the canine guidance. So there were no interference in the occlusion, and you can see the nice occlusal anatomy. This one tooth was missing. And then with the waxer, we take a putty index and we do the test dry in the mouth. So test dry, just we can use the protein and place in a putty index and place in the patient mouth without any preparation, just to show the patient, and you will get an idea how the patient will look after it and what could be the occlusion of the patient. Okay. You can see here the patient smile after test drive. Okay. You can see here the crossbite is not there. Okay. So you can see in the anterior teeth, we have done the test drive. Then final restorations were started, then phase bow, then preparation. You can do the preparation through the test drive also to do the minimal preparation and to avoid the excessive tooth cutting. So the BIS trial and anteriors, we have given mostly the veneers except one tooth low and the lowest crown, because there was a lot of interdental space. And this was what the final smile and final you can say occlusion of the patient. You can see good occlusion with the good canine position. Here this is a maxillary arch, and this is the mandibular arch. Okay, this is a good occlusion, right and left side, with good anterior guidance. Posterior clearance is there, so good anterior guidance. Canine guidance. You can see the canine guidance when canine is in contact. The rest of the teeth on the same side and the opposite sides are not into contact. That is a canine guidance, presence of canine guidance. This is a smile of the patient. And this is before test dry and the final restorations. Okay. So we have done Emax, restore the full case with the Emax, and we are not done the root canals. It was previously done here. You can see some. So minimally invasive. And then again, the full coverage splint with the minimal thickness is given to the patient as a preventive, or you can say maintenance. Okay. Then patient again came after 6 years, and this is a 6-year follow-up of the patient. So this is before, this is final restoration, this is 6 year. So everything is in place. And this is the facial photograph of the patient. So we nearly following this case since 2013, and now it is 2024. So nearly 10 to 11 years we following the case from the initial fracture of the cervical filling till the head, neck, back pain, and his orthopedician had was told he got good. There's a structural change in this lumbar area also. So his lumbar spondylitis is also improved, and his migraine, tingling numbness of the hand, many things are improved, and they are stable throughout the all these 10 years after the splint therapy. So there's a great role of the splint and the occlusion in the patient posture and the TMJ, you can say. So these are the, we have made a study, and these are the list of patients who got maximum relief from their symptoms. So if you see here, the symptoms like MPDS, displacement with reduction, without reduction, then with limited mouth opening, then head and neck, osteoarthritis, head, neck, back pain, chest pain, upper and lower limb pain, tinnitus, vertigo, and burning mouth syndrome. So if you see the first case, this Ikra, you can see her mouth opening increased from 17 to 36 mm. So she was a case of displacement without reduction. And you can see here, there was, before we start the case, this mouth, you can say there are two clicks, mid opening and late closing on the both the side, and it after the therapy there was no click. Okay, then again this patient, you can see Suchit, he was having lot of problem like head, neck, back pain, and the TMD with he was having osteoarthritis also, and the displacement without reduction with limited mouth opening. So his mouth opening was 24 and increased to 42 mm, and he was having the history of clicking. Okay, so no actual click. He was history of click, but after treatment he started getting click. So it means the disc is getting reduced to the you can say close to the original position. So if you get a click, there was absence of the click, and if you get a click after treatment, that means there's an improvement. Okay, so disc is getting stabilized to the original position, and we are shifted from disc displacement without reduction to disc displacement with reduction. So this way we have done a study of many patients, and out of that, this you can see 64 patients are out of symptoms, symptom free with the occlusal splint therapy only. So this is the next case where the diagnosis was myofascial pain dysfunction syndrome, disc displacement with reduction. This displacement without reduction, neck pain, back pain, chest pain, upper and lower limb pain, and his mouth opening before the treatment was 24 mm and post treatment was 42 mm. So I'll show the case. The clicking he started after treatment. There was a history, and he started the clicking after the treatment, and mouth opening increased. So disc is nearly recaptured here. So this was the previous MRI of the patient in 2019, where you can see the study revealed the degenerative changes in the bilateral temporomandibular joint and the reducible anterior subluxation of the bilateral articular fibrocartilage disc. Underlying developmental small size bilateral mandibular condyle is same. So it is a disc displacement with reduction. Now, when the patient done again MRI in 2020, here the stage 2 internal derangement of the bilateral temporomandibular joint with the anterior dislocation of the articular disc and possible in incomplete reduction on the mouth opening. So it changed to the disc displacement without reduction. Now this was the CBCT report in 2020, and he was having one side condyle is that was not fully developed, and he also shows the flattening of the head of condyle. Can you see here some? This is also flattening of the condyle. And this right side condyle was not fully developed. And joint space you can see is also reduced on the left hand side. Okay. Now, when he reported to me, he was also under treatment. He also undergone ortho treatment, and someone has given this type of splint to him, the posterior bite plate. But what I feel, we should not give us, I already told, should not give a partial splint for a long period of time. So what happened if the partial splint is given for a long period of time, there will be the supraeruption of the uncovered part and the intrusion of the covered part. So when I saw his bite, the posterior, the occlusion, posterior occlusal contacts were not there. Okay. So this was a splint. And then we have given the full coverage splint to him. This is a full coverage splint, a stabilization splint with the proper vertical dimension and anterior and the canine guidances. Okay, you can see here, anterior and the canine guidances. This is a mandibular stabilization splint. Okay, now his bite is getting settled after the splint. You can see here the gap is there. Gap is getting closed, which previously was there. Okay. And his also mandible gone to the posterior position slightly. There was a gap again here. And then once all his symptoms were patient becomes symptom free, then we started to go for a definitive treatment. So we have given an anatomic sprints 24/7 for the 6 months. Okay, so it is a stabilization phase. Okay, and after that, what type of the you can say what you want to achieve the occlusion, like vertical dimensions in the occlusion after the post ortho. So same way we are given an anatomic splint at the same height, and we proceed with the neuromuscular orthodontics with the same splint. So this was the previous photographs. And we also post splints, we also evaluated, this is 2023. We also evaluate the airway of the patient. Airway of the patient without the splint is good. Okay, you can see here the good airway. So I advise all the doctors who are doing TMD treatment also should evaluate airway of the patient also before we start the treatment, before the ortho treatment, before even the FMR also. Now this is 2023. You can see here the nice head of condyle. So osteoarthritic changes are not increased here, both the side. Little, it is at the same level. It is not aggravated. Okay. This is a 2023 May. And now everything is okay. Now we started with the ortho treatment with the anatomic splint in the patient's mouth. Okay, so given the anatomic splint and the braces, we started, and this is again the OPG to 2022 and 23 evaluation. And this is the we started with the neuromuscular orthodontics. So the splint is cut from the back side, and then we started getting the posterior teeth into the occlusion. Here you can see. So this is the neuromuscular orthodontics. The splint is cut from the back. So we'll get the posterior teeth into occlusion and then the anterior teeth. So we can achieve the same vertical dimension which we have achieved in the this anatomic splints. So this is the Shimbashi for the anatomic splint. So Shimbashi should be 19 to 20. So I told you before the movement disorder. So this patient was having the movement disorder, dystonia, and I'll just want to share the video. Audio is there. Just see. He was not able to speak.
साधारणपणे 2010-11 मला दोन्ही राईट आणि लेफ्ट साईडला आळशी झालेला आहे आणि त्यानंतर तिथे कॅप घातल्यामुळे थोडा मला उमजटा फील होत होता त्यामुळे मी फक्त लेफ्ट साईडने खूप खायचो आणि
Basically, I want to show that he was not able to speak, and
गेले
went to AIMS
3-4
Delhi
महिने
also. There he has
मला
given
थोडा
Botox injection
इकडून
and he was not
वाईट
got
व्हायला
relief.
लागलं. त्यामुळे मी
So one of my
डॉक्टरला
friend
दाखवलं
he's
आणि
referred
त्यांना
to
सांगितलं
me,
की असं
and
असं व्हायला
he was
त्याने
having the
थोडंसं
displacement also,
ट्रीटमेंट करून हे
malocclusion,
कमी करायला प्रयत्न केला
and we
पण
treated him with a splint.
त्याच्यानंतर
And after 2.5
मला
years,
बोलण्याला
was able to
त्रास व्हायला गेला.
sing. You can see it. So basically, there was a problem which is the masticatory apparatus. Only with the splint. So this was the previous photographs of the patient when after we splint therapy is over, before any definitive changes in the teeth were done. Then after these changes we get when the patient got symptom free, then we started the definitive treatment. We started his full mouth rehab because he was having the attrition of the teeth and the class 2 malocclusion. Okay, and deep bite also. So this is again the test drive in the patient mouth. Okay, all the factors of the occlusion were taken into considerations. Okay, anterior guidance, canine guidance. Once the test drive is okay, this was the previous splint. This is splint again with the test drive, and you can see the lot of again you can see the space here. So again the mandible is deprogrammed. And then after a period of everything, we got stable. Then we started with the definitive treatment with the full mouth rehab. Now patient is undergoing still the final treatment is not completed. Okay, you can see the patient face. So from here to here. So nearly it is now 4 to 5 years. Due to COVID, the treatment was halted because he was at other place. Okay. Okay, one more case of the dystonia. So you can see her the lip is getting moved to right side when she tried to close the lips. And again, this was having a problem. This patient having problem with the occlusion, and we have given a stabilization splint. And after 9 months of the follow-up, so she is all right. Dr. Sonal, how much time I have remaining? Okay. So this patient was misdiagnosed as a trigeminal neuralgia.
पूरा पेन करता था, ये यहाँ तक पूरा इधर एकदम डेंजरस से करंट्स आता था. तो फिर मेरे को न्यूरो सर्जन को दिखाया पुणे में. फिर उन्होंने मेरे को गाबा पेन करके एक टैबलेट दिया. फिर उससे भी मेरे को पेन ठीक नहीं हुआ तो उन्होंने सर्जरी के लिए बोला, ब्रेन सर्जरी. डॉक्टर अविनाश को दिखाया. उन्होंने एक ही छोटा प्लेट दिया मेरे को लगाने के लिए. उससे मेरे को रिलीफ है थोड़ा. ये प्लेट दिया लगाने के लिए.
So we have given, actually she was taking treatment since last 8 years. She was taking phenytoin sodium, gabapentin, but there was no relief in her pain. And the MRI brain were not showing the significant compression of the trigeminal nerve. And then she suggested a brain surgery. So one of the dentists called me for the consultation. And then I diagnosed her with the myofascial pain. We have given an anti-deprogrammer first for 3 weeks, and her pain gone without the without the medication. And then we started with the splint therapy. Now it is a 4 to 5 years follow-up, and still she is okay with her pain. No severe pain increase. The severe pain. Okay. So last slide. Okay. So what are the benefits of the occlusal splint therapy? So no medication or injections are used, so no side effects, very conservative and more natural physiologic way, prevents teeth wearing, protects teeth TMJ muscles from harmful night grinding forces, relaxes contracted muscles of orofacial region along with the affected body muscles, useful for differential diagnosis of the myofascial pain for the other orofacial pain. So this is a very important factor. So suppose you are confused what the patient is having. Suppose you have given an anterior deprogrammer to the patient and there's a reduction in the patient pain, not 100%, maybe you can say 10 to 15%. That will guide you. This pain may be related to the, you can say, myofascial pain or the TMD. Then physiologic way of healing affected TMJ, reduce headaches, neck, back pain of muscular origin, balance your body from head to toe if affected due to the teeth and the imbalance, TMJ imbalance, and if restricted mouth opening improved, can avoid invasive TMJ surgery. So having the prognostic value also. So this last case I want to show you. So this patient reported to me, this is a hard, she's a 16, she's a 13-year-old female with the limited mouth opening was 19 mm and her MRI and the CBCT shows orthotic changes. MRI shows disc displacement without reduction. And I have given her a splint and within a period of, you can say, started this is 6 months and this is the 8th month. So 2 months, she got the mouth opening from 19 to 38 mm. Okay. So there's a drastic change. So this was a CBCT report showing some arthritic changes, flattening. And so I have seen the patients below the 20 years of age, whatever the problems they have. So with the splint therapy, they get a faster results because they are in a, you can say, growth spurts are there. So we can take the advantage of that in the healing of the TMJ. This was a CBCT report. Okay. So thank you for the patient hearing. So any questions are there?
Yes, doctor, you will definitely have questions because everybody is all wanting to know about this plant therapies and all. So first question is from Dr. Sandeep. Dr. Sandeep, you have been an active participant, I must say, and I congratulate you for listening to all the speakers so patiently. So what is the purpose of splint post FMR?
So basically, what post FMR, why do we give? Because basically 2 factors are there in the when you do the patient do the bruxism and the clenching. So first is the occlusal interferences. So occlusal interference we have removed, but the stress is there, some emotional stress, physical or mental stress is there. So mental and that stress we cannot eliminate. So patient has a habit. So patient does the grinding. Okay. So if you given a splint after FMR also, the patient cannot grind that. It will be very patient will grind without a splint, but that will be minimal. But if you are given a splint after FMR also, you can say the effects of the grindings are minimized or no effects are there. Just to avoid the wearing of the teeth. That's it. No other purpose.
Dr. Sandeep's second question is, can you elaborate on steps for making the splint? I think he's asking for your lecture. The whole 2-day conference he wants to attend. Dr. Sandeep, yeah. So can you just tell him the steps or you want him to send your address to him so that he can join your course next time?
So he can contact me, but steps, see, it is again Dr. Varun told, it is the different things are there and every patient's splint is customized to according to his problems and according to his occlusion. Okay. So full coverage splint, it should cover all the teeth, upper or lower. It should have this specific thickness according to the patient bite. Okay. It is not only 2 mm. It's according to the bite of the patient, the height of the splint is decided. And then it should have a good anterior and the canine guidance. And always the hard splint should be given, not the soft splint. Because if you give a soft splint, we cannot balance out the forces. So hard splint should be given. Vacuum form suck down tray on a model should not be given as a splint. We say it as a night guard. No, the full coverage splint with the proper anterior canine guidance will always be helpful rather than giving a partial or the only the vacuform tray night guard splint.
Okay. And again, one more question is from Dr. Naman. He wants to know what adjustment in full coverage splint do you do during follow-up visit?
Okay, so suppose I give an example. We have a stabilizer given the splint to the patient day one, and that time occlusion on the splint is good. Now, when the muscles relax or deprogram, so suppose the it goes from point A to point B, the jaw. Okay, so same way you need to do the adjustment in the splint. So suppose I'll again give a one example. Suppose the patient is biting on right and left side. Only the right side the occlusal contacts are coming, left side they are not coming. So you need to reduce the point on the right side, heavy we say high point, so that the left side the side also get contact. Sometime you need to add, sometime you need to reduce from the splint to make it stable every time the patient is visiting to you, so that the next changes will happen in the jaw or the TMJ or the muscle.
Okay. Doctor, next question is, were all the splints done in centric relation or MIP?
No. So basically, all the splints we give, we should not give the splint in a centric relation. Why? Because the patient already having the TMD. So if the it is also given in Dawson also in TMD patient, we get an adapted centric. Okay. So if you try to get the patient into centric relation, the patient may get pain. Okay. Because in that to get into centric, you need to press the jaw downward and upward. So at that time, the muscle, joint, and the they are not in a stable position. They are in a, you can say, in a sick position. Okay, they are sick. Muscles and the joint is sick. So better to do the splint in the MIP only, in the TMD.
Okay. Next we have is, would you suggest laser and splint both for all TMD patients?
Yes. So what I say, there are the modalities available. I told you like physiotherapy, TENS, lasers, SWD. So we have done many studies on it also. We have done a study on SWD. We have done study on STEN. It's a 3 years dissertation. We have done the GDC. And what we found that all these are the things are the you can say just symptomatic relief patient get. Whatever you do, laser, we do SWD, we do TENS, symptomatic relief, because only they increase the blood supply in that particular area to heal the that trigger point. Okay. So, but etiology of the, if the TMD or you can say myofascial pain or muscle pain is the occlusion, once you stabilize the occlusion, then there may not be need of all these things, or you can, if you do it together, so the patient will get 10 to 15% more benefit. But alone, all this therapy won't help to give a cure or you can say permanent relief to the patient. There's already done the study on it.
Yeah, and what would be the routine for follow-up?
Routine for the follow-up for the splint. So first day we give a splint, then we call the patient on the third day, then the seventh day of the first month after seventh after a week. So in first month there is a 4 follow-ups, and then afterwards first once in a month for 4 months, and after 4 months we can call the patient after 1.5 to 2 months after. And again depend on the patient discomfort. Some patient may require a frequent reprogramming, some may not. So always give a choice to the patient. Just if there any discomfort, just call and take the appointment.
And one more very inquisitive question is, what should be the thickness of the splint given? And is it a nightwear or a daywear appliance?
So depend. So again, I told you it is the customized according to the patient, and the bite of the patient is important. So in the height of the patient, we should consider the Shimbashi. Shimbashi is the zenith of the upper central incisor to zenith of the lower central incisor. That height should be minimal 19 to 20 millimeters. Okay, if you need to maintain that height and the golden proportion of your face. So from the outer canthus of the eye to the lip, this distance should be equal from the base of the nose to the chin. So you try to maintain this golden proportion when you make the splint. It's not only the 2 mm. It depends on the patient occlusion also. So these two things you need to see while determining the vertical dimension of the splint. And normally splint is 24/7. except I tell the patient not to wear during eating and during having breakfast or tea, coffee, because what happened, the mouth opening is limited. Again, that will difficult the patient to do that. But if mouth opening is good, if I give an anatomic splint, even with the anatomic splint, I ask the patient to have a food.
Yeah.
But if they avoid it during, if it is the chewing is painful that time, if they avoid, they can prevent the staining of the splint. Otherwise, the tea, coffee, and the food, they may stain the splint. But if it's painful, they can wear during eating also.
Okay, and one more question, last question I would ask you is which airway analysis to be done for TMDs?
So basically, when you send for the CBCT, now I normally send after I examine the patient, I first send the patient for the CBCT, that is closed mouth CBCT. And in the inside CBCT, they do. Inside CBCT have many centers in Mumbai. So other CBCT center also do if they have a full volume CBCT. So just write airway analysis. So in airway analysis, they give everything from nose to throat. So if there any obstruction in the nose area, so you can evaluate the patient is having a sleep apnea, patient is a mouth breather. All these things you can evaluate in this thing. So it's very good because I have observed many patients are having the obstructive sleep apnea and the mouth breather if there is a nose is blocked. So we can help the patient that.
Yes, thank you, doctor. That was really insightful, and I'm sure your mailbox is going to be full with all the questions which participants have. Because of the time limit, I'm taking in only few questions, but I'm sure you will be contacted very soon with all the sets of questions. Thanks for the insightful lecture, doctor, and it was pleasure having you here.
Thank you, Dr. Sonal.
Okay,
And thank you, organizing committee, for this invitation.
with that, I'll invite our next speaker, Dr. Maithili. Dr. Maithili, are you there?
Yes.
Hello, Dr. Maithili.
Hello.
Yeah. So Dr. Maithili is currently an associate professor at the Eastman Institute of Oral Health, Rochester, New York. And she has completed her master's in orofacial pain from University of Medicine and Dentistry of New Jersey. She has completed a fellowship in orofacial pain from UMDNJ. And she is board certified and diplomate of American Board of Orofacial Pain. She has completed Masters in Dental Sleep Medicine of American Academy of Dental Sleep Medicine, and she has published several articles and book chapters. Actually, this introduction was given to me by Dr. Maithili, but to tell everybody, this is very humble of her to describe herself so humbly in a way that it humbles me also, because she has achieved so much, and she and Dr. Davis Thomas can be called as the grandparents of orofacial pain. They have been actively making research, doing research works, and in mentoring the students worldwide. And it's a pleasure and honor to have you here, Dr. Maithili, and stage is all yours. You can start your presentation, ma'am. I can see your slides.
Yeah, thank you so much. So it's an honor and privilege to be with all of you here today. And I'd like to thank the organizing committee and the organizing chairperson for giving me this opportunity. So the topic of my presentation today is trigeminal neuralgia and other neuralgias of the orofacial region. So we'll begin with a brief introduction to neuropathic pain and then move on to clinical features. The purview of the lecture is basically diagnosis of different neuropathic pain conditions in the orofacial region. We'll briefly touch upon evidence-based management and conclude the lecture. So when we speak about neuropathic pain, the most widely accepted definition of neuropathic pain is by the IASP, the International Association for Study of Pain, and the current definition. So a lot of definitions have been modified periodically, and the current definition, which was modified in 2020, defines neuropathic pain as a pain caused by a lesion or a disease of the somatosensory nervous system. So this could be the central nervous system or the peripheral nervous system. Now, when we speak about the classification of neuropathic pain, particularly in the orofacial region, the ICOP is the most widely accepted classification. So the international classification of orofacial pain was proposed in 2020. And again, 2020 was a landmark year for us because orofacial pain got accepted as a specialty in the US. The ICOP was also for the first time published in 2020. And a lot of our colleagues and mentors were the primary people who were involved in genesis of this classification. Now, with the international classification of orofacial pain, it also relies on the broad classification using ICHD, the International Classification of Headache Disorders, and the DCTMD for temporomandibular disorders. Now, in the international classification for orofacial pain, they basically dwell on just trigeminal and glossopharyngeal neuralgia and refer to the rarer orofacial neuralgias to the ICHD classification. And hence, I thought it would be appropriate in today's lecture to basically stick to the ICHD classification. So basically, when we're speaking about different neuralgias of the orofacial region, there can be different classification systems. And so based on the location, neuropathic pain could be classified as central or peripheral neuropathic pain. Based on the etiology, different neuropathic pain disorders could be classified as classical, idiopathic, or secondary. And based on the presentation or the clinical features, they could be classified as neuralgias or neuropathies. And we'll be dwelling into a little of these in detail. So when we speak about peripheral neuropathic pain, again, the definition by the IASP is that it's a disease, it's a pain caused by a lesion or a disease of the peripheral somatosensory nervous system. And this can be again subclassified into episodic or continuous neuropathic pain. And when we speak about episodic, it's generally referred to as neuralgias. And when we speak about continuous neuropathic pain conditions, it's referred to as neuropathies. So the most common episodic neuropathic pain conditions that we see in the orofacial region include trigeminal neuralgia, glossopharyngeal neuralgia, occipital neuralgia. And continuous neuropathic pain condition or neuropathies commonly include post-traumatic trigeminal neuropathy or idiopathic dentoalveolar pain, idiopathic persistent idiopathic facial pain. So these are common continuous neuropathic pain conditions that we see in the orofacial region. Now coming to central neuropathic pain, it's basically defined as pain caused again by either a lesion or a disease of the central somatosensory nervous system. And again, it could be classified as episodic central neuropathic pain or continuous neuropathic pain. And the most common conditions are multiple sclerosis, post-stroke pain, brain injury. So these are common conditions that present with central neuropathic pain. So initially what I'll be doing is I'll be giving a broad outline of the different neuralgias. When I say neuralgias, it's basically episodic neuropathic pain in the orofacial region. And then we'll be dwelling into specific instances of neuralgias affecting particular nerves. So the broad classification is into classical, idiopathic, and secondary. So when I say idiopathic, basically, as the term implies, it means that we basically do not know the cause of the condition. So when your clinical findings and your imaging findings or electrophysiological tests do not find any significant abnormalities, it's commonly referred to as idiopathic neuralgias. On the other hand, when you have specific MRI findings of nerve compression, and this nerve compression is resulting in anatomical changes or morphological changes in the nerve root, that's when we refer to it as classical neuralgias. So in classical neuralgias, it's just not neurovascular contact, but you need to see actual morphological changes. So if it is plain neurovascular contact with no morphological changes, you would classify it as idiopathic. But when you see morphological changes and anatomical changes during the surgery, you would classify it as classical trigeminal or glossopharyngeal or any other neuralgia in the orofacial region. Now, a lot of instances, the previous classifications, if you were to go over, you would broadly see it being divided into primary and secondary. So primary included both idiopathic and classical neuralgias, and secondary were generally secondary to underlying clinical lesions or diseases. So when neurovascular compression is secondary to lesion or a disease, then it is referred to as secondary neuralgias. And about 10 to 20% of neuralgias that we clinically encounter, they are secondary neuralgias. So a good clinical examination and a good history is essential to delineate classical, idiopathic, or secondary neuralgias. And imaging plays a very important role in this diagnosis. So if you're looking at the classification, we have idiopathic, classic, and secondary trigeminal neuralgias. Secondary trigeminal neuralgias are generally accompanied by additional clinical features such as numbness, paresthesias, dysesthesias, and which would raise suspicion for further imaging. And the current clinical diagnosis generally suggests a strong recommendation for adopting these imaging modalities in any case of trigeminal neuralgia, because just relying on the clinical features may not be sufficient to distinguish these three categories, particularly in early stages of trigeminal neuralgia or secondary trigeminal neuralgia. Idiopathic and classical trigeminal neuralgia are further subclassified as purely paroxysmal episodic neuropathic pain and with concomitant background pain. So you could have neuropathic pain conditions where there is sudden bursts of sharp shooting pain, and it could be purely paroxysmal. And the second category is where they have pure paroxysms of episodic pain, but underlying that, the patients would describe a continuous kind of burning or aching pain in the background. So sometimes when the patients present with concomitant background pain, a history is very essential because they can mimic odontogenic pain or temporomandibular disorders. And like we've been discussing since yesterday, the spectrum of orofacial pain is really huge, and distinguishing different conditions requires patients, a good history, and a good diagnosis. So getting a good history is very critical to getting the appropriate classification, and then getting the proper diagnosis, ordering the proper investigations, and finally to treatment and its success. So the diagnostic criteria for neuralgias, episodic neuropathic pain in general is that the pain. So when we describe the pain in terms of history, we basically speak of it with 6 magic questions. That is the location, the duration, quality, intensity, aggravating, and alleviating factors. So when we speak about different neuralgias, the location primarily is based on the distribution of the appropriate nerve. So if it is the trigeminal nerve, it would affect one or more branches and divisions of the trigeminal nerve, and the pain would be limited to the distribution of the trigeminal nerve. The characteristic of pain is that patients describe it characteristically as acute, the worst kind of pain they've ever experienced. It's sharp, shooting, electric-like kind of pain. And the duration of pain is characteristically a few seconds to a few minutes. The longest documented duration has been about 5 minutes. It may or may not be accompanied by autonomic symptoms. And generally, when it is accompanied by autonomic symptoms, you would classify it as a trigeminal autonomic cephalalgia called SUNC, and that would be the distinguishing characteristic. And it is always aggravated or caused. It can be spontaneous. In certain other instances, it can be triggered by light touch, exposure to cold, applying makeup, combing your hair. Any of these innocuous stimuli can trigger the pain conditions. And very importantly, it's not accounted for by any other ICHD3 diagnosis. So to begin with the case, this was a 65-year-old male who presented with a chief complaint of left facial pain of approximately 35 years duration. He was diagnosed initially with trigeminal neuralgia, and he was treated with carbamazepine initially, had good success. And over a period of time, he stopped responding to carbamazepine, and he had to undergo interventional radiofrequency ablations. The patient did have relief for 8 to 10 years, but recently the pain reappeared, and he wanted a second opinion. So the neurologist had referred him for microvascular decompression. But owing to his comorbidities, medical comorbidities, he wanted a second opinion, and he presented to us. So remember, when you're dealing with any pain condition, your history and your clinical examination is very critical. Like I mentioned, episodic neuropathic pain or neuralgias, as the name implies, it's accompanied by brief sharp shooting pain. And often these patients present to a dentist, assuming it's toothache. If you've heard Dr. Thomas's lecture yesterday, he was speaking about pre-trigeminal neuralgia. There can be episodes where it marks particularly and manifests particularly in the teeth. And a lot of times these patients present to dentists and undergo multiple dental procedures, assuming it's odontogenic in cause. The characteristic feature is that there's very poor response to analgesic, and you may also have trigger zones. So early on in the history, there is a concept called pre-trigeminal neuralgia, which has been floated about. And sometimes these patients may present with dull, burning kind of continuous kind of pain before the onset of actual trigeminal neuralgia. And a lot of these studies are retrospective studies which have reported the concept of pre-trigeminal neuralgia. So there is still a lot of discussion on the existence of these conditions, but a lot of patients in retrospect do recollect these early bouts of burning, continuous kind of pain. Now, early on in the disease, the frequency and the intensity is lower, and the patient may have just 1 or 2 episodes early on, and they do have a remission period. So early on in the course of the condition, the remission period is larger, and as it progresses, the remission period gets shorter, and the frequency and the intensity of the pain may progress. So the figure is basically an animation showing the 2 different kinds of neuralgias. That is, one is which is purely episodic. So you have 1 bout of sharp pain, and then the patient has no pain. And the second kind, which is accompanied by background intermittent continuous pain. So the patient is never at a normal stage where there's no pain. So they will have a bout of continuous background pain and bouts of sharp shooting pain in between. So in particularly these instances, it's essential to distinguish it from other causes of orofacial pain. So when we are speaking about the different orofacial pain, orofacial neuralgias, it's essential that we have a good idea of the neuroanatomy. And the conference has been excellently planned because there was a session which was dedicated just to neuroanatomy today. So getting a good grip on your anatomy and physiology is crucial before you understand orofacial pain conditions, their presentations, their diagnosis and treatment, because without a proper knowledge of the anatomy, you fail as a clinician. So also you need to remember the distribution of each of these cranial nerves, because some of them do share, some of the structures in the orofacial region do have common sensory innervations. And generally with neuralgias, the distinguishing feature is based on the nerve that is supplying the particular area. So if you see the external acoustic meatus, there are several nerves. You have cranial nerve 5, your 7 and 10 supply your external acoustic meatus. And similarly, your tympanic membrane, the medial surface is supplied by the glossopharyngeal nerve, whereas the lateral surface is supplied by the cranial nerve 7. So a good understanding of your anatomy is essential, because you need to distinguish the nerve supply of the particular region. So if a patient is speaking about pain in the ear, you need to know about the sensory distribution of the ear, the external acoustic meatus, before you classify it as a particular neuralgia. So trigeminal neuralgia, among the orofacial neuralgias, it's the most common one. And the incidence is about 4.5 for every lakh individuals. And it's primarily a disease of the older individuals. So if you see it in a young individual, and particularly a patient who's wheelchair bound, or who's having systemic issues, your primary concern should be ruling MS, because that's the most common secondary cause of trigeminal neuralgia. The clinical features are very similar to the episodic neuropathic pain that I said, and it generally follows the distribution of the trigeminal nerve. So if you keep your fingers across your face, that's a distribution of the trigeminal nerve. And generally, you can see it either in the ophthalmic, maxillary, or mandibular division. And it's the most common in mandibular division. And following that, it's common in the maxillary division. Whenever the patient presents with bilateral symptoms, or with symptoms of involvement of 2 or more branches, that should raise a suspicion for further investigations and further imaging as well. Do a good review of systems, because ruling out systematic conditions and secondary causes is extremely important. So like I said, it can affect any of the 3 divisions, and having a good idea of your anatomy is critical. Okay. The second thing that is always confused in neuralgias is use of the terms trigger points and trigger zones. Trigger points, we commonly encounter it in myofascial pain, whereas trigger zones are encountered in neuropathic pain condition, episodic neuropathic pain conditions. And trigger zones generally are areas which are hypersensitive and can trigger an episode of the episodic neuralgia. Classically, in either idiopathic or classical trigeminal neuralgia, you would have a refractory period before onset of the next bout of pain. Glossopharyngeal neuralgia, among the facial neuralgias, trigeminal neuralgia is the most common, and the second most common is your glossopharyngeal neuralgia. The percentage is 0.5 to 1 in 100,000 individuals. And again, if there are other symptoms like numbness, the patient has dysarthria, difficulty swallowing, dysphagia, blurred vision, difficulty talking, is wheelchair bound, has numbness in particular areas, and characteristics which are not fitting into classic neuralgias, you should start suspecting MS, because that's the most common secondary cause of neuralgias in the orofacial region. Again, the distribution, it follows the glossopharyngeal nerve. So you would feel it as pain in the ear, the base of the tongue, tonsillar area, or the base of the angle. And common triggers are swallowing, talking, coughing. And again, there is a refractory period generally in idiopathic glossopharyngeal neuralgia. Sometimes, because of the association of vagal nerve, the patients may have additional symptoms such as vasovagal syncope, cough, or hoarseness of their voice. The other uncommon neuralgias are nervus intermedius neuralgia and occipital neuralgia. Again, in nervus intermedius neuralgia, remember it follows the distribution of the facial nerve. So you would feel the pain deep in the auditory canal, and it can radiate to the parieto-occipital region. And neurovascular compression is the major cause in most of the orofacial neuralgias. And it could be, again, idiopathic, or it could be classical and secondary types of nervus intermedius neuralgias. Occipital neuralgia, this is the only one which isn't a cranial nerve, and it would follow the distribution of the lesser and greater occipital nerves, and it's commonly due to nerve compression. And there may be, it is one of the few neuralgias which may have a continuous component, and the patient may also have additional numbness and dysesthesia in the particular areas. And there is tenderness in the occipital area as well. One common thing that we have with odontogenic pain and episodic neuralgias is that we commonly use local anesthetic blocks to distinguish the site and the source of pain in several orofacial pain conditions. But remember that in neuralgias, they do respond to local anesthetics. So your history in deriving a good history and clinical examination is very critical to distinguishing it from odontogenic pain. So generally, what are the red flags that you encounter that should raise the suspicion? Generally, if it's a young patient, less than 40 years of age, absence of refractory period between the attacks, involvement of one or more divisions of the any of the nerves, bilateral facial pain, and sensory changes. Most commonly, neuralgias do not wake the patient from sleep. So if the patient is waking from sleep, you have to raise suspicion about involvement of secondary causes as well. Now, the management of the neuralgias is a little beyond the purview of today's lecture, but I'll briefly speak about the different management strategies. So conservative medical management is the most important one. Unfortunately, I see a lot of physicians directly prescribing, more than physicians, a lot of dentists prescribing carbamazepine directly without appropriate blood work and without appropriate knowledge of the medication. So it's critical that we have a good understanding of the pharmacotherapy, because a lot of these are heavy dose medications, and you need to know the pharmacokinetics and pharmacodynamics of these medications before you start prescribing it. It should be accompanied by appropriate investigations as well. So you have different first line, second line, and third line medications, and sometimes combination of the three is also essential. And you also need to be familiar with the different side effects. There are also interventional and surgical modalities. This is beyond today's lecture's purview. But we do often do interdisciplinary management with the pain physician and with the neurosurgeon. And there are different surgical modalities and interventional modalities. And there are specific indications and contraindications to refer the patient for these modalities. And they have been found to have good success as well in appropriately selected patients. So always think of your question and what you want to do with every particular patient. And going back to a patient, so when we look back at the investigations in this patient, he had an MRI early in the 1980s, and after that, he never had an MRI. And remember, at that point, MRI in the 1980s was still at its developing phase. So we thought, looking at the scenario of this patient, we assumed that we require MRI because it's been more than 30 years since he's had one. We did the MRI, and what we found, we had to order an MRA as well, and we had to refer him to an interventional pain physician because there was bilateral agenesis of the internal carotid artery. And because of this, there was collateral circulation being developed, and there was dolichoectasia of the vertebral artery, applying pressure to the trigeminal nerve. And this was causing the neuralgia. He was also starting to develop symptoms of glossopharyngeal and nervous intermedius neuralgia as well. And at this point, because of the medical comorbidities, and he had 2 TIAs during the course of treatment, and hence it was decided to go against microvascular decompression and other interventional modalities. A trial of pregabalin had never been done. So a trial of pregabalin was done, and the patient had very good relief just with that. In addition to medical management, his cholesterol levels were very high. He had hypertension. So all those were managed, and with that he had good success in the treatment. So concluding today's talk, the current clinical guidelines says there is no particular clinical feature which can exclude trigeminal neuralgia, which is secondary to other causes, and hence MRI is generally recommended in all cases with trigeminal neuralgia. And in patients in whom MRI is contraindicated, then you can do other testing modalities as well. But relying just on evoked potentials is not a good idea. And when you're distinguishing idiopathic and classic trigeminal neuralgia, remember the distinction may be important when you're thinking of referral to a neurosurgeon for microvascular decompression, because classical trigeminal neuralgia or glossopharyngeal or any other neuralgia may respond better to microvascular decompression as opposed to idiopathic neuralgias. So I'd like to thank the organizing committee once again, and my professors, teachers, and colleagues for giving me this opportunity, and thank you so much.
Thank you, Dr. Maithili. It is always a pleasure listening to you, and there are so many take-home points. And if you could share the slide, okay, or maybe tell them. Yeah, there was a question asked. Can you share the medicines again, like
Sure.
Yeah? So I think people would want to take a screenshot of that.
Sure.
But mind you, please do not start prescribing these medicines without knowing the side effects and the treatment at the correct titration. So this is just a helping guideline or something like that for you. Don't try to use this as a 100% effective mode, because this is after reaching to some conclusion, some diagnosis, then we prescribe and titrate it accordingly. So though this chart, you can take it home, but don't start prescribing from tomorrow itself.
Right. So I totally agree with you, doctor. And the most important take home from this slide should be that what you're seeing about the side effects, right? Stevens-Johnson syndrome, particularly in the Asiatic population, is very common and it can be life-threatening. Good knowledge is you can counsel the patient, but advising these or starting with these medications, I would be very, very careful. And I would always suggest, if you don't have an orofacial pain specialist, please do consider referring to the neurologist because they are, or the physician, because they're better equipped with the knowledge to titrate or change the doses when they're starting these medications. And some of the side effects can be life-threatening, and we are not equipped to deal with those. So you have to be extremely careful with these medications.
Yeah, doctor, can you go one slide up? They
Sure.
want the previous slide also. I think this answers all the questions because, ma'am, you covered everything so well that yes, it has generated a curiosity amongst everyone that and I'm sure they will go back to their cases and definitely try to find a diagnosis, a
Sure.
solution to these everlasting pain conditions. Thank you so much, Dr. Maithili, and it's always a pleasure listening to you.
Thank you so much, Dr. Yarpude. It's been such a pleasure interacting with you.
Same
Thank you
here.
for giving me
Same
the
here.
opportunity. Yeah, thank you.
Thank you so much, ma'am. And with that note, we would like to welcome our next speaker, that is Dr. Vaishnavi Prabhakar. Dr. Vaishnavi, are you there? Dr. Vaishnavi? I saw her in the chat room.
Hi, Doctor, I am here.
Hey, hello, hi. How are you, doctor?
I am fine. How are you?
Great, great. So I see you're in a clinic setup right now, and I can see the mandatory any orofacial pain specialist that should have is a skull with mandate attached. Okay.
Yes.
Yeah, so let me welcome you to International Orofacial Pain Congress, doctor. And can you just adjust your camera a little lower, maybe an inch or so?
I
Okay,
think it's
perfect.
good.
Perfect. This is way better. Thank you, doctor. Dr. Vaishnavi Prabhakar is an MDS. She's done it in prosthodontics from SRM University. She has completed a fellowship in orofacial pain and TMD and sleep medicine in 2018 and mastership from the same university, that is Roseman University and Uttan, USA in 2020. And diplomate, she's a diplomate in American Board of Orofacial Pain, PhD certificate with Dr. MGR Educational and Research Institute. She manages patients with severe facial pain, temporomandibular joint pains, and other headaches in Dr. Prabhakar's Facial Pain and Family Dental Center. And I believe that is in Mumbai, right, doctor?
No, Chennai. I'm
Chennai.
from
Okay.
Chennai.
Pardon me.
Chennai.
Okay,
No
so
problem.
Vaishnavi, you are touching base with a very important topic, that is burning mouth syndrome. Many of our patients are misdiagnosed as ulcer cases, and actually they are suffering with a very life-altering phenomenon, that is burning mouth syndrome. So, Dr. Vaishnavi, you can start sharing your screen, and stage is all yours.
Yeah, thank you so much, Dr. Sonal. It is a pleasure for me to be here. And I would like to thank Dr. Maithili, who's been, I think, guiding us and lecturing us for quite some time. And it is a pleasure lecturing after her. I'm just a baby when it comes to Dr. Maithili and everyone. So shall I share my slides, Doctor?
Yes, yes, please go ahead. As I say, Dr. Maithili is the grandparent of
Exactly.
so we all are babies in front of her.
So
Yeah.
today is, I think a lot of TMD has been going on, but today is a little, I don't know if it's going to be boring or interesting. It is burning mouth syndrome. It is nice that I am placed after Dr. Maithili's presentation. This is because right now burning mouth syndrome is not only considered as just a clinical entity, but a neuropathic pain. So coming to the introduction, it is an idiopathic chronic pain disorder which is characterized by burning sensation in the oral cavity in the absence of any identifiable organic disease. So there should not be, when it comes to a syndrome, there should not be any clinically identifying factors that is present that can relate to the BMS. And this is given by the International Headache Society, and it classifies BMS as a painful cranial neuropathy. So coming to the definition, it is by the International Headache Society, you see that it is intraoral burning or dysesthetic sensation that is recurring daily for more than 2 hours per day. So it should be there for more than 2 hours per day, and it should be chronic, that is more than 3 months, without any clinical evidence of causative lesions. The International Classification of Orofacial Pain, the ICOP, which ma'am was mentioning, this says that it's an idiopathic pain disorder which has intraoral burning sensation or dysesthesia recurring daily, again for more than 2 hours per day and for more than 3 months without any identifiable causative lesion with or without somatosensory changes. So the American Academy of Orofacial Pain defines BMS as a burning sensation in the oral mucosa despite the absence of clinical findings and abnormalities in the laboratory testing or imaging. So when it comes to all the large organizations, they describe it as a burning sensation which is present in the mouth for minimum of 2 hours or more than 2 hours and continuously for a minimum of 3 months period without any clinically identifiable lesions in the oral cavity. So coming to the prevalence, it occurs in 1% to 3.7% of the population. It can have spontaneous remission and go under the rags after 5 years in 3% of the cases. Prevalence of BMS is higher in the postmenopausal women, that is 18%. These women have a higher chance of BMS. Female to male ratio can range from 3:1 to 20:1. It depends, it changes. So there are 2 classification systems which make us a little knowledgeable on this. This is Lamy and Levi classification on BMS type 1, where the burning increases throughout the day and peaks in the evening. Then type 2 is when there is continuous sensory disturbances that is present. And type 3 is when it is intermittent with pain-free periods. So next is the Scala et al. Classification, where the primary is when BMS is the exact condition and there is no local or systemic cause that can be identified or related to the burning sensation. Secondary is when there is organic, local or systemic cause for intraoral burning sensation which is present. So coming to case presentations before we go ahead with other part of BMS. So this is case 1. She's a 48-year-old female. She was undergoing premenopause. This patient has been with me for the last 7 years. So she had initially, when she had walked into the clinic, she had severe pain and burning sensation. So where was the pain? Chief complaint is pain right behind the left ear, that is left ear. And next is pain in the lower left jaw. Next, she had burning sensation in one half of the tongue, tingling sensation in, again, the lower anteriors, itching sensation all over her tongue, and loss of balance. So these were her complaints. So the location is in the left postauricular region, lower border of the mandible, mandibular anteriors, and left half of the tongue. So it was a sudden onset and it has been chronic and non-remitting. It is not budging to any treatment given by anybody. So the left postauricular region, 9 out of 10 VAS scale was present. Lower border of the mandible, 7 out of 10 VAS scale was present. Pain attacks were at least 10 attacks for lasting for a few seconds with pain-free intervals. This comes under the type 3 category of BMS. So tongue left half continuous burning pain is present, 7 out of 10 VAS scale. Intermittent itching in the entire tongue present multiple times in a day, 3 out of 10 in the VAS scale. So the mandibular anteriors had a background tingling sensation which is 3 out of 10 in the VAS scale. Where's my slide? Okay. Associated with loss of balance, vertigo, feels like the face is swollen, recurrent ear deafness in blocks and neck stiffness were present. So treatment is, she was given several splints for TMD and it gave her 50% relief. NSAID responded well with regards to the preauricular and the mandibular pain. So intraoral, we did an intraoral examination, extraoral examination, and TMJ examination. So overall, there was bilateral symmetry with all the structures. Intraoral examination, she had a class 1 occlusion with no painful spots in the mouth or any deep caries or anything like that. Her plaque levels were moderate, and there was no requirement for a scaling. So we did a TMJ examination. There was an opening click and a closing click present on the right and left TM joint with mild to moderate pain on the left side. The muscle palpation, the right was within the normal limits, but the left side, temporalis, had mild pain. Superficial masseter had severe pain with trigger points. Sternocleidomastoid again had severe pain with trigger points. Deep masseter had some amount of pain, which is referring again to the ear. And the anterior digastric, which had severe pain, that is referring to the lower anteriors. So now we gave a differential diagnosis of intracapsular disorders, that is disc displacement with reduction, myofascial pain in the left mandibular region and the lower anterior region, which I have not mentioned. Then it could be a cervicogenic headache. It could be a TAC, which is hemicrania continua, or a neuropathic pain, which is trigeminal neuralgia or glossopharyngeal neuralgia. So the diagnostic test we did was endomethacin testing. This was taught by Dr. Davis and Dr. Maithili, where we test these patients for hemicrania continua, and we do some serum investigation. In that, there's a bunch of tests that we usually, protocol that we follow, that I would show you later. And this patient was low on vitamin D and iron levels, serum iron and vitamin D. So MRI brain was performed because the intensity of the pain was quite high, and due to the certain factors such as pain coming as shocks and waves and having pain-free periods, and the burning sensation which is severe with swelling. So there was an indication for an MRI brain, which was done under the supervision of a neurologist. So now coming to the MRI findings. MRI, the vascular structures were compressing and crossing over 3 cranial nerves, that is the 5th, 7th and the 8th cranial nerve complex, trigeminal, facial and the vestibulocochlear nerves. So coming to the pain behind the left ear was related to the myofascial pain. Pain in the left jaw was correlated to the myofascial pain. Tingling sensation related to the lower anteriors is myofascial pain due to the anterior digastric. Burning sensation in the left half of the tongue was related to the cranial nerve 5 neuropathy. Itching sensation all over the tongue. Itch is a primary sensation before pain. Again, it is considered as pain. And loss of balance was related to vestibulocochlear, where she complains of mild amount of hearing loss also. This could be related to the vascular structure that is compressing the vestibulocochlear nerve. So please understand how complex is a diagnosis, and this patient was treated on each aspect. The pain aspect, that is the myofascial part, was treated separately. The burning mouth sensation and the trigeminal neuralgia part was treated separately, and the itching, loss of balance was again handled with the help of an ENT specialist. So it really requires a multidisciplinary patients. These are not patients that can be easily handled at a dental practice. So we had 4 different diagnoses: trigeminal neuropathy, secondary to vascular nerve root compression; burning mouth syndrome, secondary to nerve compression; TMT disc displacement with reduction; and myofascial pain with referral. Now, again, another interesting case. This was a 70-year-old female who walked into my clinic in 2017 or 16. These are very interesting cases, so we picked it up for the presentation. She's a 70-year-old female. Burning sensation all over the mouth, cannot enjoy her food. She's a lovely lady who loves to have good food and has a good social life, but she could not enjoy her food. She was having difficulty consuming anything spicy. So pain, and she's lost a tremendous amount of weight. She was she lost around 15 kgs. So this has been present for the last 2 years. There's continuous non-remitting chronic burning pain, 7 out of 10 in a VAS scale, not associated with any other symptoms, cannot consume any spicy food, symptoms worsened over the years, symptoms start during the day, increase towards the night, sleep is not disturbed, and no pain during sleep. So usually there's something that you have to notice: BMS does not have pain during sleep. Patient has visited minimum 3 dentists. Oral candid paint was advised by the first dentist, no change in the burning pain. Extraction in the maxillary dentition by the second dentist. So she got all her upper maxillary teeth removed, considering that it was related to the pain, and there's no change in the burning sensation. So she was wearing a denture when she walked into our clinic. She was advised psychiatric opinion by the third dentist, but still there was no change in the pain. Systems review was done. Everything was within normal limits. She didn't have any other. She was fit and fine. She didn't have any other complaints. She was just feeling a little bit of disturbance in the sleep, mild tiredness. Since she was a very enthusiastic lady, maybe she took it very lightly. She was bilaterally symmetrical. Maxillary complete dentures and mutilated mandibular dentition was present. There was pale tongue. TM joint examination was within normal limit. Muscle examination was again within normal limit. So this was a case of BMS secondary to iron deficiency anemia. We went through detailed blood investigations in our clinic. We analyzed each step and we found out she was having severe iron deficiency levels, where the hemoglobin was around 8 or 9, which was missed for the last 2 years by many physicians and dentists. So a simple investigations which will help these patients. She loses her social life. She loses the nutrition that she's getting through food. She's lost around 15 kgs. She's depressed. She thought she was psychotic. So analyzing our patients step by step will help us look over it and make sure that these patients are fine in the long run. She was a very happy lady towards the end of the treatment. So a routine investigation with special focus to BMS was done. Now his very sad case was a 27-year-old female. She's unmarried. She was pastry chef. A very good looking, nice girl again. So her chief complaint was constant sore mouth, burning sensations in the corner of the lips, tongue and front portion of her palate. So this was a gradual onset of the burning sensation where it started, usually it is with the spicy food, but here you see it started with sweet food. And it used to give her burning sensation in her throat. She related into infections or some sweet food triggering viral infections or whatever, and she stopped consuming these sweet foods from 2015. So since 2019, occasional sore throat she used to have and choking sensation in her throat she used to have. August 2019, burning sensation started all over her throat and followed by dry cough with pain and irritation. September, she was having dinner, she had something spicy, she vomited. From then on, she's been suffering from extremely severe throat pain, which was burning in sensation. Patient developed intolerance to spicy food. Symptoms has exacerbated over the last 15 months. So pain characteristics every day since the last 15 months. This was done in 2020, this case. Yes, 2020. Correct. So 15 months and multiple times in a day. Throat pain, she used to wake up with 8 to 9 out of 10 throat pain lasting for 2 hours. After the which she'll have continuous non-remitting 5 out of 10 background pain which is present throughout the day. Burning pain was associated with choking sensation. Tongue, palate and lateral commissure of the lip were all involved. Associated with dry cough, hand tremors, cannot tolerate low temperatures. So what are the sensitive foods? Sour food, tangy, citruses, spicy, mango, watermelon, everything was analyzed step by step because this was a patient who would pick and know which she's picking up burning sensation. Every patient should be analyzed in such a way. What were the relieving features? Warm water, warm food. Tulsi was helping her, brushing her teeth with Colgate herbal mint, which had all these all these extracts in it, did help her with the pain. Gargles with the coolant helped her relieve from the pain. Past treatments, there were many with no relief, cannot sleep, sometimes due to pain. And she's a loud bruxer. She started sleeping in a recliner for the last 15 months due to pain and discomfort. So as a child, she's had mumps, bronchial infection, wheezing, chronic pharyngitis, and sore throat. If you see, she's always had some irritation in the throat region. There's been a tonsillectomy done in 2005. She had pneumonia in 2005 and she was admitted in the hospital and the tonsillectomy was done. 2015, a septoplasty was done for the septal deviation. 2015, she had no throat. March 2015, she had no throat pain. Slowly after which the pain started and started initiating. So in November 27th, she had her, this is why when Dr. Maitli and Dr. Ben Sonal were talking about mismanagement and giving out medications unnecessarily, taking pictures doesn't matter, because how much and what these patients go through in their lifetime is completely traumatic. So first the endoscopy was done knowing that this patient is having a burning sensation which is in a scale of 9 out of 10 with no anesthetic and no lubricant, and she was restrained by a couple of people and the tube was literally forcefully pushed into her throat where she had 10 out of 10 burning pain. It was complete trauma for her. The second endoscopy was done under GA by another gastroenterologist. Again, no findings. The third was mild to moderate hiatal hernia, acid reflux causing burning mouth was identified, but no acidity she complains of. So ENT, throat was within normal limits, cardiovascular within normal limits, respiratory, lung and pharyngeal wall was within normal limits. Psychiatric, they called her to be, she has chronic anxiety and panic attacks because of what and all she's gone through. Genitourinary burning micturition has started. She has tremors in both hands. She has been identified with PCOD and she's not pregnant or any hematological diseases. So past treatments, they had performed the surgery to help her with the burning pain. That is a fundoplication surgery where the stomach is wrapped around the esophagus. Next, she's been on bland food and dairy-free diet for the last 5 months to avoid acid reflux. Proton pump inhibitors, several has been given and nothing has worked. Vitamin B12 supplements has been given, iron supplements, even IV has been given. Extraoral examination, she is bilaterally symmetrical. Class 1 occlusion, everything within normal limits. TM joint examination was within normal limits. Muscle palpation and MRI and paranasal sinus CT was within normal limits. So this was a very interesting case of peripheral small fiber neuropathy. The small fiber meaning C fiber neuropathy. This can be due to several conditions such as metabolic, hereditary, infectious, immune-related or toxic etiogenesis. It involves both A delta and C fibers, mostly C fibers. It is usually present in the periphery. So it has a very complex set of investigations which has to be followed. This is better handled by a physician or a neurologist. So this case was again referred to the neurologist to proceed further with their treatment plan. We gave her clonazepam and to sober down the pain. Right now she's doing much better. So coming to discussion, so the pain characteristics can be the anterior two-third of the tongue, hard palate, and the gums. These are the most common areas which is affected in order. Bilateral or symmetrical, unilateral localization is mostly present. Pattern, its circadian rhythm plays a very important role. It worsens during the day and slowly increases in the night. Minimal or absent in the morning and increases during meal times. Moderate to severe intensity seldom interferes with sleep. It has no relationship with sleep, PMS. Alteration in taste can be present, dysgeusia, phantom taste can be present, metallic taste can be present, oral dryness, xerostomia, dry mucosa can be associated. Reflecting changes involving taste and oral somatosensory perception is important. Feeling of roughness and sandiness in the mouth can be present. When you can make a diagnosis for BMS, when all of these conditions are found to be negative, you can consider a diagnosis. The systemic factors are something that is very important that we should be really considered when you're treating a BMS condition. Is BMS neuropathic? ISP calls it a neuralgic pain. IHS calls it a neuropathic pain. Research done in BMS in the last 2 decades is identifying BMS as a primary condition with sophisticated diagnostic tools like functional brain imaging. There's various levels of involvement in neuropathic involvement, showing that these patients are not just simple patients, which is only the local factors that is affecting these patients. The neuropathological role in BMS, damage in taste sensation fibers may drive dysregulation of the central inhibitory system. There can be a role of peripheral neuropathy. There's in these patients, there's significant loss of epithelial and subepithelial nerve fibers. Then there is proliferation of nerve growth factor, cannabinoid type receptor 2. TRPV1 channels is increased. TRPV1 is known to be associated with hypersensitivity and neuropathic pain. So what are the steps in management? You need to do a complete history taking, physical examination, laboratory examination, serum blood investigation, radiographic investigations, and necessary referral. Please understand it is okay to refer these patients if necessary. So investigations, all these investigations can be done. Usually when referred to orofacial pain specialist, we do have a complex panel. If you want to run through basic investigations, you can run through. And oral cultures should be done if necessary, if you find white plaque or based on any ulcerations or any ulcers present, or you can take your investigations based on that. Imaging can be done. MRI and CT or nuclear medicine, depending on what is the pain properties and everything. Salivary flow rates can be found out, and it can be really beneficial in this patient. Allergy testing, if necessary. Medical listing any medications that they are taking that could affect BMS. Increased ACE inhibitors are known to be contributed for burning mouth. GERD reflexes, you should analyze it. Work with the gastroenterologist. Assessment of dental, where you have to check whether there's amalgam restoration or ill-fitting dentures that are causing this condition. And management, there are several modes of management. So the last one is something that I would not touch without a consent with the neurologist. Psychological, even topical medication, you just take a step back, wait, analyze the patient, and then you can proceed with these patients. Usually amitriptyline and clonazepam oral rinses work really well, and capsaicin also does help in BMS management. Thank you so much, Dr. Sonal. It is a pleasure being a part of your team, and I hope it was a useful presentation.
Yes, Dr. Vaishnavi, always a pleasure listening to you. And definitely, you have covered the topic so well that I'm sure there are questions for you. But you have covered the topic in a way that at least they have a basic understanding of which cases to not let go, saying that they are just a normal regular ulcer cases. So now they have a better understanding on the topic. Yeah, they wanted to share the investigation slide, if you can share with them.
One.
I think this should do the job. Okay, and there's one more question. What was the diagnosis of the third 27-year-old patient case?
Yes, she was a case of peripheral neuropathy, small fiber neuropathy. That is because of the multiple procedures she's done, or we had to really dig in deep to find out if it is related to any other immune conditions. So it is a small fiber neuropathy case. She has mild burning sensation throughout her throat.
Thank you so much, Dr. Vaishnavi.
Thank you
And
so much.
I'm sure if anybody would want to connect with you, they have your details, so they can always connect with you. And thank you, Dr. Maithili. You were kind enough to share your mobile number and all with the participants. It takes, and it's again one more learning curve for us, that you are available for all the participants 24/7. Thank you so much. Thank you, Dr. Vaishnavi. With that, I would like to welcome our next speaker, Dr. Shashwat Diwan. Dr. Shashwat?
Yeah, I'm there.
Yeah. Hello, Dr. Shashwat. Okay. Dr. Shashwat and me go way back because we did a fellowship together with Dr. Thomas, and I always used to call him the most notorious person in our group because he was the one who was never doing his submissions on time, yet he passed the whole session with flying colors. And I'm very proud the way he has been conducting himself all throughout. I keep seeing his progress. I'm very happy. And Dr. Shashwat Diwan is a maxillofacial surgeon. He's running his exclusive practice of maxillofacial surgery. I must say his better half is the one who's running the practice while he's running around managing the surgeries. And he's a mentor in many courses around India and internationally also on zygomatic implants, exodontia, and whatnot. And he has trained over 150 doctors around country and is also an international mentor. His pathological reconstruction and trauma case management is his core. Along with that, a very humble and a very loving person, I would say. Welcome, Dr. Shashwat. Yeah, your camera is perfect now. Yeah, can you share your slide, Doctor?
Yeah, sure. Thank you very much, Dr. Sonal, for a lovely. It feels really good to get an introduction from you. Thank you very much for having me here. And can my screen, is it visible or
No,
how is
start
it?
with share screen.
Yeah. Is it visible now?
Yeah, can you go to a presenter mode or a full screen mode?
Yeah, I'm there.
Yeah, okay. Stage is all yours.
All right. So a very good afternoon and a good morning to all those who recently joined. And thank you very much once again, the whole organizing team, to have me here. And as Dr. Sonal just mentioned that, yes, our orofacial pain journey goes a long way. And yes, we have come a long way and still trying to figure out a lot of things and learning a lot of things. And the previous lecture just before this on the burning mouth, of course, it had a lot of insights. So thank you very much, the presenter, for that. So today our topic, which I'm going to discuss, is TM joint arthrocentesis. So it's basically the joint solutions which we always are confused about. If I go back around 5-6 years back, I was really confused because the only thing I understood in TMJ was TM joint arthrocentesis. As a surgeon, I was taught arthrocentesis, but then comes Dr. Davis Thomas, and he really opens up our horizons, and we came to know that there are a lot of things which we need to understand apart from just the surgical aspect, and that is something that I'm going to relate in the coming 15-20 minutes of time. So just since I already had a good introduction, yes, I'm a maxillofacial surgeon by profession, and yes, my core work is
Dr.
maxillofacial.
Shashwat, sorry to disturb you. Your screen is halfway visible. Only the quarter section is visible. I guess it is divided into, yeah, can you maximize the slides first? No, what has happened is your screen is divided into section.
Is that fine now?
No. It is still divided into section, doctor.
Okay, how about this?
No. Go to a full presenters mode, right? The full screen mode.
Yeah, I'm on it. I'm already on a full.
Maybe you could just log out of the share screen mode and log in again.
Sure, I'll do that.
Can I just, are you using a Mac, doctor?
Yes, I'm using a Mac.
So go to the presenter mode and change it to single screen.
Okay, just a moment.
Hello, Dr. Ratin, and always a pleasure having you as my back-end support system. Dr. Ratin Das is here. He was our jury yesterday, and he and Dr. Rathi, Dr. Seema Rathi was our jury for the paper presentation, and the students are really, I mean, they messaged me also saying that the whole inputs given by Dr. Das were wonderful.
Thank you so much.
Okay, I'll just cut here. I went to the presenter mode, and what do you want me to do next?
So start sharing the screen first, Shashwat. Start with sharing the screen.
All right.
Okay. Now she will be fine. See,
It is just see.
Looks good.
good for your presentation.
Open your presentation.
Yeah.
No, we can see a blank screen, doctor.
Oh, I think there's some glitch here. Let me have a look. Okay, can you see any? What do you see on the screen?
Blank.
Nothing. It's a blank screen. Yeah. Now you will come.
Now you need to
Full screen. It's to go to full screen
go
presentation.
to
Some
full.
thing is getting cut, his screen is getting cut. I don't know why. This 1/4 of the screen is shown now.
Okay, so do you want me to do one thing? I'll just share the presentation on your phone, and you can just share the slide if that's possible.
Dr. Nooral?
Dr. Shashwat, can you send your presentation to us? We can share from our side, or I'm doing one thing. I'm just letting you, removing your co-host authority and then giving you again. You try once again. Let's see if it is working. Otherwise, I will take the alternate. Just hold it.
Yeah, hello everybody whoever has joined today, and I am loving the audience because from morning the audience number is the same, and I love that you all are glued to your chair today. Yesterday we had a very lovely session with Dr. Davis Thomas and Dr. Ratin Das, Dr. Ramesh Selvam, and Dr. Marathi in session. And Dr. Noodle, can you just mute your camera, this thing mic? And today, since morning, this is what fourth, fifth session, and yeah, Dr. Shashwat, can you yeah, he's
Please
shared.
try again, Dr. Shashwat.
All right.
So we started with neuroanatomy of orofacial pain. Then we continued on with Dr. Varun Conte talking about the joint vibration evaluation, and then we had TMD demystification by Dr. Avinash Shah. Yeah, Dr. Shashwat, can you share your screen now?
Yeah, I'm already sharing the screen.
Yeah. Okay.
Do you see it?
Yeah, I can see the same error wherein only the quarter of your screen is visible.
Okay, just a moment once again.
Dr. Shashwat, if you allow, can we take the next speaker, and by the time you can share the slide
that
to
should be
us,
good. That should be
and
good.
we'll do for the next turn actually.
I think that should be good.
Okay, yeah.
I'm giving you hi on your WhatsApp. You just send your slide on a WhatsApp if possible,
Yes.
or you can email me.
Yeah, you can stop sharing screen, Dr. Shashwat. Yeah, our next speaker is Dr. Tanvi. Dr. Tanvi, are you there?
Yeah, I am there, but I need 2 minutes. I'm just speaking. Just 2 minutes I need to log in from my laptop.
Okay.
If that's okay. Yeah. Just give me 2 minutes. Yeah.
Okay, so I was just summarizing the morning half of our lecture day today, day 2, and so we had joint vibration analysis done by Dr. Varun Kunte and followed by Dr. Avinash Shah, highlighting the appliances and TMD. He demystified TMD with his therapeutic management, the way he manages it. And thereafter, we had Dr. Maithili, who fantastically decoded the most debilitating and most life-changing phenomenon, that is the neuralgia, which each and every clinician also gets to check. Dr. Tanvi, you take your time. You can shut your camera and take your time. We'll give you time. And then we had burning mouth syndrome with Dr. Vaishnavi Prabhakar. And to all the delegates present, I am actually monitoring the ones who are actually attentive because they are asking questions. And I have a very wonderful gift for you all. Please be there till the end of the sessions. And the ones I know have been attentive enough, because the moment you attend any lecture, that is the time you will ask some questions. And it's not about a competition, but definitely you are on for some goodies from my side. And you share your number. I'll announce the names and you all please share your numbers. So you will receive some goodies from my side. And all the participants and audience, thank you. Thanks for the lovely interactions and pepping up the speakers also, because I always say the heart and soul of a conference is the audience. And you all are doing a fantastic job at that. And with that, Dr. Ratin Das, can you just elaborate your day yesterday, the evening you spent with us, if you're there, Dr. Ratin Das?
Yeah, I'm there, very much there.
Yeah.
Yesterday was a wonderful day, It was an eye-opener for me that the way, today we are discussing and we're trying to find out the various modalities. What was my learning lesson of yesterday's was there's a vivid plethora of ways that we can look at orofacial pain, especially the way Dr. Davis explained and, uh, Salem explained, the beautiful way that we need to look at our cases. It was such an eye-opener. And I would also emphasize on the presentations that we had, every presenter had something new to add on to our, information about orofacial pain. So it was really good. I had a wonderful day, and that's why I had to log in today again. And I'm there here and trying to do my rest of my work and trying to put something into my ears. But I'll want to have one of those gifts that you have in your goodie bags. So I'm going to be attentive.
Yes, doctor, you will definitely receive. Yeah. And you
Yeah.
can switch on your camera if possible, doctor, whenever possible. And
Yeah.
see, the whole concept of orofacial pain is so multifactorial, and along with it, the treatment plan will also be multifactorial. It cannot be like you cannot be saying that, okay, I have administered this many medicines and this treatment plan will definitely work. So
as you are continuously mentioning, I must also re-emphasize that we should be very careful, not that we heard something here today and we start, doing it from Monday. So that should not be, we have to understand, because these medicines have a lot of after effects, a lot of side effects and after effects. So we have to be very careful when we administer any of these medicines. So we have to diagnose properly before we jump into any of it and get trained for it. So what is most important is the training. We should train ourselves, educate ourselves well before we go ahead and do any treatment for facial pain.
Yes, definitely. That makes so much sense when we as orofacial pain specialists, even after so many years, even if we have to administer certain treatment plan or medications, which we need a consent from our fellow physicians, firstly.
Absolutely.
And secondly, an understanding about pharmacology. Like Dr. Ratin Das said yesterday, that book was always kept in corner after the exams are over. So literally, Dr. Davis Thomas made us read the whole concept, understand the whole concept, and still we are at the tip of the iceberg. There is so much to learn in orofacial pain. It cannot be like, you read a book and you are done with it. Every case is different, and I call it a Pandora's box. It's always, there are so many conditions that will come, and it will humble you because each and every patient will come up and you will be like humbled that, okay, I didn't know this condition and I need to learn more. So this is what orofacial pain has taught me, that the learning will never stop.
Absolutely. And we must go back to our basic books. And I must say, given time, we must read our anatomy books once again, because I'm sure we'll understand it much better now. Our anatomy, our physiology books, and our dental anatomy book. One book which we all must revisit is our dental anatomy book. That's extremely important. These three books, physiology and medicine and surgery to a little bit extent, but definitely anat and physiology. physiology we must revisit, because I'm sure at second BDS level when we heard, first BDS level when we heard physiology, it was just like any other science, But today it will make more sense to us because we are dealing with it on a daily basis,
Absolutely. And yesterday there was a very nice statement made that when a person, it's not a tooth you're treating the person as a whole. So orofacial pain is all about what not to do. You need to be cautious enough.
Exactly what
Yeah.
Spanky always said. It was Spanky man who said that I never saw tooth walking into a dental clinic. So it
Yes.
was a human being which is walking in. That's what we need to remember,
And caution yourself before touching these cases. You need to caution yourself that really, do I do this treatment, or will I be doing this kind of extensive treatment on my family members or any loved one of mine? So I need to be very careful and diligent in my diagnosis. I will
And I
always.
always use a quote in my presentations when I teach. I always tell that if you would do it to your child, you do it to your patient.
Yes,
I never say do it to your spouse because many times we like to do a lot of things to our spouses, but we'll never to our
I'm
children.
keeping this statement for my quality and understanding purposes, and I'll talk to madam about it then.
Yeah. She knows about it. She knows about it.
I know. She's the sweetest person I've ever met. So and she's the one who was all enthusiastic during our last conference. She was the jury also that time, the Pink Dental Congress. And this year I'm missing her. Maybe when if she can
She
join us also
wanted
for a
to
few
know when
seconds.
it comes on YouTube because she wanted to hear all of it. And
Yes, it will come. It is already live on YouTube. The
I
sessions
can
are all
see it
live.
is now live on YouTube.
Yeah, it is all live on YouTube, and also even if anybody has missed some session, they can always go back to and always check on those sessions. And
I'm ready, Dr. Sonal.
oh,
Sorry to
great,
interrupt.
Dr.
Yeah.
Tanvi, she is ready. Yeah. We saw your cab ride, and I was just wondering what Dr. Tanvi is doing today is what all the females in India, abroad, wherever are designed and mastered in doing. That she was doing multitasking. She had her parents' medical appointment at Bridge Candy, I suppose, and or Bombay Hospital. Yeah, and she is managing that, and I'm proud to say that. And Tanvi, I love you for this, because I'm proud to say that we women are multitasker, and Dr. Ratin will also accept this, that yes, what we can achieve.
I'll show you this little thing that my son gave me, okay? Can you see
Okay.
that? Let me just see if I
Yes,
can.
yes. We can see that the multitasker Dr. Ratin
Yeah,
Das.
that's what my son has given it to me.
Okay.
Yes.
I understand, doctor. I understand that, but then I will still say the women are better multitaskers. And right example is a
Hands up,
person
hands
sitting
up,
in front
hands
of
up,
you,
hands up,
Dr.
hands up.
Tanvi, Somaya, and Tanvi.
Yes, I'm here. Yeah, hi, Dr. Sonal.
Thanks for adjusting your time schedule and all and coming. And I understand family comes first. Always family should be the priority. But still you managed. Okay, Dr. Tanvi is BDS from MGM College, Navi Mumbai. And she is also a master and fellowship. She has completed a master and fellowship in orofacial pain from Smile USA, Roseman University, under mentorship of Dr. Davis Thomas. We are all his disciples. Yesterday already he mentioned all this. So, and she is the owner of Dental Abode Dental Clinic in Mulund, Mumbai, and she's practicing for 12 plus years, and plans to run an exclusive orofacial pain practice in near future. She crafts beautiful smile personally and professionally, and she also is a holder. She has a beautiful smile of her own. So, Dr. Tanvi, can you just share your screen so that
Yes,
start
sure.
your presentation?
Thank you so much, Dr. Sonal, for this wonderful introduction. Yes, we all women, I think all of us have to be multitaskers.
Yes, women are better, but I would always say that. Okay,
Is
your
my
screen
screen visible?
Yeah, you can go to presenters mode.
Sure. Is this okay?
Yes, please go ahead, doctor.
Yeah. Thank you so much, Dr. Sonal, and for accommodating. I mean, I could make it on time, but I knew your support was always there. So I know all of us have been listening to TMDs, TMJ related things, and plus then there is trigeminal neuralgia. Those things, I think we see it very routinely, so it's easier to connect with that. This is a very different topic, trigeminal autonomic cephalalgia. It's topic. I'll try to make it simpler in the time I have been given. And I dedicate this presentation to my mentor, Dr. Davis Thomas. You all heard him yesterday. This is from a recent travel, but the only purpose of putting this picture here is like orofacial pain is like a sea or an ocean of knowledge. And as much as you do, you will know you have to learn more. And TACs or the trigeminal autonomic cephalalgia is just maybe a drop in this ocean. We heard it so many times by now. What the mind does not know, the eyes cannot see. So let us learn these things, process these new information related to our patients. Let our neurons scintillate. And I would say keen observation is the key, because once you observe clearly, you would be able to diagnose your patient or at least lead them to a proper diagnosis. The scope of my presentation today is I'll just brief you about the spectrum of OFP, introduction of TACs, ICHD3 classification, pathophysiology. We'll cover cluster headache, paroxysmal hemicrania, hemicrania continua, sunk suna, the comparative table of their clinical features, differential diagnosis management, one of my own cases, and clinical implications of these. I know these lot of terms are new for you. I'll try to make it simpler. Orofacial pain, the spectrum was like well done yesterday in the presentations. So we'll just directly move to trigeminal autonomic cephalalgias, TACs. So TACs, the word literally means the trigeminal means the trigeminal nerve distribution is involved, autonomic. It has autonomic features. Cephalalgia, ceph is head, algia means pain. So that is a headaches involving these trigeminal nerve distribution and having autonomic features. The word was coined by Gottspy and Lipton in the year 1997. The more commonly involved is ophthalmic or the V1 division. Under ICHD3 classification, that is International Classification of Headache Disorders, it is classified as primary headaches. So just a brief section from that. The characteristic features, these are unilateral headaches, like strictly unilateral, and they have ipsilateral cranial autonomic features, means one-sided, the same side as the headache is persistent. It's lacrimation, edema, nasal congestion, meiosis, then runny nose or rhinorrhea, as we know, conjunctival injection, that is redness of the conjunctiva, forehead or facial sweating exclusively to that side, ptosis, all these features are observed. So these are autonomic. Most of them are parasympathetic, but like sweating is a sympathetic features. So the different TACs what we are going to discuss are cluster headache, paroxysmal hemicrania, hemicrania continua. SUNT, the full form is short-lasting unilateral neuralgia form. That means neuralgia-like headache attacks with conjunctival injection and tearing. Or there is a term short-lasting unilateral neuralgia form headache attacks with cranial autonomic symptoms, or short-lasting unilateral neuralgia form headache attacks. Suna. There are secondary TACs also, which are these symptoms of TACs or the presentation is seen secondary to some tumors. So the pathophysiology or pathogenesis, this is seen with the trigeminal autonomic reflex pathway, because we know the involvement of these two pathways in this, and parasympathetic pathway plays a very important role. The parts of the brain which are involved are like thalamus, cortex, hypothalamus, the autonomic system, trigeminal system, parasympathetic pathway, and like a few neuropeptides like neuropeptides Y have been proposed in this. There is a posterior hypothalamic activation seen. So in cluster headache, it is the ipsilateral, the same side as of the headache. In paroxysmal hemicrania, it's the contralateral hypothalamic activation. In SUNT, it is ipsilateral and bilateral. In HC, that's hemicrania continua, it's contralateral. So let's see cluster headache. Cluster means group, as we understand from the term itself. It's a prototype of TACs. The episodes occur in clusters or group. It is usually seen seasonally, like fall and spring have more episodes. It has a circadian pattern, a specific time of the day. For the individual, you will see that the person has headache at during that particular time itself. These are known as suicidal headaches because the pain is very intense and a stabbing kind of a pain, which like makes the patient feel that committing suicide is a better thing. But the thing is, you would observe them banging their head against the wall kind of a thing. they would wake up from this like sleep. They have hot sticks or sting behind the eye feeling. So the thing you would see them, they would just wake up in the night, middle of the night, and they would start roaming or take some water, go near the window, open the window, and take a fresh air. That makes them feel better. Plus, they would either go out, and if you see, they will just keep moving. They would be restless and agitated. The duration of these headaches is 15 to 180 minutes. Remissions may be observed. It is predominantly seen in second to fourth decade of life. The prevalence is less than 1%. Once in every other day to 8 times in a day, the episodes are seen. It has a male predilection. It is the most episodic one. It has severe intensity, restlessness, and agitation. These all, along with the autonomic features which I described earlier, the tearing, the redness on the side of the ipsilateral side of the face, plus rhinorrhea, all are occurring with these features which I have described. So the management is 100% oxygen, 7 to 12 liters per minute for 15 minutes through non-rebreathable mask. Non-rebreathable, the purpose is so that they don't breathe the carbon dioxide again inside. Triptans are one of the first line of treatments. Other treatment modalities are corticosteroids. The preventive mode is verapamil. There are occipital nerve blocks, neurostimulation, sphenopalatine ganglion blocks. MABs have also shown some efficacy. So this is the picture, like this is how they feel, like a cartoon picture of this headache. Paroxysmal hemicrania. Paroxysmal is episodes which comes and goes without any certainty. So they come in episodes at any time and just go away. Hemicrania is half it. They are side locked. It will be either just right side or just left side. The duration is 2 to 30 minutes. It occurs several times a day, has a severe intensity. The age group is 35 to 50 years. Low prevalence rate. Remission may be observed. It could be episodic or chronic. And neck movement may trigger these headaches. So, and plus the autonomic features which we have already seen. Management, these are indomethacin responsive headaches. So the therapeutic dose of indomethacin like completely aborts these headaches. So we can say that this is a pharmacological diagnostic testing. Other management modalities are COX-2 inhibitors, nerve blocks, sphenopalatine ganglion block, deep brain stimulation, and occipital nerve stimulation. Hemicrania continua. If you understand the term itself, hemi means half, crania is head, continua is a continuous pain. The word was coined by Shasta and Spearings in 1984. Prevalence is less than 2% of adult population visiting the headache clinics. Age range is 30 to 50 years. It is the most chronic because it's a continuous type of a headache. It is persistent. The usual pain is dull, but when there are exacerbations, it is throbbing sharp. Even stabbing pain is seen. Mild to moderate background pain is usually present. The maximum duration could be 30 minutes to 3 days. Even they feel restlessness and agitation. Rarely bilateral pain is being observed in hemicrania continua cases. It has a female predilection plus all the autonomic features we have seen earlier. The management modalities, even this is one of the indomethacin responsive headaches. Melatonin may be used for management and neuromodulation techniques also have shown some efficacy. Sunk, Sunar. These are moderate to severe intensity. These last for just seconds to minutes. They occur at least once in a day and they can have up to 100 to 200 episodes in one day. Prominent lacrimation and redness of ipsilateral eye, which is like conjunctival injection and tearing in the sunk. The word itself, it says that. It has cutaneous triggers. It is neuralgia-like. The neuralgia form word itself means neuralgia-like. Neck movements may trigger these headaches. So the headaches like cervicogenic headaches could be one of the differential diagnosis for these headaches. But because these are very short lasting and are the most frequent headaches. This is one of the management. The first line is lamotrigine. Other anti-epileptic drugs and IV lidocaine have also been used. So this is a comparative table. If you see cluster headache and sunk have male predilection, hemicrania continua has female predilection, and paroxysmal hemicrania has equal predilection in males, like no particular predilection. Quality of pain is mostly stabbing or throbbing and sharp in all of them. But in HC, it is only when those are exacerbated. Otherwise, it's a dull quality of pain. Most of them are very severe headaches. The The headache attacks, if you see, cluster is just 1 to 8 and sunk can have 1 to 100 or up to 200 also. And duration of attacks is 15 to 180 minutes in cluster headache, 2 to 30 minutes in paroxysmal hemicrania, 30 minutes to 3 days in HC, and 1 to 600 seconds in sunk or zone. Alcohol is triggered in the rest of the three except for sunk, which has cutaneous triggers. And we saw the line of treatments already. So if you see, the most frequent is sunk or zone amongst the three, and cluster headache is more in duration. So the differential diagnosis is migraine, trigeminal neuralgia with autonomic features, TMDs, primary stabbing headache, trigeminal neuralgia, primary cuff headache, primary exertional headache, hypnic headache, pituitary tumor-related headache, maxillary sinusitis, Tolosa-Hunt syndrome, and lateral medullary infarction. So if you see, the diagnosis can be as simple as a sinusitis to some tumor-related headaches. Management. Frankly, the management involves an interdisciplinary approach because as a dentist or just an orofacial pain specialist, we may not be able to manage these cases. So prompt referral is really indicated. I'll share my case. This is a 45-year-old male. He complained of severe pain around the right eye, even on slight touch. He felt pin piercing feeling from the palate in the upper right premolar region. So the location was right periorbital, retroorbital, and temporal on the extraoral sides. The frequency was every 30 to 45 minutes he had an episode, which lasted for 10 to 15 seconds. Intensity used to be 10 on 10, and sometimes it used to be 5 on 10. The quality of pain was poking or stabbing. Aggravating factors were touching, eating. Associated features were sensitivity of teeth and right eye tearing. He used to wake up due to pain and he had no medical history. So with the presentation, we can see that one of the differential diagnoses which he was given was trigeminal neuralgia, and he was treated for the same, but absolutely no relief of pain was seen with that. So our diagnosis for him was sunk because the male predilection, we see the location of the pain, the duration, the intensity is all very much coincidental with sunk. He was given lamotrigine and he really responded well. And I would want to say this case was a neurosurgeon himself. So there are so many such cases which we might see when he went to a dentist for this sensitivity of teeth or that pin piercing in the palate. But so because we don't know what it is, these could go unnoticed and undiagnosed or mistreated and misdiagnosed. So what are the clinical implications? Most of them are misdiagnosed as TMDs or migraines and trigeminal neuralgias. So succinct knowledge is crucial for correct diagnosis and prompt referral due to severe and disabling nature of these headaches. These affect the quality of life and these are really uncommon. So having a proper knowledge will really help us aid in the diagnosis. So proper history is the way to correct diagnosis, as I told, in the first slide of mine. Keen observation is the key, and listening to a patient, taking a proper case history and understanding what are the complaints of the patient is really crucial. I would like to thank my mentor, Dr. Davis Thomas. This is our JADA, our article which made to the cover page of JADA on sleep neuroscience. I would like to thank my husband and whole of my family because for their support, I could do these courses right now also, and I am where I am today. Thank you, Dr. Sonal. This picture is for you especially. These are my fellowship batchmates. Here is Dr. Srishti, who actually motivated me to take this course. And I am saying, I really feel now I'm a doctor. I was just a dentist before, but with this knowledge, at least I am on those lines where I'm reaching. And these are my mastership batchmates. I have my ex-dean, Dr. Savita Ram. I don't have Dr. Shankaraya sir's picture in this. He was not there. This is Dr. Samida Gandhi, ma'am, where I used to work before I opened my clinic. And this is one of my closest friends and it represents all my friends. So thank you everyone for your patient listening. Thank you IOPCON MedSkill for inviting me for this. And yes, so this is my clinic address, my email ID if anyone wants to reach. And any questions, I hope I could do justice in what the time I was allotted.
Yes, Dr. Tanvi, it was really wonderful lecture and very insightful. And I'll just check if there are any questions. Yeah, Dr. Maithari is congratulating you for a wonderful lecture, along with Dr. Jitendra Kumar also. He is congratulating you.
Thank you. Thank you so much.
Yeah, and one more, since there are no questions from the audience, yeah, so I would like to ask you, Dr. Tanvi, a very impromptu question. I'm sure you will be the right one to tell. I see that you have done your BDS. So can we
Right.
consider orofacial pain as a specialty, as a master specialty, and a new pathway for students who are pursuing, or they are really not sure about their uh, future, which course they want to take. So can you just throw
So
some
you
light?
want to stop? Let me stop sharing. Do you want
Yes,
me to
please
do
do that. Yeah.
Yeah. Yes. Yeah, yes, I am a BDS, yes, and I actually would recommend anybody can take, and I don't think it's a specialty, it's a super specialty, I can say. I think you would agree that with me for that. So anybody can take up, and I think it has broadened my horizon after taking up this. I understand my patients in much more better way. We usually take case histories like 15, 20 minutes. With this, now we understand so much is more important than just looking at a patient. Yeah, yesterday's slide, exactly. It's not the tooth, the whole person who is walking. And you saw this case, a neurosurgeon himself could not diagnose. If you see these cases are like at the level of a neurologist or a neurosurgeon. So if they can misdiagnose or underdiagnose these cases, definitely I think taking up this specialty, we can make a difference in a lot of patients' lives.
Yeah, thank you, Dr. Tanvi. And please check the chat box. You have lots of praises to going your way.
Yes.
Okay, with that, I
Thank
would
you.
like to welcome our earlier speaker, Dr. Shashwat Diwan.
Oh, so Dr. Kajal is asking lamotrigine dosage. So
Okay.
basically, so see, it's like I would rather not like put at the dosage right now. It's obviously you have to take into consideration a lot of medical, the history and everything, and then you should work in conjunction with a neurologist or neurosurgeon rather than prescribing it on your own. This is like the way I told you, it needs an interdisciplinary approach. So because this was almost towards trigeminal neuralgia for which he was treated. So like a better understanding. Yeah, I agree with Dr. Durga. It's a realm of a neurologist.
Yes. Okay, now we have Dr. Shashwat with us. And Dr. Shashwat, I'm sure your slides are visible now. Dr. Nooral, are you the one handling the slides?
My team, Ryan, is handling. Yeah, you
Oh.
just, Dr. Shashwat, you should just say next and he will change the slides. Yeah. Okay.
Dr. Shashwat? Okay.
All right, that works.
When
All
it's
right, so
Shashwat, something has to go wrong. That's what we always say.
absolutely, absolutely.
Shashwat?
For better things to come, the start
Yes.
has to be rough. So yes.
Okay.
All
Thank
right, can I have the next slide, please? So I'll just introduce briefly for people who have just joined now. Yes, I'm a maxillofacial surgeon and I practice in Ahmedabad. And my core specialty work is treating pathologies, trauma, and of course implants. Uh, Today, I'll be talking about a different topic, which is TM joint arthrosynthesis. Can I have the next slide? Now, TM joint arthrosynthesis is something that we had been learning since about 6-7 years. But the thing I realized after some time was that because I was an oral surgeon, I only used to see TM joint and arthrosynthesis as a treatment modality. And sooner I realized that there is something more to it apart from just being radically or thinking about it with a surgical approach. And that got me to the Orofacial Pain Fellowship. And of course, Dr. Davis Thomas, he has been a stalwart. He took us out and expanded our horizons for the treatment of TMDs and orofacial pain. So can I have the next slide? Now, next please. Yeah, so as we travel around everywhere around the world, we come to know that every people have a very different approach when it comes to orofacial pain. And trying to really sum up all these experiences into the presentation today, I'm just going to talk a bit on temporomandibular joint, the arthrosynthesis, and why not arthrosynthesis sometimes? So these are some things which would be the highlight of the presentation. So as we all know that temporomandibular joint, I'll just go back to something that we really read years back, the anatomy. So we all know that temporomandibular joint is a very special joint. It's not like our elbow joint or the knee joint because it has a hinging moment. It also glides. So next slide. So when we see that the temporomandibular joint, it's a very complex multi-axial synovial and bicondylar joint, which means that there is one bone that's the mandible, but it's been controlled by two joints. So that is one basic thing that we need to understand why a TM joint is a special joint. Next, please. So as we see that there is a condyle in the mandible and there is a glenoid fossa where it gets articulated. But somewhere in between, the problem lies. Or rather the problem, it's the complex discussions that lie. In every conferences we go, people talk about the articular disc. People talk about the condylar shape. So TM joint, as far as I see, is a very gray area and it definitely requires a lot of research still, which we really need to go through it. Now, if you see in this picture, you see a pink colored, that's a disc. Now, as I go for the further slides, I just want you to remember this picture of the articular disc. So as the mouth or the jaw opens, we see that the disc also moves, right? Next slide. But if we are really treating a TM joint, why do we really need to understand what is orofacial pain? That's the question. Yeah, keep this slide, don't change. So the basic problem here is that if I think as an oral surgeon, I always see that if the patient comes to me with a pain in the TM joint, he has something to do with the TM joint. But as we go deeper with the orofacial pain, we realize that some pain that are seen or felt in the TM joint are not actually because of any problems in the TM joint. Sometimes there's a referred pain which are referred eventually to the TM joint and we mistake it as a TM joint pain. And hence, not only a surgical approach is very important, but a medicinal approach or an approach of orofacial pain along with a TM joint pain exclusively is very important. It's like if you have both the treatments in your platter, you really can give the tailor-made treatment to every patient as per his or her needs. Next slide, please. So how do we really differentiate between a muscle pain and a TM joint pain? Now that's, I see a lot of clinicians really checking the joint, and once they check the joint and the patient will just shout and the doctor would say, oh, you got a TM joint. Well, everybody has got a TM joint. Everybody does, because there is a pain, the patient has come to you. Now the first thing which I was told by my mentor, Dr. Davis, you need to reproduce that pain before you really come to a treatment plan. If you can reproduce the same pain which a patient is feeling, that is the right way to take the treatments ahead. So one of the tests which I would like to discuss, it's called a wood stick test. Next slide. Here what we do is, we ask the patient to chew a wood stick on one side of the teeth, and you just observe. Now, if there is a pain on the ipsilateral side, it can be considered as a muscle pain. But if the pain is on the contralateral side of the wood stick, then it could be a TM joint pain. And sometimes, even if the patient is biting on the one side, but still there will be a pain on both the sides. That could probably indicate both the components, not only the TM joint or the muscle, but it would be TM joint and the muscle pain. Next, please. So when I say muscle pain, you can take it as a myofascial pain. Now we have already been hearing a lot about myofascial pain, so I don't want to really go into that detail. But the second thing that in a clinical scenario that every dentist should be knowing is how do you unload a condyle. So this is something that we do. You ask the patient to open the mouth, and intraorally you put the thumb in the molar region and you just push the mandible downwards, and that unloads the articular disc from the condyles, which means that the condyle drops a bit down and that creates a space. So the articular disc really unloads. If still the pain is there, then definitely it is a muscle pain. But if by unloading the condyle or taking it downwards, if the pain doesn't occur, probably it could be a joint pain because the articular disc has, the condyle has become away from the articular disc. The second test that you can do is, next please, the loading of condyles. What do you do in that? Again, you ask the patient to open the mouth. The mandible is again held intraorally on the molar region, and you put rest of the fingers extraorally at the angle of the mandible and just push the mandible slightly upwards. Now once you do that, and if the patient feels pain, it is definitely something to do with the joint space or the articular disc, because when you're pushing the jaw upwards, you're really compressing or reducing the joint space, and that is the time the patient feels pain. Next please. So this is how a normal disc position looks like. If you see in the first two pictures at the top, that's a normal disc position while closing the jaw and opening the jaw. But when you see the second picture, that is the anterior disc displacement without reduction. What does it mean? Sometimes when we send the patient for investigations in MRIs, the radiologist would just mention this word, that it's a disc displacement without reduction. So what does it mean? It means that whenever the patient is opening the jaw, the disc has moved anteriorly, but when the jaw is closed, the disc fails to fall back to its position and it is left at the same place or anteriorly. So that is what we mean anterior disc displacement without reduction, because the disc doesn't reduce back. Second is anterior disc displacement with reduction, in which understandably the disc goes back to its position. Next please. So this is how we classify the TM joint disease. We can classify it into stage 1, 2, 3, 4, and 5. It's Wilkie's classification. Clinically, when we see stage 1, you would just come to know that patient has some pain disc clicking and some unrestricted function. So patient is absolutely fine. Patient might just come with a mild clicking. And when you do a MRI for it, and you see there will be a very mild disc displacement with absolutely normal condyles. But as you move ahead with stage 2 to stage 3, the patient comes, gives you a complaint of some frequent locking or joint pains. They are not very regular, but yes, they do complain about it. And sometimes they also complain about a restricted mouth opening. So that is something, when you undergo MRIs in these patients, you might see some deformities, or you will see the disc. The radiologist would very well mention that some degenerative changes have been seen in the disc. So that is something that is kind of a stage 3. And then you have your stage 4 and stage 5. Stage 4, now stage 4 is something which is a very important thing for us to understand, because when the patient is under pain, sometimes these patients come to you with, after visiting 4, 5, 6 doctors. So it's been a year when patient is actually roaming around, and then they finally end up in your OPD. So the patient would tell that, yeah, I had a lot of pain, but now since a month, I don't have pain. So sometimes in stage 4, you see that the MRI shows that yes, there is a displacement, there is a deformity, the condyles are abnormal, deformed, but yet patient doesn't feel pain. Sometimes at stage 4, the pain goes down. So sometimes we misunderstand it and say that, okay, now things are getting fine, you should be good. But no, that's not the case. These patients end up in stage 5, which is a severe joint dysfunction. There is a crepitus. What does a crepitus mean? When two rough surfaces of the bone, that is the condyle and the glenoid fossa, have a friction between them, there is a crepitus. Now, these kind of crepitus, you can also hear with a stethoscope when you put it on the ear of the patient, and you can really appreciate that clicking sounds and all those things. So always my one of the take-home message that I would like to give is, keep a stethoscope in your clinic. It will really help to hear what you cannot hear clinically in the TM joint. And these kind of patients, when you go for MRIs, they show a severe deformity. Sometimes they have already ended up into osteoarthritis. Next, please. So how does TM joint arthrocentesis help? So first thing we really need to understand is that there is a negative pressure created in the upper joint cavity. So every joint has an upper compartment and a lower compartment. In between there is a disc. Right. So whenever a jaw opening occurs, the synovial fluid displaces from the upper joint, right? And the disc adapts very tightly with the glenoid fossa. So now what happens is, whenever the condyle again moves, there is a severe pain and there is a resistance in the movement. And that is how patients come up with a locked jaw. Patients complain that they cannot open the mouth fully, they cannot close fully. That is the reason. So in arthrocentesis, what happens is, whenever you insert a needle inside the joint and you distend it with a ringle-lactate solution, what happens is, because of the water thrust, the joint space again increases. So the adhesion of the disc with the bone goes away. And that is the reason instantly the mouth opening starts getting better. Next, please. Second, what happens is that because there is a constriction in the capsule, and whenever there is some distension happening because of the liquid or the fluid or ringle-lactate solution, there is a distension, and again it releases the condyle and the disc. And the last, because there are some inflammatory exudates already inside the joint space, so when you really irrigate it or do a lavage, arthrocentesis is basically a lavage of the joint space. When you do a lavage, you are removing those prostaglandins and all and creating a fresher, better environment for the joint to heal. Next. So one of the most important landmarks that you need to remember if you are performing arthrocentesis, it's called the Helsing-Holman line. It starts from the middle of the tragus to the outer canthus of the eye. The posterior entrance point, the posterior one, which you see in the picture, the B point, it is located along the canthotragal line, which is about 10 millimeters from the middle of the tragus and 2 millimeters below the Helsing-Holman line. And the anterior entrance point is about 10 millimeters further from point B, as you can see in the picture. So these are the very basic landmarks. But if you are starting with your TM joint arthrocentesis patients, I would advise that you can really mark the zygomatic arch, you can mark the condyle, and just try to imagine the anatomy beneath the skin. And once you are thorough with it, you can eventually switch to just point B and C. Next slide. So this is what we do. Of course, the area has to be sterile, so we use a betadine scrub and sterile the area. And of course, we give a auriculotemporal nerve block to anesthetize the TM joint. Where the block is given, it's right anterior to the tragus, where you inject the lignocaine with adrenaline, and that suffices for the in terms of pain for the patient. After that, the first thing you do is, with a 20 gauge needle, you go to the point B, enter the joint, right, and inject approximately 2 ml of ringle-lactate solution in the upper joint space. Next, please. After that, once you inject that, what you're basically doing is you're distending or creating a bigger space in the upper joint area, the superior joint space. After that, we inject some more, about 50 ml to about 200 ml of ringle-lactate solution and do a lavage. Along with it, we also add a bit of lignocaine and some beta-methazone steroids are also injected inside the joint space. With my experience, what I've seen is steroids do a fantastic job inside the joint. They really reduce a bit of inflammation. They fasten the healing in terms of the inflammatory exudates, and that really helps to the patient. Next, please. This is just a clinical case. If you see a marked black line on the right side of the picture, that's the line that you should keep in mind, that starts from the lateral canthus of the eye to the tragus. Next, please. And this is something that one of my very immediate junior in our, when we used to study, she designed this kind of a needle which was two needles being welded and connected to a single part. This is like a single prick TM, single needle technique, and this is very handy. But if you're looking for something really even better than it, then yes, you see one more picture. This kind of needles are also available for arthrosynthesis. Can I have the previous slide, please? Yeah. So the right side picture that you see, it's a single needle technique in which one of the end you inject the solution and the other end it goes out through the suction. Next slide. So after all the markings and the auriculotemporal block, next slide. Next, please. Yeah. So after that, you push the solution inside and you would see the solution coming out through the other port. Now, the picture that you see here, that's a TM joint arthroscope. So in cases of, say, stage 4 and stage 5, you can also do arthrosynthesis using a arthroscopy. So you are actually seeing the joint on the screen, and that is really accurate, and you can also remove excess adhesions if at all you see in the joint. So with the incoming arthroscopes, very fine arthroscopes that you see these days, arthrosynthesis has become really predictable. And again, it's an art to or a skill to learn TM joint arthroscopy. In fact, it's a very different subject. So that is something that also can be done. Next, please. And then you see this exudates coming out from other needle. This is how it actually happens even in the clinical scenario. Once you understand the anatomy and the landmarks, the process becomes pretty simple. What you need to take care is, once you inject the solution, once the solution comes out, you have to ask patient to actively move the joint, open and close, and the lateral movements. That is something which is a must. What happens is, sometimes when you inject the solution, the capsular space does get distended, but the adhesions don't really come out. For that, you really need to have some movements. Initially, I used to do these procedures under general anesthesia, then we switched to sedation, and sometimes now we also do it under local anesthesia, and because of its predictive nature. But if it's an arthroscopy that needs to be done, we prefer it under general anesthesia. Next, please. Yeah, so that's the procedure which I explained. In the double needle technique, you insert in the upper compartment of the joint. And yes, what our protocol is, we add lignocaine, we inject Kenacort along with it, and of course, adrenaline is always there with it. That gives us a clear bloodless field. So this is the protocol that we follow, which I just explained. Can I have the next slide? And yes, on the termination of the procedure, the patient is advised to advise restricted jaw movements and soft diet for next 24 hours, a day or two. And of course, we give them NSAIDs, and indomethacin sustained release is also given, because the pain can last for about 2 to 3 weeks. So you should be prepared for it. The counseling of patient is very important, because patient sometimes comes with a complaint that I now have a different sort of a pain after a procedure. But yes, that is expected for about 2 to 3 weeks, but should be good after that. Next, please. Complications. Now, every innovation and treatment comes with complications. So the most dreaded complication, which should never happen, is joint contamination. The sterilization, because it's a very yeah, thank you. Joint contamination is one of the dreaded complication which we really don't want, the infection or anything like that. Nerve damage. Now the entry points in 3M joint arthrocentesis are very far away from the facial nerve, but if you go a bit lower, you will encounter either chances of you encountering the facial nerve trunk. So that is one thing that you should be aware about. Also, one thing is very clear, that whenever you do these procedures, always take a consent about this and tell the patient about the complications beforehand. Foreign body reaction, yes, that is also always possible when you're injecting something which is not part of the body. And yes, you will come across this temporary swelling, which is again because of the lot of copious irrigation that has been done. And sometimes because of some internal bleeding, this can also happen. Next, please. So if I have to conclude this topic, I would say that TM joint arthrocentesis is a fantastic procedure when it comes to the outcomes. But case selection is very important because not all TM joint pains are originating from TMJ. This is something that we really need to understand, that just because I know arthrocentesis, I cannot treat every TM joint pain with arthrocentesis. I would rather prefer arthrocentesis in stage 4 and 5 cases, or in osteoarthritis, TM joint arthritis, in which they really work. In some cases, arthrocentesis is for a symptomatic treatment, and in some cases, they are really a predictable cure. So that is something that we really need to understand, or the reverse, that not all medicines can treat a TM joint pain, and the reverse, that not all arthrocentesis can release the joint pain, because some pains don't originate in the TM joint. They originate in the muscle, myofascial pain, and they release in the TM joint. So that is something that we need to understand. TM joint arthrocentesis also has shown excellent results in case of locked jaws. And with use of arthroscopy, the procedures have become really predictable and result oriented. So this was just a very brief. TM joint arthrocentesis is a very long and fantastic topic, but yes, I would like to thank Dr. Sonal and the team to really have me here. And yes, I'm open to questions, as I can see that.
Yeah, there are many questions for you. And first of all, congratulations on this wonderful lecture. And with all the glitches, I would say it was worth waiting for you. I love the presentation and all. Definitely, students will, or the participants will have lots to take home, and they have queries. So first is that there is a lot of scientific literature refuted corticosteroids in the joint due to erosion of condylar head. What is your take on that?
Yes, so there has always been a big discussion on this, whether should we really use corticosteroids if there is an erosion. So now we need to understand this thing, that when the patient already has an erosion, which means that there is an arthritic joint, you cannot really generate a disc. What you're doing in arthrocentesis is you're just giving a very asymptomatic relief to the patient, but these patients eventually end up into TM joint replacements, because even by adding corticosteroids, there is not enough literature to really support that it would, you know, destroy the joint or do good to the joint. But the clinical scenario is that these patients, we are just trying to delay the TM joint replacements till the body really can resist and heal the joint. But yes, these patients eventually end up in TM joint replacements, either one side or bilateral.
Absolutely.
And
any specific reason for indomethacin SR as a drug of choice for post-op pain?
well, post-op pain, any medicines can work, but just by a protocol, indomethacin has been used for a lot of TM joint pain and all. It is pretty good with controlling the pain, so that is the only reason. But yes, talking scientifically, indomethacin is not the only drug that can be used. Even good aceclofenac or tramadol can help.
Yeah. And how accurate are the markings in your experience, sir? In our settings, we at
A
times
lot of anatomical variations. So see, it's like I would just compare this thing with a dental implant. We do implants. We have seen people doing dental implants with just a RVG. We have seen people doing implants with taking a OPG and a CBCT. Now we all understand the importance of CBCT, right? Because of the anatomic variations. Similarly, when I compare it with TM joint arthrocentesis, yes, it is a blind procedure. You are just arbitrarily, as per the literature, what it says, you are just keeping that in mind and creating landmarks. But that's the reason why an arthroscopy comes into play. Because now the problem here is that I would love to do arthroscopy in every arthrocentesis patient, but how many of the people will be well versed with arthroscope and how many people would have a arthroscope? So yes, to reduce that experience of anatomical variations, arthroscopy really helps.
Wonderful lecture, Dr. Shashwat, and I'm looking forward to having you on board next year also. So thank you
My
so
pleasure,
much.
Dr. Sonal.
And next year, hopefully without glitches. Okay, when it's Shashwat, there are glitches around. Thank you for joining, Dr. Shashwat.
Thank you
And
so much. Thank
our
you.
next speaker is our distinguished speaker from Savita Dental College, Dr. R. Ramya. Dr. Ramya, are you there?
Yes, ma'am, I'm there.
Yeah, Dr. Ramya, she is a well-known person in terms of when it comes to academics, and she's MDS and she's completed her PhD, and she's an associate dean of extension activities and professor and head of department of oral biology, Savita Dental College. Ma'am is going to be talking or discussing about non-pharmacological adjuncts in orofacial pain management and institutional experience. So, ma'am, can you switch on your camera, please?
Yeah, sure. Yeah, can I start sharing?
Yeah, please. It's always lovely to have you on board, Doctor.
Thank you. Thank you so much.
Yeah, presenters mode. Slide share. Yeah, play.
Is it clear now?
Yeah, please go ahead, ma'am.
Okay, so are you able to hear my voice?
Yes, ma'am. The slides are also clear and voice is also audible.
Okay, perfect. So, thank you again, Dr. Nurul and Dr. Sonali. It was, I'm really grateful for such a wonderful opportunity in a very prestigious platform. I've been traveling with both of you, I think, for past 2-3 years, but this is a very special experience because it is related to orofacial pain, and pain has gathered a lot of interest in the recent times. So this is something which we feel that if given an opportunity, this is a very wonderful opportunity to speak about. I'm sorry, there's, yeah. So today's topic is mainly on this non-invasive and non-pharmacological therapies, which we shortly put it as an acronym as NINPT. And we've been hearing very big names, very big medicines for the past 2 days. And I'm very clearly giving a disclaimer that this particular presentation is not to undermine any of the statements which have been said below. This presentation is mainly to make all of you understand that there is a very important holistic approach to pain which is needed than anything else. I can see that there is a trend towards orofacial pain specialists mentioning the word holistic pain. And this is a kind of reiteration that is the most important statement. I'm sorry. Yeah. So if you really understand the definition of pain in a single word, it is multidimensional. And the perception or the understanding of pain has really improved over the years. And we are now in a very advanced time period where we really understand pain by multiple opportunities, and there are advanced neuroimaging techniques and so on. So, but still, if you would quickly summarize on all the presentations or most of the presentations or any literature related to facial pain, they would all be related to mostly pharmaceutic interventions. And it's not just to blame the therapists to opt only for pharmaceutical interventions. It is not that intention, but if the pain mechanisms are understood better at a very deeper level, then our perspective towards designing the treatment planning would entirely change. So this particular slide is all about what pain has to, I mean, what we need to know about pain. So the psychological.
Dr. Ramya, sorry to disturb you. You are still on the first slide.
Oh, I'm sorry.
Yeah, can you just change your slides?
Yes.
Is it seen?
Yeah, now it is there. Go ahead, doctor.
I'm sorry. Yeah. So pain is mainly biopsychosocial, and this every time you encounter a patient, the next second, even before asking the history about the illness, whatever, this particular Venn diagram is what every one of you should remember to get the complaints directly and to understand the multidimensionality of pain. So once you get that kind of approach, your therapeutics would be really very, very helpful. And I've been following this kind of management in my practice for almost now close to 2 decades. So why are we not recommending only conventional methods? Because obviously...
Ma'am, sorry to disturb again. The Venn diagram slide didn't come. Maybe you can go back and go on a presenter's mode. The play mode is not working because you're still on the conventional slide for us.
Okay, yeah. I'll do one thing, Sonal. Can I quickly convert it into a PDF and get back?
No, ma'am, don't do that. You can just go to, yeah. Once you're clicking on the play, right? What is happening is only that slide is visible. Yeah. Now this Venn diagram slide and all were not visible.
Yeah. Is it clear now?
Yeah, this is central sensitization slide.
Oh, it is not moving. Right. Okay.
Dr. Ramya, could you please share your slide through WhatsApp to us? Can we, run the slide from here if possible?
Yeah, I can do that. So give me a 2-minute break. I'll do that.
Okay.
No. This is a very beautiful lecture and we would not like to miss it. So everybody, please hold on for a few minutes and we'll get back on this. Dr. Ramya has been a part of our team since I think this must be our 4th conference together. And last year, this year itself, we had Pink Dental Congress, and the way she explained forget about it, the women brain has literally opened my husband's eyes, I would say. That I have started understanding him better, or he has started understanding me better. So it's all in the brain. That's what she explained it to us. So all the fights you husband and wives are having at home, it's all chemically related. You're designed to fight that way.
I'm actually very happy that Sonal, you remember a bit of it. It feels really good. So I do one thing. I'll quickly log out and come back.
Yes, please
Hold
do
on.
that.
Please apologize. Yeah, please.
No worries, ma'am. No apologies here. Yeah, I'll quickly tell you all about MedSkill and National Health Academy. We keep on organizing programs, and Dr. Nurul is the backbone behind it. We have, I think Dr. Nurul is organizing every quarterly. There is one or the other conference, right from sleep conference to he's conducted one conference for women. I mean, there are very few men who honor this kind of and keep a conference dedicated only for women. And that thing, I think we had a conference saying the theme was life beyond dentistry. And last conference Dr. Nurul had was for neurosurgeons, and one was for sleep medicine people. So it round the clock, National Health Academy is engaging into such learning platforms. So you all be in touch with the organizing team, and I'm sure you all will be benefited. We as dentists, we can and definitely improve our knowledge by attending such conferences. Next, we have Dr. Karpagavalli and Dr. Divya Kumar, and you are in for a treat here because they are going to be discussing about trigger point injections. So after Dr. Ramya, please, and I would say you all please have a working lunch like how I am having. So I doubt we have time for lunch breaks. Dr. Nurul, if we can accommodate lunch, let me know. But I'm sure we don't want to break the continuity. Working lunch would be better.
Yeah, of course. We have there is a one small slot 340 between 340
No,
to
no, no,
is
no, no. There is no slot, doctor.
actually
Don't do
between,
that.
but
Don't do
there
that.
is a would be a tea break at that time.
Yeah,
rather.
no, that will be also working high tea break. We will not want to break the continuity. So better that you all have a working lunch.
Dr. Ramya, if you facing this problem, if you are struggling, just share the your slides to
I'm
us.
actually trying to share. Meanwhile, if the other speakers are ready, they can please go ahead so that we can sort it out instead of wasting time.
Yeah,
Okay,
Dr.
okay.
Fine, I can wait. You can go ahead with the next speaker, please.
Okay, Dr. Karpagavalli, are you there? I'll just check if the next speaker is
Hi,
joined.
Dr. Sonal, but I just need some 5 minutes to.
5 minutes? Okay, ma'am. No problem. No problem. Yeah, take this as a lunch break itself, like, or maybe short 5 minutes break. So you all can join back. Not don't log out. Just have a lunch break, working lunch break. As I was telling all the audience who had joined earlier also, we have a goodie bag for the audience, and that once I realized that the participant who is attentive enough, asking questions and always present, will receive a goodie bag from my side. So please stay tuned and don't log off in between.
Yeah, Dr. Sonal
Done.
shared my presentation if possible. Like if Dr. Karpadaselvi is fine, I can complete, or else I can wait. Not a problem.
Okay.
Either way, it's fine.
Dr. Ramya can proceed, Sonal, and I'll do as per the order, like after Ramya.
Okay.
Yeah, thank you.
Dr. Nurul?
I'm trying to share Dr. Ramya's slide. Just hold on. My team is there. Yeah. Okay.
I have a question for audience. Can anyone list 4 systemic factors that can influence orofacial pain? And the winner who will answer this question first, all the 4 points, will also receive a goodie bag from my side. What are the systemic factors that can influence orofacial pain? I'll repeat the question.
Sonal?
Sorry. Yeah, you're there. Yeah, Dr. Ramya is back.
So,
yeah. Just a second. We'll take one more couple of minutes to get the slides on. So the question is, what are the factors that systemic factors that can influence orofacial pain? Dr. Tanvi, you're disqualified.
Yeah, ma'am, there are hormonal factors. We have multiple sclerosis.
Delete the, first of all, Dr. Ramya, Dr. Tanvi, delete your answer. I want the audience to answer this. And don't speak. I want it to be typed. And I want all 4 of them in one go. Don't write it as one single messages. I have to be strict, right? I have only few goodie bags. If I all become orofacial pain specialists, I'll have to keep giving away prizes like this.
Dr. Ramya, can I get your PPT, presentation PPT format you sent on a PDF, and I think it is not shareable. So could you please share
no,
the?
actually, you can share, but anyway, I'll quickly do it right now.
Okay, please. If you try, you can do it from your
Sure.
end.
Okay, Dr. Kajal. I want few more answers. Okay, Dr. Gayatri. What are four systemic factors that can influence orofacial pain? Dr. Komal. Okay, now we have Dr. Ramya's slide there.
Change हो रहा है.
Oh yeah, it's coming. I think this is getting time to attach. Dr. Nurul, we'll proceed with this.
Okay.
Dr. Ramya, I think you were there in that slide, no?
Exactly. Yes, sir. Yes, I think I can start with this.
Yeah, please.
Yeah,
Continue.
I'm extremely sorry for this delay. So yes, we were actually discussing about the conventional modalities that is using the pharmaceuticals. Yes, we don't deny, definitely we cannot get rid of them. You have to use it. The problem is when it comes to long-term use. So that is why this NINPT plays a very major role. Now, just as a single line, NINPT gives a very interesting diverse coverage on many aspects of what pain is already about. So it can give you a multi-dimensional approach, which pharmaceuticals will not give. So all the pharmaceutical agents which are currently available and are evidenced to very great heights definitely have some limitations, and they are only for short-term use, and long-term use is not possible. Next slide, please. Yeah. So this particular word is again something what you need to remember about the earlier picture, which I already said, that pain is multidimensional, and this one word is very, very important. So if you understand that any pain comes to you, or the perception is all about the central sensitization. And once you understand the basic of central sensitization, you will automatically give a treatment plan which will address this central sensitization and which will give a very broader treatment, and it would be a very big relief to the patient. So this is one important word which you must always remember. Next. Yes. And this is career development or personal upliftment or motivation. So once you really understand the master controller, you will understand what everything pain is all about. So yeah, this, of course, we are not people of neuroscience, but you should definitely, at least the basics are must to remember. And here you have to understand that among the other areas of pain perception and pain modulation, the chemicals involved and everything, the prefrontal cortex is the most important area which has a very significant effect on pain perception. And if you just go into slightly more in detail about the prefrontal cortex, it is everything what the cognition is all about. Cognition is the way you think and how you perceive everything around you. And that is entirely or mostly in the prefrontal cortex area. And that is why we created a very interesting study, which I'll be discussing later in the presentation. Next. Yeah. Again, this is quickly to tell you about NINPTs. They not only give a wholesome approach. There are some very important points to be taken from this particular slide. It helps in modification of the pain processing. How your brain processes the pain, that is possible to be controlled. And it also enhances, or it has the ability to dampen the activity of pain pathways without any unnecessary adverse medications. And the other interesting thing here about is the neurotransmitters. We have heard enough about all these pain-related neurotransmitters. We know more about serotonin, norepinephrine, and so on. All of them can be modulated by using NINPT. And more than all what we saw now, cortical plasticity is something, is a very interesting aspect of neuroscience as well. So the ability for the cortex to undergo changes, to modify itself or to adapt itself is something most of us do not tend to manipulate or do not tend to play with, mainly because I feel there is impatience from our side as a treatment provider, and there is impatience from the patient side as well. So there is so much which this NINPTs can offer. Next. Next slide, please. Yeah, thank you. So this particular data here is mainly from the studies which are conducted by my postgraduate student, Dr. Ramya Suresh. Again, there is a name similarity. The area of pain was actually not my cup of tea. My area of interests are very diverse and I'm into too many things. But every time a patient walks into my clinic, I tend to spend more time with them than for normal procedures, especially in case of atypical facial pains. I tend to spend more time, and that is mainly to address and find out that there is a emotional component which is coming out. And the moment the patient knows that you are willing to listen, they will definitely come out with so many things which is actually disturbing them. I'm not telling you to spend more time, and we know that your time is very, very precious. But unless you understand and pick that emotional thread which is linked to your atypical facial pain, believe me, your treatment is not going to be complete. So this was my perspective about pain for past 2 decades. I was not very curious to get into pain research as well, but this was all pain research which are currently happening at Oral Biology Department at Savita Dental College is mainly because of my PG student. And it was her interest and the inspiration which she took from Dr. Davis Thomas was the main reason that we started doing multiple approaches. And every time when she comes up with a proposal of newer topics, I would immediately bring her down to the ground level, and I would say that pain is multidimensional, and do not get carried away by fancy studies and people giving you very different kind of approaches, and that is becoming a rage and things like that. So it used to be a very big brainstorming every time we discuss about pain, and all these data are from her studies. So with the institutional data, which we already have at our college, we have a very big digital repository from the patients who walk into our outpatient department. We have around 3,500 average patients walking in daily. So overall, neuropathic orofacial pain, like any other literature, we also have found that it is very clearly more in females, and the 4th to 6th decade is more commonly affected. And put together all types of facial pains, trigeminal neuralgia was more common. Next. And this is again slightly more in depth about the disease patterns of temporomandibular joints, which has reported to us. And in this, again, these are not very different from the literature reports which are already existing, but all these data are from a very large cohort of patients which we have in our institution. And again, this also shows specifically to the TMDs. It has a female predilection, and here, if you see the younger age group is more commonly affected, which shows that the Gen Z is a group or a specific cohort which all of us needs to be aware of. We all know that how the entire thought process, the approaches, everything is different in this cohort of group patients, and we have to be very, very curious to know what drives their kind of thoughts and their perception about pain. So 18 to 25 years is what we commonly observed as far as TMDs is concerned, the group among TMDs. And masseter and temporalis were more commonly involved. And I'm sure the next speakers who are going to talk about trigger point injection would be addressing all this. Next slide. Yeah. And now into the interventions which we tested. So from the beginning of my 2-decade-old practice, I've been very, very particular that I will not be doing any kind of very interventional pharmacotherapeutics. And the same thing when I told my student who wanted to do her thesis on pain, she immediately agreed, and that is why we proposed ultrasound and therapy and an additional therapy for management of TM disorders. This ultrasound was specifically chosen because it had enough evidence of how much of effect it can have on pain. The more interesting aspect of ultrasound on pain is that it can give you, when we previously saw about the central sensitization, you can see the second line that it has a effect on almost everything. It can affect the inhibitory pathways, it can modulate the neurotransmitters, the neuropeptides, it can reduce inflammation, and above all, the word central sensitization, and stimulates tissue regeneration, which is something I would say is so nice to know. Non-invasive procedure, a non-invasive protocol, which is not going to do any harm to you. And if it's going to regenerate your tissues, that is something, a blessing to have with. So that is something which we took as an intervention. Next slide, please. Yeah. And the moment you hear about emotional component or the psychological component of pain, it's all about the master controller, the brain, and you can control the brain only by mindfulness-based interventions. Second, next slide, please. Yeah. And the moment we see this word, most of us do not tend to like it, mainly because it is very slow and it takes a lot of time to practice. And it doesn't give you that a very high feel of what inpatient mind is seeking. So that is a disadvantage of not benefiting from this treasure. I would say this is actually a treasure. And coming back to the master controller, which I was already speaking about, prefrontal cortex is the most important primary area for how your pain is being perceived. And we took a procedure from, took a technique from yoga, which has a direct effect on the prefrontal cortex. Next slide, please. Yeah. So this was the study which was done in our institution and as a thesis of my postgraduate student. I'm not going into the detail because this is still unpublished. So the two interventions which we used was a yoga technique and ultrasound. Both were used as a separate groups, and they were together, brought together with a combination also. And these were done in a specific cohort of myogenic temporomandibular joint disorders. We narrowed down on myogenic temporomandibular joint disorders with consensus from Davis Thomas sir, and sir is a co-guide for this particular study. And if you see the results of this particular study, it is a very interesting output what we got. So the temporalis and masseter were the predominantly affected muscles, and we saw that temporalis were even more affected. Of course, this is a smaller cohort, but still smaller but very specific cohort. And then comes the masseter and lateral pterygoid. Most of the times when we read about facial pain, we tend to remember lateral pterygoids more. And now you can see that the tendency for, or the pattern for presentation is slightly different here. Well, lateral pterygoid is there, but the predominant or the prevalent group is, as far as muscle commonality, is more related to temporalis and masseter. And site of pain, of course, all of us know it's more commonly on the left side. And these are the groups, and there is a specific mention about the method here. In addition to ultrasound therapy, we have mentioned the name of the yoga therapy. This yoga therapy, I've been practicing this for quite some time in my own life. And you believe me, it will relieve you of stress within a few seconds. I'm not talking about any magic here. It actually works, because the moment your tongue is lifted and it touches the junction of hard and soft palate, it immediately calms the prefrontal cortex. And now you can link where I'm bringing this perception to. As you roll and then press, the prefrontal cortex calms down. So there was a very interesting finding. Next slide, sir. And we found a drastic improvement in the way the pain perception was done. We also conducted it with a lot of anxiety scales, and everything were very, very positive, especially in combination groups where there was ultrasound and the yoga therapy brought together. So that group was found to be the most significantly promising group. Next slide, sir. So why is this being again said is, this Venn diagram which I was talking to here is always imagine to always or follow a holistic approach. And only when you follow a holistic approach, all your treatment aspects will work. Whether it is going to be putting them on a very strong opioid or a very strong NSAID, or whether you're going to give a trigger point injection, all of them are excellent to give immediate relief to the patient. Yes, we do fully agree. That is what the patient is there for you. But that will, for that, all your treatments to have a long-term effect, please address the emotional and the psychological component of pain, and then you would really become very good pain therapists. And that is the main concluding take-home message of my presentation. And we have proven this statement by doing a proper controlled randomized control trial. Next slide, please. Next slide, please. Yeah. With due regards to Nurul and Sonal for having me again here, I'm really honored and I'm privileged to be in your team. And thank you so much for making me here. And I feel I have given a very small, important thing which the young minds should follow when you are treating a patient with pain. And special thanks to my postgraduate student and the faculty and postgraduates of the Department of Oral Biology. Thank you.
Thank you, ma'am. Thank you so much. And it's always a pleasure. That's what I say, that, your insights are really heartwarming because, yeah, what you said, the emotional part of it is what is missed in our practice. Like at times we are just mechanically administering the patients are treated with medicines and whatnot, therapies and all. But understanding them, the pain condition is more important than anything else. Doctor, there are certain questions. Can we ask you a few questions?
Yeah, please go ahead.
Dr. Sandeep, congratulations. You are receiving a goodie bag from me. But his question is, what is your take on laser physiotherapy? Laser and physiotherapy it should be. And how long do you advise ultrasounds?
Yeah, ultrasound, we did it for a period of 3 months. And we did it for 10 minutes per day for a period of 3 months.
And what is this? What is your take on laser physiotherapy?
Yeah, laser physiotherapy, actually, well, physiotherapy, yes, it will definitely work. I'm not very sure, or I've not read any evidence-based proof about laser physiotherapy. Plain regular physiotherapy for modulating the muscles, yes, it definitely works. I'm not sure because I've not read literature supporting laser physiotherapy.
And Dr. Naman has to ask you, what specific yoga poses or pranayams do you recommend for TMD patients? Yeah.
Yeah, so the TMD patients which we followed was the Kechari Mudra, which will immediately calm down your prefrontal cortex. And the second, which I have done it myself and I usually teach to my student, is called as Brahmari Pranayama. It's called a bee buzz, where you try to close all your senses and then you do a hum like a bee. And that again immediately controls the entire brain. It makes it very calm and soothing. And that again improves your cognitive levels to a great degree. And the pain perception would definitely improve.
Yes. And Dr. Abhay has raised his hand. Dr. Abhay, are you there?
Yes.
Yeah, tell me.
Yeah. Good afternoon. Madam, I wanted to ask complementary and alternative treatment for the same TMDs and all this. And if at all you believe in that, which pathy do you have a trust on it?
Yeah, my generally, not only for TMDs, I deeply believe on naturopathy than any other pathies, because I feel it's all about lifestyle, and having a very clean lifestyle and clean food habits would really keep you in best of health. That is my perspective again. And
Okay.
all the other group of alternative medicines involve some kind of chemicals to be taken. So I would rate naturopathy as the best, and then others come. Again, it's a disclaimer that I'm not trying to put anything down. Considering
Yeah.
patient,
It's your
always
mistake.
have a
Well,
multidimensional approach. Utilize the best of all the practices. And being in India, I feel we are the most blessed to know about more practices than any other part of the world.
okay. Now, the thing is that would you recommend this as your first line of a treatment, or after trying our conventional treatments, if the treatment doesn't respond? I
That's an
mean,
excellent
this is the
question. Yeah, that's an
if it-
excellent question. And I'm sure this would be going in all the speakers' mind as well. Yeah, definitely not as a first line of treatment, but the moment I'm giving the first line of treatment, parallelly, I would advise this to all my patients. And this is
okay.
what I've been doing for past 2 decades, and I've been really finding it very, very effective. Especially the mudra therapy. It's what I've been following it for a very long time.
Okay. Okay. Thank you. Thank you.
Ma'am, what is your benefit? What do you feel are the benefits of low-level laser therapy?
Yeah, low-level lasers and the laser physiotherapy, which you said, definitely will have some reduction on the inflammation, what is there at the tissue level. Being an oral biologist myself, the neuroinflammation is something the lasers will definitely have a control on. But that alone may not be enough.
It's an adjunct to the therapy.
Exactly, yes.
Yeah, there is one more question I wanted to ask, if the time permits.
Yeah, last question, sir.
Yeah. Madam, you said about oral biology. Can you little bit highlight on what exactly this specialty is and where all exactly it is dealing with?
Okay, sir. Actually, I would, I'll take your number from Nurul, and that's a very big specialty by itself. We are having a separate department at our institution. I can talk to you about everything what we are doing. In a single line, oral bio is like a foundational subject to the field of dentistry.
Very much, very
Please
much.
do reply me for the same. Okay.
Yeah,
I'll be
my
waiting.
pleasure, sir. My pleasure. I'll contact
And
you.
one more participant's question is, ma'am, I would like to ask if this ultrasound therapy also used for peripheral pain in orofacial pain.
Yes, it will definitely help. It will definitely help. All peripheral pain, whether you categorize into giving them different names, peripheral pain can be very easily handled by ultrasound.
Okay, great. Thank you, ma'am, and thank you for this really enlightening lecture. And I'm so surprised that even if it's a lunch hour, everybody's still stuck with and eager to listen to you. And thank you, audience. And any other further questions will be answered in chat section. So, ma'am, if you can hold on for some time, you can just answer in chat section if you wish to.
Yes, sure.
And I would like you to wait and attend the other lectures and guide me also on the same. Thank you so much, ma'am. Thank you. Yeah.
Thank you.
Do we have Dr. Karpagavalli now? Hello, Dr. Karpagavalli. Dr. Valli, are you there?
Yes, Dr. Sonal, I'm here.
Yes. Yeah. Nice, lovely background, doctor.
Yes.
I couldn't do it.
Sorry,
Okay.
last minute I had to call Nurul and tell please send it.
Wonderful. Okay, now again one more stalwart from Seema Dental College, and if I have to read her bio, I think I will need one more session on the same. So in brief, very short bio, and of course there is much more to Dr. Valli's profile. Dr. Karpagavalli, as we all know her, she has completed her MDS and she is professor and head of Department of Oral Medicine and Radiology, Seema Dental College and Hospital at Rishikesh, Uttarakhand. One of my favorite places to be, ma'am. If a retirement plan is planned, that would be definitely Rishikesh.
You should welcome. You're welcome all the time.
Yes, so she is there since September 2018. And I mean, I really envy you. You're living in heaven right now. Ma'am, would you like to share your screen, ma'am? Welcome to International Orofacial Pain Congress.
Thank you. I think my screen is visible.
Yes, ma'am. Yes.
I'm audible.
Yeah, you're audible, and you can go to the presenters mode. Yes, ma'am. Stage is all yours.
It shows admit. Should I do anything on that?
Ma'am, just continue with your lecture. Ignore the admit part. This is the heaven I was saying. Ma'am, your slides again have... Ma'am, it was visible earlier. What have you done now? Okay. Yeah. Ma'am, your mic is muted.
Sorry about that. Good afternoon, everyone. And sorry to take up the lunch hour, actually, of everybody. And thanks to the entire team of Dr. Noorul and Dr. Sonal. And thank you all for giving me this opportunity. And it's a wonderful sessions which are going on from yesterday, though I'm not able to actively listen to it. And I would love to do that. And actually, I'm really committed with the international conference which we are conducting in Rishikesh from 13th to 15th on forensic odontology. And I would really welcome all of you. Whoever is interested could attend it both on virtual as well on physical mode. And this is an opportunity for Dr. Sonal to visit us. And it's a short notice, but still, I think all of you are welcome. And coming on to today's topic, warm greetings from Devbhoomi Rishikesh and Seema Dental College and Hospital. I would go on to today's topic, that is the potency of trigger point injections in the management of myofascial pain. So all of that, you must have heard a lot of infos on orofacial pain from most of my batchmates and colleagues and even from our mentor. And this is something which is very, very important in a dentist life, I would say, which even as an oral medicine person, I didn't give too much of importance into that part of pain aspect. We always think it's always TM joint and it's the temporomandibular disc and it's a disc displacement or it's something to do with the teeth. So non-odontogenic pain, which is especially the myofascial pain, is one of a very important thing. That's why I've chosen this topic. And I have started doing like n number of trigger point injections. And I would say that I'm going to give the real relief what my patients said, not just there are some places where it's not 100% relief also, but I would let you know. And it is all a combination modality. And following me, you have a wonderful speaker from our batch, Dr. Divya, who's going to tell the advanced aspect of what we are doing, that is the trigger point injections. So a small intro, I think I won't go much into it. You all know what is orofacial pain. It's a very important field of dentistry. And the most important part in our field is diagnosis and management of the chronic complex facial pain and oromotor disorders. So this is a definition. I will share the PDF of my presentation to the organizers. So anybody interested in academics can also be benefited by it. The most important thing all of us have to remember, which was told by Weldon Bell, that assume that it is dental until proven. Otherwise, then muscular until proven otherwise. So the first pain is always a dental pain. If you're not able to prove it's dental, then always think it is muscular. Don't just jump into neuralgias and all the weird ones. We should still go in the order of dental, or that is odontogenic, followed by muscular. The sources of non-odontogenic toothaches, I think you must have had some talks on that. The most important part is myofascial pain, which is the commonest one, followed by neuropathic, neurovascular, and pain from other structures. This is a classification of the temporomandibular joint disorders from the DCT and TMD. And I think most of the speakers would have told you about it. The major classification goes from temporomandibular joint disorders, in which you have the joint pain, the joint disorders, then the joint diseases, and the fractures, congenital disorders. And the most important part, which we are going to talk today, is the muscle pain. And if you see in the muscle pain, we have myalgias, in which you have the local myalgia, the myofascial pain, and the myofascial pain with reference. This is the DCTMD, which I was talking to you about. This is a diagnostic criteria, which was earlier called as the research diagnostic criteria, RDCTMD, and now it's confined as DCTMD, in which you have certain descriptions for every pain. So in the myofascial pain, you have descriptions of where the pain has to come from, how the history has to be on examination, what are the things that should be present, and how the validity, that the sensitivity and specificity, and finally, what is that we have to be done. So I'm not going to go in depth with it, but you should all be aware that a patient should have a pain from a muscular origin, okay, which is usually myalgia. The pain can be at its site or it can spread beyond the site of palpation. That is one important point. The history should say pain in the jaw, temple, in the ear, or in front of the ear, and the pain can be modified by jaw movements or by any functions or parafunctions. Now, the most thing is on examination, patient should have positivity for either confirmation of the local palpation, which we call it as tender points, which could be in any of the muscles of mastication, or it could be trigger point, that is you palpate at one pain and the pain is radiating at another spot. So this is, you always have to make sure that you elicit the familiar pain. So that is your duty, that you make sure that you elicit the familiar pain. Going on to the myofascial pain with referral, the most important thing, it's all the same in the history. In examination part, you have to confirm by the pain location, if it could be in the temporalis or the muscle. The patient would be complaining of pain in a tooth. So the tooth could be the patient where it says, but you will be able to reproduce this familiar pain by palpating the muscles. So this is one of the things which is myofascial pain with referral. So I'm not going to go into depth of all this. You need to know that myofascial pain usually has, this is a picture which shows the muscles. This is the normal muscle, okay? And here you can see the shortened sarcomeres, and here you have the long sarcomeres. So this is where you have the trigger point region, okay, because of the shortening of the sarcomeres. So what does the patient complain of? Intermittent dull aching pain. It is usually unilateral, limited mouth opening, tenderness in one or more muscles of mastications, pain sometimes in the neck and shoulders, and the patient can also give history of headaches, earaches, tinnitus in the ear, there is ringing of the ear. Frequent history of tooth clenching and grinding could be there, and pains can increase with stress and function. There is something called jump sign, which you should all be aware of, which we sometimes call it as latent twitch response. That is, confirms on firm palpation of a trigger point. When you palpate on the muzzle, the patient just jumps out of you or moves out of your finger. So that's called that is a latent trigger point, in which LTR it is called, and it is in which you elicit the jump sign. And there is also a twitch response, which is a rapid contractile motor effect elicited by snapping palpation of a taut band at the location of the trigger point. So what is this? We are all talking about trigger point, trigger point. Everybody keeps telling this word, trigger point injections or trigger point. So as per AASP, the trigger point is characteristically elicits referred pain when stimulated. So when I stimulate a trigger point, the pain is felt in a different region. That is the referred pain. The clinical definition goes as it is the palpable nodule in a taut band on compression, referred tenderness with motor dysfunction and autonomic phenomenon. So it has three components: sensory, motor, and autonomic features. The etiological dysfunction is that this occurs because of the dysfunctional motor end plate in the skeletal muscles. All of you know that there is a motor end plate. I'm not going to go into the physiology of it, where the acetylcholine is the neurotransmitter secreted at it, which helps in this functioning. So there is a dysfunction at that point. So that is, they say that this could be the etiological definition. So what are the types of trigger points or the myofascial trigger points? You have an active trigger point and you also have a latent trigger point. So the active trigger point is something which the patient complains to you with. The patient comes to you with that pain. Okay, there is an LTR, which is the local twitch response, and there is also a referred motor phenomena. What is a latent trigger point? A latent trigger point is the patient is not aware of the trigger point. It's a clinically quiescent trigger point. And when you palpate, patient says that that region is painful. So painful only when palpated. So characteristic features of a myofascial trigger points: localized area of tender nodules, tight palpable bands of muscle. Pain intensifies when there is palpation on the trigger point, and the area to which pain is referred is known as the zone of reference. And this zone is not in continuity with the region. It is usually distant from the involved muscle. So you should know the trigger point referrals. I would all advise that all of you at the end of the course, I will really highlight it that this knowledge is given to us, to most of us, I would say, from the fellowship that we have all completed from Smile USA under the mentorship of Dr. T, that is the Davis Thomas sir. And after that only I really saw this diagram, though I'm an oral medicine specialist. Now my PGs learn it, but it's not that all of us are aware of it. So I feel as dentists, this picture should be in all our clinical setup. We should know that the teeth can be, the muscles can refer that pain into the teeth. So it is very, very important that we don't start going ahead doing root canal treatments or extractions when somebody points out the pain at a premolar or a mandibular molar region. So the trigger point referrals from a masseter muscle is the trigger points is located in the site of the superficial muscle, then it could refer to the posterior mandibular and maxillary teeth, the jaw and the face. If it is from the deep masseter muscle, it refers to the ear and the temporomandibular joint area. That is the preauricular area in front of the ears, tragus. The temporalis muscle, as you could see that this is the temporalis, it has an anatomical distribution of referral. The anterior temporalis refers to the maxillary anterior teeth, the mid-temporalis to the middle teeth, and the posterior temporalis to the posterior teeth. So it follows an anatomical distribution. And in this, most commonly, the patient will come to you with a headache and a toothache. So don't start thinking it's migraine. Then it's the medial pterygoid muscle, the referral zones for medial pterygoid, the posterior part of the mouth and the throat as well. Somebody will say that they have a pain in the throat or they keep clearing the throat as well, and in the temporomandibular joint. And usually the patient complains of pain in the infraauricular area, just behind here, in this region. Many patients come to me with pain in this region, in the infraauricular ears. So this could be referral from the medial pterygoid muscle. Coming to the lateral pterygoid, which has two heads, that is the superior lateral pterygoid and the inferior lateral pterygoid muscle. The inferior lateral pterygoid muscle usually refers to the TM joint. So we start thinking it is TM joint, the disc and this and that, but finally it could be the inferior lateral pterygoid muscle. The superior lateral pterygoid muscle usually refers pain to the zygomatic area. So don't confuse it with a sinusitis or a pain from the dental origin of the maxillary teeth. You should also know about the infrahyoid muscles and the neck muscles. So coming to the sternocleidoid mastoid, so you all know that you have a sternal and a clavicular head. Okay. So the referral zone from the superficial sternal division of the sternocleidoid muscle goes to the entire face and the head. So this is the head. It goes even to the vertex. So you can see, and to the entire face. So this is the referral for the superficial sternal division. And for the deep clavicular division, okay, this is the inner part, which is the clavicular division. So from the clavicular division, it goes to the ear. Patient can complain of ear pain. Okay, he would have visited multiple ENT surgeons also. He could complain in the mastoid region, that is post-auricular area, and also in front of the ear like a frontal sinusitis. So this could all be from the trigger point from a sternocleidomastoid muscle. Coming to the trapezius. So this is one of the shoulder muscles, and it is a upper traps, the traps muscle. It always gives very severe pain. The referral zone of the trigger points in the upper part of the trapezius, that's the upper traps, is along the posterolateral part of the neck, the post-auricular area, the mandibular angle, and the temple. So somebody would say that he's having a pain in this region, or it could be the temple. So it's like a question mark. If you see, this is an invert. Usually we write the question mark like this. This is a reverse question mark. Okay. And this could be the trigger point placed in the trapezius muscle. Lastly, I think I missed the picture of the what is that, the trigger points from the into the anterior mandibular division. That is a tooth of the mandibular anterior teeth. Okay, so from the infrahyoid muscle, that is the anterior and posterior belly of the digastric, especially the anterior belly of the digastric, the pain is usually referred into the mandibular front teeth, that is the anterior teeth, central incisors and lateral incisors. So going on to, I would not say trigger point is the only source of management of a trigger point or the myofascial pain. First of all, you have to rule out systemic. you need to do a proper myalgia protocol. You have to go in for all the investigations. You have to have a proper evaluation. And we take a detailed case sheet for almost 1 hour with 15 pages taught to us by our mentor. So all these has to be completed. And when you are sure that you are dealing with the myofascial pain, I would say one of the best source of management is trigger point injections. But a combination modality with physical therapy is always essential. Okay, just don't keep giving this what do you call the therapeutic medications, like dosing the patient with a lot of muscle relaxants, all that doesn't help. It's all temporary relief. So go in for trigger point injections. But the most important thing, again, I say you have to be 100% sure about the diagnosis that you are dealing with the myofascial pain. So then you can go for muscle injections. These muscle injections not only act as therapeutic, but it also acts as a diagnostic block test. So when you give an injection into the muscle, that is the source of pain, the patient should be totally relieved of the familiar pain. So if a person is complaining to you of a pain in the premolar tooth, maxillary premolar tooth, and you have given a trigger point injection into the middle temporalis, and if the pain in the tooth has completely gone, then it means you can be sure of the diagnosis. So it acts as a diagnostic modality also, this trigger point injections, and it is mainly indicated in myofascial pain, especially myofascial pain with referrals. So what is the procedure of a trigger point injections? The most important thing is to locate the trigger point, that is the local twitch response. Okay, most of the time you will be able to locate the trigger point. Then, so in other words, you are able to reproduce the familiar pain. Place the finger over the muscle. Okay, apply firm pressure to locate the tight bond. Then you have to insert the needle into the tissue and deposit a solution. So this injection can also be done by dry needling as well as wet needling. I always prefer to go by wet needling, wherein I use local anesthetic agents. And I always, before I start doing it, I am 100% sure of my diagnosis. I make sure it is the right diagnosis. I go through all the investigations, the myalgia protocols. And then when I'm confirmed of it, then I start explaining the patient about the management protocol. And we have to make sure that you cover the patient's eyes with goggles, the ears. Also, you clean the surface with betadine and also with saline. And then you start the procedure. Before starting the procedure, explain the procedure to the patient, and then you go ahead. And the most important thing, I'm going to show you this is my institutional experience as I work in Seema Dental College. These are the cases which I have started doing here. And routinely, we do trigger point injections. And I'm honored to even say that my mentor had been here, and we had a lot of cases piled up, and we even did some treatments of trigger point injections by my Dr. T over here with many patients, and they were benefited by his presence. And one of the most important thing I would like to say before I start showing my cases is, don't just start doing this tomorrow or today in your clinics, please. This is not something to be started just like that. You have to know the science behind it. Without knowing the science behind it, just don't start exploring these things just because you have attended a 20 or 25 minutes lecture on trigger point injections. Okay. Even today, I'm still on the learning curve. After almost 25 years of experience, still I keep learning. And I still feel that if I have doubt, I can call my mentor. So Smile USA with the fellowship is handholds us throughout our life. And I feel that we should be a part of it. And I always say that we should make us more educational and equipped before we explore into something. I would never like to explore something without having the knowledge in that field. So I always recommend the same to all of you. So these are some of the ways in which the trigger point injections are given. These are all available on net. So if you see, this is how the textbook says that you need to give the trigger point injections. But how many of you know to locate the muscle rightly? How many of you know to palpate the muscle, masseter or the temporalis or the SCM or the trapezius or the posterior cervicalis or the suboccipitalis? So how many of us are well equipped in doing it? Yes, we are all equipped because we went through the 150 hours and another 300 hours. We had rigorous training of almost 450 to 500 hours by Dr. T and his team. So these are my case series, which are all my personal experiences, which I'm sharing here. So a patient of 28 years old, Manisha Yadav, came to us with complaint of pain in front of the right side of the ear for past 2 years. History revealed that the pain was there for 2 years. It was sudden in onset, dull to moderate and severe. And we could say a visual VAS score was around 7 on 10, and it was aggravated on functional movements, that is chewing, eating, and all that. Patient had visited multiple doctors, and she also had visited AIMS, and she was prescribed analgesics, NSAIDs, piroxicam. Nothing gave her permanent relief, and it was all temporary relief. She had even gone for wearing a night guard for 1 year, but still she felt that her pain was not fine, and she reported to me. So I have a method I was taught a method, and now I regularly use it, a mnemonics, which we call it as Dr. T mnemonics for evaluating the pain, okay, which goes with onset, was sudden in onset, and location front of the ear. The chronicity is 2 years. The frequency is intermittent because of it gets only on yawning and chewing, hard foods. The VAS score was around 7 on 10. The quality of pain was dull. The temporal characteristics was chronic, non-progressive. There was aggravating factors of chewing, opening the mouth wide. Relieving factors is only temporary relief with the medicines. That's the treatment response. There was no associated features and no radiation and referral, and her sleep was normal. So this is the way in which we evaluate the patient's myofascial pain. We have a TMJ evaluation. We see the mouth opening. We have the lateral excursions. We also go in for joint palpation. We palpate the lateral pole, the posterior pole. We also see if there is any swelling or pain during that. We also go for detailed muscle evaluation of both the sides. After doing all this, it was diagnosed as right TMJ synovitis capsulitis with myofascial tender points on the right superficial masseter. And we decided to give myofascial trigger point injections in the right superficial masseter. So this is a patient. And she underwent. So this is how we proceed with her. And this is what we did. With plain LA, I usually use plain LA, and we had given for almost 3/4 of a capsule to her into the masseter after locating the trigger point. So the trigger point injection was given in the right superficial masseter. And I would like to say, luckily, this patient had complete relief after the first injection. But it's not always like that. Okay, there are patients which, along with it, I also give some physical therapy. I ask the patient to do some mouth opening exercises as well. And also I give some topical analgesic followed by hot and cold fermentations. So, but I would like to emphasize that there is no specific cookbook to go ahead with it. Okay, so you need to, it depends with every patient, it varies. So this patient, I had complete relief with the single injections, but there are patients where I had to repeat the injections for every week for 3 weeks. So it all depends on patient to patient. And this is another patient of 24 years old who was a student from my own college, and she complained of pain in the side of the left side of front ear and also in the left forehead region. And she also complained of some clicking noise. She was not bothered of the noise, but when the pain started, she reported to us. So after going through her, she experienced pain and the clicking noise. And after evaluating her, she also complained of hyperacusis, and she had dizziness due to pain, and she had difficulty. So you can see there are some autonomic features also here. And her pain VAS score was 9 on 10. And I would like to say that I even presented this case to my mentor and got his opinion on it, and then proceeded with it because she is my student also. So I wanted to be doubly careful about it. And if you see, this patient had difficulty in sleeping, and the pain radiating was there to the left forehead and backward of head region. And the VAS score is 9 on 10. So after doing the mnemonics and after evaluating, we came to a diagnosis that the patient had capsulitis synovitis with trigger points that is, she had trigger point with myofascial pain with referral in masseter, temporalis, and SCM. She also has ADD with reduction, but that is not something to be worried about. You all know that ADD with reduction is anterior disc displacement with reduction. But she had it for 2 years, and that is not her worry. Her worry was her dizziness, the pain in the ears. So all the autonomic features and the pain going very high and excruciating, which she is not able to tolerate. So this was a patient with myofascial pain with referral, in which we had to give multiple trigger points in multiple muscles. And this patient, I could bring her VAS score from 9 to 4 on 10. So as I also told you, everybody doesn't go to 0, okay? So make sure when you are dealing with chronic pain patients, don't tell them you are completely going to make them relief of pain. You are not treating them, you are managing that pain. So pain management is only done, and it is only going to be to the level of feasible by us. Don't give them high hopes, and don't just extend your odds by saying that, okay, tomorrow you after my trigger point injection, you are going to be totally pain free. No, I never tell any of my patients like that. So make it very clear to them. We are trying to manage that pain, and for what they are suffering for years together, you cannot make it okay in just a 5-minute or 10-minute trigger point injections. So this patient had multiple injections at multiple muscles, masseter, temporalis, and the SCM. And we could bring her VAS score to 4 on 10. And she was happy with it. And she could at least the tinnitus, the dizziness, the pain in the ears, and had all gone down. But we had to give her multiple injections, and we also combined it with some physiotherapy. This is a 22-year-old male who was also a student who was from a local region, but he complained of pain in the left side of the jaw, 4 to 5 months. And he was having a VAS score of 8 on 10. As I told, he also had a clicking on TMJ mouth opening and closing, which he was not worried about. His worry was over the pain in the jaw on opening the mouth. So as usual, I did the pain mnemonics. And since the VAS score was 8 on 10, and I went ahead with the TMJ evaluation, and you can see on muscle palpation, he had posterior temporalis was 2, and the lateral pterygoid was also tender. Okay, and on pole, the lateral pole was tender. So myofascial pain with trigger points was there, and also there was pain in the masseter. So trigger point injections was given initially on masseter and later on the temporalis, and there was also trigger point injections given intraorally in the temporalis tendinitis. So this patient also, after the first injection, he had a reduction of 4 on 10. For this patient, I had to also combine this with stabilization splint and also thumb tense, following which he was completely relieved of pain. Then this is Vishal, who is a school student, who was 24 years old boy, who complained of pain in the left side of the ear and left forehead region, followed by the clicking noise. So this is the patient's VAS score was 7 on 10. Okay. And he said that he developed this following a punch into the right lower region. And his VAS score, after evaluating him, if you can see, he had the diagnosis what moderate synovitis and capsulitis with myofascial pain in the left masseter and the SCM. So trigger point injections was advocated. So we had given injections in the masseter and also in the SCM. You need to be very careful when you're giving trigger point injections. We don't even get to start doing it after our first module. We wait to learn the entire science behind it, the theory behind it, and around our third module, we start learning to do this hands-on. So I would again say that just looking at these pictures, don't start poking your needle into the neck. Remember, there is a internal jugular vein, there is an external carotid artery, and you could end up doing worse things to the patient from a muscle pain. So please don't do that. And also with the upper traps, you have the upper pole of the lung. If you puncture it, it is going to be irreversible damage, and it will end up in even death of the patient. So you need to be really careful. Sometimes with the masseter injection, patients can develop transient facial palsy. You need to warn the patient of all those things. You should have a consent. Luckily, till now, I have not gone through any complications. The reason behind which is I got myself trained. I got myself very confident about, and that is when I started doing these things. And I'm not shameful to say that I have not done this even after my MDS or till I became a professor or a HOD. There's nothing wrong in it. We all have to keep learning it. So I'm proud of it to say that I have learned it in the right way, and I'm doing it in the best way possible. So this patient had a complete relief from 8 to 2 on 10 in the next sitting. So there's another patient who's Poonam Devi, 32-year-old who complained of pain in the right side of the ear and neck. So this again goes the history and the pain mnemonics. So on evaluation, you can see she has pain in the anterior temporalis. She had pain in the styloid area, the SCM, the posterior cervicalis, and also her medial pterygoid was painful, the trapezius bilaterally and lateral pterygoid. So she has almost like a regional myalgia, okay, and myofascial pain in all this muscle. So she again went for multiple muscle trigger point injections and also multiple sitting. I think she had to come for 3 visits, and this is her right anterior temporalis and her right superficial muscle, the injections being given. And also she underwent in right upper traps, the right SCM. And following all these injections, her pain score went to 3 on 10. So this is another patient who's 18 years old. She also had complaint of pain in the right in front of the ear since 2 months. So all these patients come to us with TMJ pain. So what do? We start scanning them. We start giving them all kinds of doing some jaw, occlusions and changing their occlusion or putting something on their, giving some appliances. So before doing all this, diagnosis is a very important thing. So that I think a lot of people has emphasized to you people that diagnosis is very, very important. So it's an art. All of us have to learn the art of diagnosis, which is very, very important, and the art of diagnosing orofacial pain. So this patient, again on palpation, is a patient who had anterior temporalis, superficial masseter, the styloid region here, the trapezius, and also the lateral pterygoid. So though this patient had ADD with reduction, which is not a very, for which you don't have to do anything, okay? So if somebody comes with a painless click, don't do anything. Just make the patient aware of him and just you can ask the patient to go back home happily, because many of us have sounds coming up from the joint, which is painless. So then you had, but the patient had a myofascial pain with trigger points in the superficial masseter, temporalis, traps, and temporalis tendonitis as well. So we had to give multiple injections along with the intraoral injection also. So the patient pass score came to 2 on 10. And this is the temporalis tendon, which was severely painful. And following the injection, the patient had excellent relief because we had given injection in the temporalis tendon, which causes the tendonitis. So you have a tenacious tendon of the temporalis coming down below the zygomatic arch over there. So you should know the correct spot. Where do you give these injections? How do you do it? So this is another case of 20 years old patient, one strike, who was also a student, complained of pain in the left side of the ear, 4 to 5 months. He just recently visited me for some dental pain and he's so happy because he came with the pain of 9 on 10. Okay, going to multiple dentists, taking various treatments, putting ibuprofen and various other pills inside with no permanent relief. So we had done a detailed case sheet on him. We had examined him. So we had found where, we had marked where and all his painful muscles were. Okay. And then we started treating with trigger point injections. We didn't do anything because one of my postgraduate students does a thesis. We are trying to evaluate or compare how the patient feels with pain management without any therapeutics. We don't give any therapeutic medicine. We isolatedly, we are doing based on, it's an RCT study. So we have a group of patients who's given only trigger point injections. And we have other 2 groups who's only given TENS and 1 patient who's only given ultrasound. So this is a study, ongoing study. We still are yet to come out with the results and we'll be publishing it as well. So we want to compare. I would also like to do a combination group, which I will go on. So I want to compare to see whether the individual works well. And right now, our evaluation with the pilot study is that the trigger point injection gives the best, even though if it's an isolated trigger point, without giving any therapeutics or any other modality of physiotherapy, isolated trigger point injections give very good results as compared to TENS and ultrasounds. So this patient again had left superficial masseter injection, upper head of SCM, and also in the temporalis tendon, and the pain score had come to 4 on 10. There's another patient from Roorkee, 56-year-old female, complaining of pain in the right ear for 6 months. Again, the detailed evaluation was done, and the patient had visited multiple doctors with no much relief. And when we evaluated, the patient had pain in the superficial masseter muscle and the temporalis tendon. So the pain was quite severe. So on injections, we gave injection. This is the injection which is being given into the patient into the upper traps. As I told you, we need to be really careful because of the complications. Then the patient also underwent injection in the right superficial masseter and also in the SCM. And patient had very good relief. So this is a patient from Haridwar, again 50-year-old patient, Madhuri Sharma, complaining of pain in the left side of the jaw for almost 9 months. Patient has gone for extraction on the same side and gone to doctors, but taken various medications. And finally, she ended up. Nowadays, I get a lot of orofacial pain patients because of referrals. I'm really happy and privileged to say this, and I'm thankful to my mentor. And this is again the evaluation, detailed evaluation, which I do. I really take 1 hour in seeing a myofascial patient, in seeing any orofacial pain cases. Though I don't charge the patient because I'm in an institution, okay, but I do minimal charges and I give the best to the patient even if it comes to my institute. And I'm really happy to say that, and I have very good patient satisfaction and also my satisfaction. At the end of the day, my conscience is really very happy that I'm doing something good to the patient who has been going around with the chronic facial pain. So this patient also had myofascial pain with left superficial masseter pain, and injection was given in the muscle. And following the injection in the left superficial masseter, the patient was totally relieved of pain. So what I would like to say, these are only little samples of the cases which we are doing here. We have a wide range of patients. I have just confined myself to myofascial trigger points because my topic is that. But I am seeing a wide range of orofacial patient cases. Maybe the eyes does not see what the mind does not know. It's the proverb which I would definitely go by. So now I would say that my knowledge level has definitely increased far bounds, and I am able to see every patient with what their main complaint is. I would never say that a patient is just faking pain or she's psychologically not okay. She's a patient sending them to psychiatric treatment. I would never say that now because I know that patients do really have pain. We are the ones who don't know to diagnose it. Okay. So we should not feel ashamed to say that we don't know. That's what is my concept. If something I don't know, I would like to learn it. Let it be from my students or from senior people or junior staffs. I have no issues in it. So it's all a learning curve, and science is something till we die, we have to keep learning. And I would tell you, all of you, one takeaway message from my talk for today would be that you all as dentists, just don't confine yourself to dentistry. There is something beyond dentistry which will awaken you. And I think my next colleague and my best friend and a good friend and my batchmate from mastership, she is going to open your eyes still further because she's an orthodontist. Okay, I am an oral medicine, so you all will say, okay, you're an oral medicine specialist, so you're talking like this. No, she's an orthodontist, and I think that is the booming specialty of dentistry. Let it be in joining PG or in making money or in clinic. So nobody can go near them. But she's going to give you a different picture. She's going to tell us something beyond us. And recently, I too attended her course. So I always say that don't stop learning. That's what one take-home message is. And all of you should explore this course. And I'm not just, don't think that I'm propagating something here. All of us are here would have done something in orofacial pain. That is why we are all able to do something in it. And we are able to give the pain relief to the sufferings. That is very, very, I live in a very, not I live here, maybe I'm from Chennai, but I'm right now in Rishikesh. And most of my time is here in Rishikesh. And the patients here are very, not much educated. They are from a very economically low background. But I'm very happy to say that I'm able to relieve that pain. And I'm happy that I'm doing this. And scientifically, it is also proved that we have a lot of articles which shows that trigger point injections is one of the best modality for chronic orofacial pain. Okay. So in conclusion, anything with myofascial pain must have a multimodal approach. The most important thing is the diagnosis. So look for the tender area, look for the referred points, always make sure that you're able to reproduce the familial pain that the patient is suffering from. And all your procedures should be safe and minimally invasive. That's very, very important. and trigger point injection should be considered as an early modality in selected patients with chronic orofacial pain. These are some of my references. And I would like to conclude that real knowledge makes us all humble. And I'm really thankful to my mentor and guru, Dr. Davis Thomas, whom we lovingly call it as Dr. T, because of whom we are all here today. And I would also like to thank the organizing team for giving me this opportunity, and also Dr. Sonal Erpude and Dr. Nurul. Thank you all, and thanks for patient listening.
Thank you, Dr. Valli. And it was really, really enlightening because you, excuse me, you covered almost each and every aspect of referred pain and the trigger point injections. And we have certain questions for you, if you may permit me to ask. Yeah.
Sure.
If the referred pain is in the region of upper eye or in the glabella, Roshni, I think she's asking regarding some slide. So, okay, doing trigger point injection is a permanent treatment, or the pain comes back after some time? Ma'am, you're muted. Ma'am, you unmute yourself, ma'am. Doctor, unmute yourself. Dr. Valli. Wait, I'll just see. Ma'am, unmute yourself first.
Yes. Am I audible?
Now you're audible. And is it a permanent treatment solution, the trigger point injections, or the pain comes back?
To my knowledge, I have, to my experience, I would say I have not got the patients coming back. But as I told you, it will not, all patients are not, it's customized. It is not a cookbook. So it varies with patient to patient. If you have done the right diagnosis, okay, and if your diagnosis is only a muscle pain, and if you're sure that you are dealing with the muscle pain, then I would say that this is one of the best modalities for myofascial pain. Okay. So always don't tell the patient that my injection is a magic thing which is going to give you 100% relief. So don't ever tell any chronic patient that thing. That is, you're faking the patient's mind. So make them say that it's one of the management of modality, and you're only managing the pain. And you'll definitely, if you're doing it in the right way, and if your diagnosis is right, you will definitely have very good success in it. As I showed you, there are some cases where the pain has come only to 4 on 10. I'm not able to get it to 0 on 10. But there are patients where I've got it on 0 on 10.
Yes. Since it's a life-altering phenomenon, they're happy.
One of the most important thing is systemic. Before we start all this, myofascial pain has, I think we have a DCNA completely on systemic factors, because of which we have. So I do a meticulous myalgia protocol, because a lot of patients with vitamin D deficiency, anemia, thyroid, I rule out all the systemic reasons. And then I start with the treatment protocol.
Yeah, ma'am, the next question is, ma'am, any specific reason or an advantages of earplugs or covering the eye during the practice?
One most important thing is we don't splash the local anesthetic into the ear, into the eyes or into the ears. So to be careful, I think we follow all these protocols. And especially when you are giving in the temporalis region, you have to be very careful that we don't get into the eyes. The LA can irritate the eyes.
Yes. And yeah, this is a different question altogether. But then, are we making the trigger points latent, or will it be removed completely?
She's almost asking the same question, the first question. No, we are not making it latent. Latent is if I press, patient should have pain. So after my injection and after I call them after 1 week, when I palpate, if the patient has pain, then it is a latent trigger point. I'm not making it latent.
Yes, Dr. Abhay Kulkarni has raised his hand. Yes, doctor, you may ask your question.
Good afternoon, ma'am. I just wanted to ask, you are giving a local anesthetic, that is a plain local anesthetic without adrenaline, yes or no?
Yes, usually I prefer to give it without adrenaline.
Okay. Is that the only one solution we are supposed to give, or can we use even? See, there is some muscle spasm also, so can we use this thing, this thing? For muscle spasm also, can we give muscle relaxants? And botulinum
relaxants as injection, you're saying?
Yeah.
Botox, you mean?
And Botox also.
See, muscle relaxants cannot be given as injections, first thing. Okay, centrally acting muscle relaxants, yes, you can give, because if you see in the etiology, it is a centrally acting mechanism. So you can give a centrally acting muscle relaxant as in the parenteral route, okay, as a pill.
Okay.
But another thing about Botox is Botox can be given, but as I said, Botox is a protein. So you should remember that Botox can only give temporary relief and patient can get hypersensitive to Botox.
No. I mean to say, along with this thing, it's not the alternative modality for the anesthetic. Along with it, can it have some beneficial effect with that?
I'm not, I wouldn't vouch on it that it is going to give an better effect. So when a plain LA is able to give it, see, I even said dry needling also gives it. There are some persons, some orofacial pain specialists who go with dry needling. They don't even give it. So even dry needling can give. So why do you have to give Botox? And sometimes there is Botox, you really have to be careful. There can be thinning of the muscle. So when there is thinning of the muscle, it can affect the aesthetics of the patient.
Yes.
So you need to be really careful of that.
Yeah.
Okay.
Ma'am, what is the dosage for administration of this LA?
Usually around, we give around 1.2 ml per muscle.
Okay. Okay. Thank you, ma'am. Thank you so much. And as usual, you have been very enlightening, like you have delivered a very enlightening lecture. And I'm very happy to know that the patients in such remote areas are also visiting for and taking orofacial pain as a specialty. And Seema Dental College is really doing a very good job, because I have seen the work. I mean, 15 patients in one go. If you guys are treating, that's really commendable, doctor. And our next presentation also goes in line with Dr. Karpagavalli's presentation. And the presenter is Dr. Divya Dilip Kumar. And Dr. Divya, can you just unmute yourself? Your slides are also running. Yeah. Dr. Divya, just unmute yourself.
Yeah, able to hear me? Able to hear me?
Yeah, I'm able to hear you, but your slides are running, dear. Just come
Yes,
back.
yes.
Okay.
Yes.
Dr.
Okay.
Valli, I would request you to wait for some time and attend the next lectures also. It would be our honor to have you on board. Thank you so much. Dr. Divya, yeah, please continue.
Sorry, 1 second. I'm just.
Yes. Dr. Divya Dilip Kumar is an orthodontist and an orofacial pain specialist. She's completed a mastership under the guidance of Dr. Davis Thomas. And she has multiple centers right from Chennai, Coimbatore, and Tamil Nadu. And she successfully treated more than 2,000 patients with TMD and orofacial pain, and administered more than 500 plus ultrasound guided trigger point injections in collaboration with radiologists. She's been a speaker for national and international forums. But more than anything else, I would like, Dr. Abhay, mute yourself, please. Yeah. So more than anything else, I would like to tell you all a different aspect of Dr. Divya Dilip Kumar. That is that she has used the social media platform to the fullest. You all can see her website, you all can see her Instagram profile, and she has very subtly in scientific way and in an understanding pattern, she has explained orofacial pain so beautifully that even a layman can understand and relate to their conditions. And this is a learning curve for each and every dentist to use social media so judiciously. The platform, that the thing in your hand which you carry everywhere, that mobile, can be of a greater help, and she's really doing a great service to the society, because she's delivering them solutions, home care tips, and treatment protocols also. So commendable job, Dr. Divya, and it is a learning. And in fact, I would like you to present a lecture on this topic also, like how to
Yes, yes.
utilize social media as a platform for dentists, and really commendable, ma'am. So the stage is all set for you, Dr. Divya. Welcome.
Thank you. Thank you. Thank you, Dr. Sonal. Able to hear me? Am I
Yes.
audible?
Yeah.
Okay.
Go ahead.
So actually, I had prepared my presentation for 20 minutes only. But then when I see others presenting, I thought, okay, I would want to present some more also. I would want to give some more. Maybe my slides are less, but then I would give as much information as possible. So, and a wonderful presentation by Dr. Katpagavalli, and she's made my job easy because she's told about everything about the basics about trigger point injections and the muscles, how is the referral. So for all of you here, trigger point injections, like Dr. Katpagavalli told, and before that, Dr. Ramya ma'am spoke about the non-pharmacological techniques. Like, for example, when you see a patient with orofacial pain, when a patient complains of pain, first thing is, like already been told, rule out dental first. And if not dental, it is definitely going to be muscle, because there are several structures around the teeth that is there, and non-odontogenic pains mostly come from the muscle. And muscle, for us especially, it is the masseter. So masseter refers pain to the teeth. Also, the masseter can refer pain to the head. So patients complain of headaches, and patients may complain of pain around the eyes. And someone asked the question, where is the trigger point for pain around the eyes? It is like, it is not one particular trigger point that is referring a pain to one particular area. There are several trigger points in combination referring pains to one particular area. For example, if it is teeth pain, it can be a referral from the masseter, it can be a referral from the temporalis, it can be a referral from the SCM also. So, like previously told, do not jump into a conclusion before you understand everything clearly. There are lots and lots of things about trigger point injections. So many studies are being done, and studies previously done and being done, and every day we learn something new. So basically, I'll just talk briefly about what is a trigger point. What is a trigger point? Like Katpagavalli ma'am told, the same thing. That is, see, when you take a muscle, there is the nerve that is going onto a muscle. For example, if you take masseter, there is the nerve that is ending in the muscle, that is the motor neuron. That sends signals from the brain to contract the muscle. So that point where the nerve ends on the muscle is called as the motor end plate. Sorry, I don't have the slides for that, because I didn't, this was just like that impromptu. I thought I should tell this before going on to ultrasound guide injections. So the motor end plate is the area of the muscle where the nerve ends on the muscle. So this area is the one that gives signals to the muscle to contract. The entire muscle is dependent on what signals comes from the nerve at the motor end plate. So for example, if you are stressed out, so what happens? The sympathetic nervous system is activated. There are signals going from the brain, releasing acetylcholine. So this acetylcholine is released any time that the muscle has to contract. So it can be a reflex reaction. It can be anything other than anything that the brain thinks the muscle has to contract. It sends acetylcholine. So when acetylcholine is released, it goes and attaches to the acetylcholine receptors that are there in the muscle. And then from there, it sends signals to the sarcomeres. That is, what happens is calcium channels get opened up, calcium influx happens, and sarcomeres contract. Like the picture what Dr. Valli had put, there are this sarcomeres contraction where the actin and the myosin join together. So before that, what happens?
Your slides are not moving.
No, I'm just, this was an impromptu. I just wanted to tell them, there is no slide for that. I wanted to tell them what this trigger point is. Hope they're able to understand without the slide. Are you all?
Yes, please continue.
Okay. So this is just an introduction of how a trigger point forms. Like for people asking if the trigger point, why is Botox not given? Why is LA given? This is just a small introduction of what trigger point is, so that you'll understand why we do these procedures. So when acetylcholine is released, like I told, there's a calcium influx, and then the sarcomeres contract, the actin and myosin are attached, and this causes the tightening of the muscles. So there are two types of contraction generally. There is a muscle, two types of contractions. One is eccentric contraction, another one is concentric contractions. So eccentric contractions are contractions that happens at the ends. So this stretches the muscle. Concentric contractions happens in the center, which contracts the muscles. So the muscle shortens. The same thing applies to the bruxism also. So when a bruxer clenches, when there is bruxism, constant bruxism, so there is a contraction of the muscles. So what happens? There are taut bands that are formed in these muscles. Again, why is the taut band formed? Because the muscle becomes hypoxic. There is no blood supply to the muscle. Lactic acid that is formed because of the muscle metabolism is not taken out. So these taut bands are formed. These taut bands that are formed, and in the taut bands, there are these small knots that is a trigger point. So this is the trigger point. Hope you understood what a trigger point means. And going on to why this happens, why are trigger points formed? Like I told you, it is most commonly because of some stress that is happening to the muscle. It can be a physical stress or it can be an emotional stress that is causing the muscles to tighten. Clear? So when we treat trigger points, we will have to look into all the other things also. For example, why is the trigger point formed? It can also be formed when there is an iron deficiency, when there is a ferritin deficiency, when there is a vitamin D deficiency, the muscle cannot restore properly. When there is no sleep, patient is not sleeping properly, the muscle don't have time to restore. So these trigger points are formed. And posture, that is when you're sitting in a particular posture for a long period of time, these muscles are stretched, or when you slouch and when looking at a mobile, there's one syndrome called as text neck syndrome. That is when you text for a long time, you get these neck pains and shoulder pains and headaches. So again, posture also gives rise to these trigger points. So remember, trigger points are not just because of one factor. It is not just because of people who are bruxing. It is because of several other factors. It is because of systemic factors. It is because of the stress factor. It is because of the posture. So we need to see a patient as a whole. We need to correct everything as a whole instead of just trigger point injections. Okay, going on to my slide. Sorry, because I've not put these slides because I didn't, just now I thought I should tell about this and then start my presentation. Now, going to the ultrasound guided trigger point injections. Normally the general trigger points, what Dr. Valli was telling us, the normal injections that we give on the muscle, that is on the masseter, on the temporalis, on the SEM, on the trapezius, all these are trigger point injections that we give with a needle 2.5 centimeters, that is around 25 millimeters. We inject and we inject the local anesthesia. LA usually is given without adrenaline. So these trigger point injections are given at particular spot of the trigger knots. So when you are not able to give these injections in particular muscle, for example, in a lateral pterygoid muscle, it is very risky to give a trigger point injection because we don't know where the muscle is. For example, in the masseter, we know the border, we know the origin, we know the insertion. It is very clearly demarcated. When you touch, you know where the masseter is. Like same way, temporalis also, we know where it is. The SCM also, we know where it is. Still, SCM has a lot of structures involved inside. So we can go in for ultrasound guided trigger point injections. Trapezius, trapezius, yes, we know that there is a bulk of the muscle, but still we have a risk of injecting in the ultrasound guided, a risk of injecting in the trapezius, because the lobe, the lung lobe might be high. In case it is high, we might puncture. So there is a risk involving the lung, puncture of the lung when you inject on the trapezius. And then on the splenius, on the occiput, there are a lot of these muscles which can be easily injected, but some muscles which we need to be very, very careful. So coming back to what is the trigger point? It is a hyper irritable spot, usually within a taut band, and it's painful on compression. And it has referred pains. Referred pains, motor dysfunction, autonomic phenomenon. What is a motor dysfunction is, you will feel twitching of the muscle. There is a twitch of the muscle. Autonomic phenomenon means the eye tearing, redness of the eyes, all these are associated with the trigger points. So when a patient complains of pain, we generally ask these patients, do you feel any muscle twitch? Do you have any watery eyes? Do you have redness in the eyes? Do you have blurry eyes? So all these things we ask so that we are sure that it is coming from a trigger point. And I've made this into a slideshow, into a video, because I had some videos in this. I want to show the ultrasound guided injections as a video. So I've made it in a video format. So now this is a trigger point. Now what you see is the trigger point. And this is how we palpate a trigger point in the superficial muscles. For example, in the masseter, we place our hand, we press the trigger point. And when you feel, when the patient feels pain, then that is the trigger point. That is the area of the trigger point. So after we press and we find out that the area, there is a trigger point there, then we place the 2 fingers like this, and in between, we inject in this area like this in between. And we make sure now when you press on one side, the trigger, the point would move on to the either sides. And we make sure and we press both the fingers and then put a trigger point so that we stabilize the trigger point. Now, next is the other palpation is a pincer palpation. In some muscles like SCM and trapezius, we will not be able to do the flat palpation. So flat palpation is for the masseter and temporalis. For SCM and trapezius, we will be holding the muscle like this because the muscle is bulky. So we would hold and then find out the trigger point, and there the patient would have pain, and there we would inject. Now the next, this is called as a pincer palpation. Now this is how we do the needling. So once you inject the needle, we will have to take it out and move it across the around the trigger points, because we shouldn't be leaving out the other small trigger points or the satellite trigger points that are around. So we make sure we needle and we inject all the trigger points around that area. Now, why ultrasound guide injections? So, like I told you, some muscles are superficial and some muscles, we know the demarcation, we know where the muscles are, we know the origin, insertion of the muscles. For some muscles, we have to do it blindly. So we cannot do these procedures blindly because we might injure the big vessels around the area. For example, in the lateral pterygoid, when you do the lateral pterygoid is way behind, way down, and it is in different positions. For example, during mouth opening, the lateral pterygoid is going down, it is pulling, while closure, it is small, and when it is contracting, it is in a different position. If you have a disc displacement, then when you inject, you would go onto the disc, thinking if you think lateral pterygoid is in that area and you inject, if it was the disc displacement, then you would inject on the disc. So we have to be very, very careful with the lateral pterygoid. We cannot take chances and do a direct injection. So in these cases, we do ultrasound guide injections. So how do we go about these ultrasound guide injections for the lateral pterygoids? And one more is, in obese patients, these injections might not reach the target tissue. So for these patients, because of the fat tissues, we will not exactly know where the trigger is. So for these patients, again, ultrasound guide injection is useful. Now, so this is, I've already told, like it helps ensure the accurate needle placement when treating this. So now here is one patient. So now I'll go on to cases of how we treat, I treat in my practice, how I do trigger point injections in my practice. So for general muscles, I do normal trigger point injections. That is like what Dr. Valli spoke. For the masseter, temporalis, even SCM, trapezius, splenius, occiput, all the muscles, I do general normal trigger point injections blindly. Whereas for lateral pterygoid, I always go in for ultrasound guide injections. So when do we require lateral pterygoid injections is when the patient has a referral pain in the zygomatic area. The picture what Dr. Valli had showed already. So this is the area where the patients will feel pain. So patients might feel pain in the ears, patient might feel pain in the zygomatic area. In such cases, once all the other trigger points are done and the patients are relieved of other pains, they might complain of pain only in the zygomatic area. So in such cases, we do ultrasound guide injections in the lateral pterygoid. Another condition when we do is when you have disc displacement with reduction, without reduction. That is when the patient has pain. So what is a disc displacement without reduction is when the articular disc is coming forward because of the pull of the lateral pterygoid muscle. In such cases, when we give ultrasound guide injections on the lateral pterygoid, the disc becomes loose. And then the disc slowly comes back to its position. So, like the previous doctor who spoke about arthrocentesis, it is one method where the disc space is getting cleaned. But what is happening to the disc? The disc has to be relieved from the force that is pulling it, right? So when we relieve the force, it easily comes back to its position. So in those cases, we give the ultrasound guide injections for the lateral pterygoid. So if you see this patient, he's a 23-year-old patient, he's a college student. So he had continuous pains in his zygomatic area and ears. So what we did was, and we do this procedure with the help of our radiologist, Dr. Alagu Balaji. So he's been with us for the past 4 years, and we have been doing this procedures. So he sees the muscle with the ultrasound, and this is the needle that is injected. See, when he sees this, he would show me where the muscle is. So what you see here is the muscle. The hypoechoic area, that is the black area, is the muscle. So in the ultrasound, the muscle is seen as hypoechoic area, and the arteries and the veins are seen as red and blue, and that can be actually interchanged. It is just the colors that we choose. And when we inject, we'll be able to see the needle tip has the hyperechoic areas. And when I inject, the liquid can also be seen around the muscles. So this patient, we are giving the injection here, and this is what we see on the screen. Going on to the next slide. Yeah. Now this is a video. Please check out this video of how we do for this patient. The screen is on the other side, and I inject after seeing the screen. And this is what we see on the screen. So this is the area of this is the infiltration of the drug. Now what you see as a red area is the drug that was delivered, sorry. Now what you saw as, now this one is the drug that is delivered, the local anesthesia that was delivered onto the muscles. So the next, another patient, again, this patient also had pains in her zygomatic area, and she had severe pains radiating to her ears. That was her problem. So she had been to several ENT surgeons, been to neurologists. More than 6-7 years, she's been having pains, ear pains and pains in the zygomatic area. She didn't know what to do. She's taken all myospas, all the muscle relaxants, been on splints for a long time, but her pains did not subside. So for her, again, we did ultrasound guided lateral pterygoid. Oh, sorry. I don't know what I did. I'm sorry. Yeah. Is it visible? My slides?
Yes, doctor, go ahead.
Yes. Okay. So this patient, again, we did a lateral pterygoid ultrasound guided injections, and you can see what we see on the screen. Here again, see, if you see, we ask, so what we do is we ask the patient to move the mandible right and left. So when she moves her mandible to the right and left, we will be able to see the lateral pterygoid moving. So that is the area where we inject. So this is around 2.5 millimeters. That is the entire length of the needle goes inside. 2.5 centimeters. That is 25 millimeters of the needle goes inside, and then I aspirate. Why do we do that? Is again, there are a lot of arteries around there. So we will be seeing it, but still sometimes we will be passing through an artery. Sometimes we will not have any other choice. The radiologist would tell me that we have very, very minimal space, so we should be careful. Sometimes we change the angulation and do it from the other side. So there are a lot of things that we do to bypass these structures, major structures. Sometimes we go through it and then inject it onto the muscle. So there are times that we have done that also, when the space is very, very less. So this is the drug delivery. So this was after the drug was delivered. That the image that you see is after the drug was delivered. Hope you're able to see it. This was when the patient was moving her mandible right to left. The echoic areas, are you able to visualize that? Now the patient is moving her mandible to the left. So this is okay. Now going on to another next interesting referral pattern, which Vali ma'am was telling about, the anterior digastric. So sometimes some patients complain of pain in the lower anteriors. Typically, they have pain only in the lower anteriors. So in those cases, the referral pattern is from the anterior digastric here. And this is a very, very tricky muscle to inject because the muscle is very thin here. And we will have to be very, very careful while injecting the muscle because there are a lot of other structures like the salivary glands that are there, the lymph nodes that are there. So we'll have to be very, very careful while injecting onto the anterior digastric. So this again is a patient, around 26-year-old patient. He had pains only in the anterior area, anterior lower incisors. He had severe pains in the lower incisors, nagging pain, pulling pain. He didn't have any other pains. He just complained of this pain. So again, he's been through all the circles. He's been to neurologists, been taking tablets. Imagine a 26-year-old patient having this pain, this nagging pain. He stopped going to college for 2 years and he was on a break because of these pains. So he had been to neurologists, all the specialists, general medicine doctors, all hospitals, but these pains were not cured. He was finally was put on antipsychotics. And then he came to us and he was telling about this. Then we said, now after this, I examined like previous speakers have told, it was not just a diagnosis in a few minutes. It was a thorough diagnosis, a thorough history was taken, all his other muscles palpated. We found out his stress history, and then his blood workup was done. After all that, we came into a conclusion that he had a trigger point in the anterior digastric. And then again, anterior digastric, we cannot do these injections directly. So we went on to do ultrasound guided injections. Here, if you see in the anterior digastric, we would be able to see the hypoechoic area, and that box inside the box, if you see the upper part of the box, that is the hypoechoic area. That is the anterior belly of digastric. So again, the radiologist, he was helping me out and he was guiding me to do the injection. And here it is just 1 centimeter. I mean, 1 centimeter. There is 10 millimeter of the needle going inside. So we wouldn't be injecting, we wouldn't be putting it as deep as lateral pterygoid because it's a superficial muscle. And as you go, sometimes 7-8 millimeters, we would be able to feel the muscle. And the needle tip will be seen. If you see this, the one small dot that you're seeing is a needle tip here. One small white dot is the needle tip. That shows that we are in the muscle, and then we inject it there. Now this is the process of injecting. So we ask the patient to tilt his head a little up, and then we place the ultrasound. Hold on, doctor. Yeah. Yes. So this is how it is injected. Now you can see, you can check me aspirating and then injecting. Yes. Okay. Okay. Now this is another patient. Yeah. This was an interesting case. She is a 40-year-old female, and her complaint was a pulling sensation, which is pulling her down. So she was complaining of a pulling sensation in her throat. That was her only complaint. She had severe pulling sensation. She was not able to eat. She was not able to talk. She felt someone pulling her down. And then we saw all the other muscles. And she had another complaint of when she was eating, she had a pulling sensation upwards. Something was pulling her up. So initially, first diagnosis was the temporalis spasm. And then first we relieved that spasm. And once the temporalis spasm was relieved, she had more of the pulling sensation down, because once this sensation is gone, this is more. The anterior digastric pull was more. So for her, again, we opted for the ultrasound guided injections. And this is how we did it for her. Again, you can see her placing her head down, and this is the drug delivery. So this here, it is very, very clear. Oh, sorry. Sorry, 1 second. So here, if you see, it is very clear in this, the muscle is very clear. Now you can see the hypoechoic, the lobes that you see on the upper part of the square. Wish I had a pen to draw and show. So that is the lobe, that is a hypoechoic part of the anterior digastric, and that is a drug that is delivered. So now going on to, okay. So now this is another patient so now that was all about the anterior digastric and the lateral pterygoid that we very commonly do. So on daily basis for the lateral pterygoid and the anterior digastric, the ultrasound guided injections are used. For some muscle, it is not used very commonly, is the trapezius muscle. Usually trapezius is done at our place only, at the clinic only, without the ultrasound guided injections. But why we did for this patient is, I'm actually publishing a paper along with Dr. Davis Thomas, Dr. T, my mentor, on ultrasound guided injections, because this has never been published. No one is doing ultrasound guided injections. So we thought we would publish a series of these injections, these cases. And so we did ultrasound guide injections for all the muscles, even the normal muscles. We tried doing ultrasound guide injections so that we would see what are the advantages and what we would achieve best with the ultrasound guide injections. So here for the trapezius muscle, we did the ultrasound guide injection. Again, it is actually very simple. In the clinic, I mean, in the chair side only, we do ultrasound guide injections for the trapezius. The only problem here with the trapezius might be in case we go on poke into the pole of the lung. That is the only thing that lobe of the lung. That is the only thing that that is a risk in trapezius muscle. But when you feel the bulk of the muscle is good, and when you're able to hold the muscle in your hand, then we can inject it directly. So for this patient, I injected it. I usually inject it directly, but here we did this for our paper publication purpose. So you can see how we inject the trapezius. So this is a video showing the trapezius injection. Okay. Again, when do we do trapezius injection? Is this patient had giddiness. So he had giddiness and referral patterns to his head and around the eyes, head. Someone asked, no, if you have pain around the eyes. Yes, trapezius muscle refers pains to back of the head and around the eyes, and he had giddiness also. Now, next is SCM. Now again, this we did for our paper publication purpose, because SCM we do it directly chair side only. And if you see this SCM, this I just want to show the big vessels that are there in the internal jugular vein, carotid artery. All these are there when we do the SCM. So we will have to be very, very careful unless we know the proper procedure, unless we are very, very clear about what the structures are. And first thing is, anatomically, we should be very, very strong. We should know which structure is where can it go wrong. All that if we know, then we can do these procedures. So this was the SCM ultrasound guide injection for the sternocleidomastoid muscle. And these are the big vessels that you see. So this is how we did these injections. Okay, now going on to why do we do, I've already spoken about this. So it reduces the risk of complications like pneumothorax, hematoma, intravascular injections. All these we can avoid with ultrasound guide injections, and we can visualize the soft tissues that are there around the place, and it guides the needle to the target and confirms the needle placement. So these are the advantages. And one of the some cases where I've had patients with occipital neuralgia. So why does occipital neuralgia happen is, one, because the nerve gets entrapped when in the splenius capitis muscle. So when the nerve gets entrapped, because of the nerve entrapment, the patients have pain. So in those cases where greater occipital nerve is often implicated as the cause of the cervicogenic headache because of the nerve entrapment in the muscle. So in those cases, when we relieve the muscle spasm, when we relieve the trigger points in the muscles, automatically the nerve entrapment is relieved, and the patients, those who have been suffering from severe headaches, they get relieved. So this I have seen in occipital, when we do occipital area. So we can also visualize where the nerve is, and we can directly inject it next to the nerve. So yeah, I think I'm on time, Dr. Sonal. Okay, so in fact, I was privileged to conduct a course on ultrasound guide injections a few months back. I think we did it in September this year, along with my mentor, Dr. Davis Thomas, and with our radiologist, Dr. Alagu Balaji. And it was a well-received course, not only dentists, but there were a lot of pain specialists coming over, that is medical specialists, pain management specialists who came over for the course. And it was a well-received course, and we were very happy to share the knowledge. So this was during the course, in the pictures that, so this was a picture that was, sorry, this was taken during the course when we had, now this was, sorry, I'm sorry. Now, this was during the course when we had our radiologist showing us where the muscle is, where I'll have to inject, and this was how we did. and this is with my mentor, and this is our radiologist, Dr. Alak Balaji. And I'm always grateful to Dr. Davis Thomas, because without him, I would not have known what this is. I would, like Dr. Tanvi was telling, now only I feel like a doctor. Seriously, only after doing my orofacial pain, I felt I'm doing something right. I'm an orthodontist basically, and now it's like more than orthodontics. I would tell my practice has shifted towards orofacial pain, and I can proudly tell that I'm an orofacial pain specialist, because the happiness that I see in after relieving my patient's pain, that is priceless. Patients come with 15 years, 20 years of pains, been to several neurologists, ENT surgeons, waiting for some solution. Like they would always come looking out for at least here will I get some relief. And when I see that happiness in patient's face, that is like with no words to tell those that happiness. So I'm always grateful for Dr. Davis Thomas for bringing this specialty to India and making us all realize that there's something beyond dentistry. So we've always been looking at teeth, only teeth, but there is so much more. And this is not like just like if you do MDS, it's like 3 years of course, and we think I mean, at least we learn what is there in the subject. But orofacial pain is not like that. There is so much to learn, so many books, so many things to learn from the basics: anatomy, neurology, physiology, biochemistry, the basics that you will have to know to actually understand what is happening. Why are these patients getting pain? Like Dr. Ramya told, the psychological aspect of the patients, that is a major aspect. So that is why we cannot just see these patients as like if you, for example, if a patient comes with teeth pain, we see only the teeth, we do root canal and we finish off. But this, we cannot see the patient like that. We'll have to see the patient as a whole. We'll have to see the patient's we'll have to counsel the patient, the stress levels of the patient, their systemic factors, and how much they've been, even emotional pattern. That is, some patients with childhood abuse, these patients have myofascial pain. See, there are a lot of things that I come across every day. I'm like thinking, I mean, how will this happen like this every day? I have these questions that I every time. It's a new learning for me every day. Every patient is new. Every pain is new. No two patients have the same pain. No two patients respond to the same way to trigger part injections. So it is totally different. So I would actually, many of them, I think most of you are orofacial pain specialists here, and some, I mean, most of them are my batchmates, I think, and many have, I think many who have not known about the specialty, I definitely feel this is one specialty that you should look at taking over. And I would like to thank Dr. Sonal for giving me this platform for presenting. Thanks a lot, Dr. Sonal. Hope I did some
Pleasure
justice.
having you here. We have certain questions for you.
Yes.
So you can stop screen sharing and
yeah. Finally, I just want.
Yeah.
I think that's done.
Yeah.
Yes.
What
So,
ultrasound
if you-
probe do you use?
If you, tell me. Sorry.
Yeah. What ultrasound probe do you use for the
Yeah,
procedure?
that is the radiologist. He uses his. We have a radiology machine at the hospital. So we are not supposed to have our ultrasound machines at our practice, because that has a lot of legal things that are involved with having an ultrasound in our practice. So it is always done at a hospital setup. So we have a hospital tie-up and we do it there.
Very good. And doctor, I would like, okay, how LA is helpful for trigger point injections, just to know the mechanism of action. I think it's a book in itself. So what I would suggest is you can just answer in the chat section, so that everybody is enlightened, and few of them would like to connect with you for the trigger point injection.
Okay, I think better than chatting, quick answer for this. Sorry.
Yeah, tell me.
So LA is just a liquid that is given to break the knots. That's it. LA does not have any effect. The lignocaine does not have any effect on its own. It is a liquid that is given to break the knot. Any liquid can be given for that matter, but the safest is LA, because if you put even water, that would break. But H2O reacts with the muscle. If you put Botox, yes, it would act, but it acts on the neuromuscular junction and it is temporary. Even saline has been tried. Sodium chloride was tried, but then again it has effect on the muscle fibers. So the safest that we have been using for decades for nerve numbing, nerve injection was LA, and that didn't have any effect on the muscle. That's why LA is given. Local anesthetic was chosen to give for trigger points.
Wonderful.
It's sterile also.
Yes, yes, yes.
Yeah, Dr. Divya, I would like you to check on the chat section. Okay, there's one
Yes.
more question.
1 second. I'm just going back.
Is it plain LA or without? It's without an.
It
Yeah.
is without without adrenaline.
Okay. Thank you, Dr. Divya. And please stay with us and listen to our
Definitely.
next speakers.
1 second. I'm just stopping my.
Yes. With that note, I would like to welcome Dr. Chenna. Dr. Chenna, can you unmute yourself, dear? Yeah. Hello, Dr. Chenna.
Hello. Hello, ma'am. Good evening.
Good evening. Okay. And we have our associate professor from Department of Oral Medicine and Radiology, Dr. Chenna Singh. She's from Rohtak, Haryana, and she's working as this faculty for the past 5 or 6 years, and she's also completed a fellowship under Dr. Davis Thomas's guidance, and she would like to pursue her mastership also. And right now she's planning to complete a PhD first. That's what I have known. A very warm person. And Dr. Chenna, the stage is all set for you. Can you share your screen, dear?
Yes, ma'am.
Dr. Chenna is going to be talking about orofacial pain, unmasking the real. So certain mystery cases she'll be discussing. So please share your screen, dear.
Yes, ma'am. Ma'am, screen is visible?
No, share the screen. It's blank screen right now. You are sharing the screen, but the slides are not visible. It's a black screen. Stop sharing and repeat the thing again. I think we'll give Dr. Chenna a minute. And it is post lunch session, and I'm still there's so much to learn in trigger point injections, or for that matter, orofacial pain specialty as such. And all the speakers are eager, still waiting. You all can ask questions if you all have any questions. They in chat box you all can ask questions to the speakers. They are still waiting for you for your responses. Dr. Nurul, is Dr. Chenna there, or she's logged out fully? Do we have our next speaker, Dr. Nilashri? Dr. Nilashri, are you there?
Yes, I'm there.
Okay. Dr. Nurul, should we continue with Dr. Nilashri and give Dr. Chenna a chance next? Is it okay? Dr. Nilashri, you're ready with your presentation?
Yeah, I'm ready. Should I share my screen?
Yeah, please go ahead. Let me introduce you first. Okay. So, yeah, you can start sharing your screen, dear.
Yeah, is it okay? Can you see my?
Yeah, go on presenters mode. Yeah, Dr. Nilashri Sachin Kene is BDS from Nair Hospital and Dental College, and she's completed her dental surgery in Department of Microdentistry from GDC Mumbai. She's also a fellow in under the guidance of Dr. Davis Thomas, and she's also a Smiley's physician and owner of Smiley Dental Clinic. And with that, she is also Miss Medi Queen, I guess, and she's known for her smile and her participation in various beauty contests. So welcome, Dr. Nilashri, and your topic is going to be actually what we dentists are looking out for, balancing the triad, teeth, TMJ, and the muscle. So the stage is all set for you. Dr. Chenna Singh, you can join later after Dr. Nilashri.
Thank you, Dr. Sonal, for giving a lovely introduction of myself. I actually like to be introduced as a doctor more than a beauty queen. My presentation is dedicated to my sir, my guru, Dr. Davis Thomas. Salute to the guru who, with brush of knowledge, opened the eye of people who were blinded by darkness of ignorance. And one of them was me, and he showed me the path of the knowledge. Today we will talk about the triad which every dentist came into day-to-day practice, and we think, is this causing the pain in TMJ or causing the pain in the muscle? So this is a long accepted theory that orthopedic stability, which we call, give the term to this, exists when the stable intercuspal position of the teeth is in harmony with musculoskeletal stable position of the condyle in the fossa. So there is no tissue injury while functioning like chewing, swallowing. That's what we think. So let's elaborate how there is relation or no relation between occlusion and TMB. Here you have to understand all the occlusion principles are gold and should be followed diligently because it revolves around the physics, as Dr. Davis Thomas also said yesterday's presentation. They are not debunking any occlusal principles. Let's see what is a triad. Now you can see the TMJ joint, muscles, and teeth. They are very in combination with each other, and though they cause confusion between our mind. So is it TMJ causing the pain or the occlusion is causing the pain? TMJ is, we have to understand the TMJ physiology for that, and the TMJ is a unique joint and most complex joint also. It has many components like articulating disc of the mandible, which connects the condyle with the glenoid fossa of the cranium. And articulating disc is the dense fibrous tissue. The ligaments also join this joint, condyles, and the glenoid fossa with each other, and it gives the integrity and limitation to the joint to maintain in that area only. The movements of these joints are like a hinging and gliding movements. But you have to understand how the hinging movement is happening and gliding movement is happening. There are two components in the joint, that the condyle disc complex and the condyle disc complex joined to the glenoid fossa with articulating disc. The condyle disc gives the rotational movement, and condyle disc complex with glenoid fossa give the transitional movement. And there are then muscles also, like elevator muscle, temporalis, masseter, medial pterygoid, that came into the picture when this joint is discussed. And this joint is given, the nutrition and the lubrication is given by the synovial fluid, that also consider while discussing the TMJ joint. Any pathophysiology changes in these anatomical components can cause the TMJ pain. Arthritic pain, ligamentous pain, retrodiscal pain, capsular pain, myalgic or tendinitis, and or the combination of all these things can cause the TMJ pain. Already, I think Dr. Kupravalli and Dr. Shaswat also elaborated this thing. I will little bit say about about the arthritic pain. It can be a degenerative changes. It can be inflammatory arthritis, psoriatic arthritis, osteonecrosis. This can degenerate the condyle, and there will be imbalance in the joint. And then you will think, okay, now the occlusion is changed. But we think vice versa, like because of the occlusion, that joint is changed. No, because of the joint change or condylite changes, the occlusion has changed. You have to take that in consideration. Then even elongation of ligaments can happen due to the trauma. And here is the fact, ligaments cannot stretch, it can get only elongated permanently. So we cannot revert back to that. Then retrodiscal pain, when there is a theory that in the teeth are in the maximum intercuspation, and if trauma happens or any injury happens, it goes to the retrodiscal area, and then the inflammation can happen. This inflammation can make the swelling in retrodiscal area, or the synovitis can happen, and because of this swelling, the joint changes and the occlusal changes can happen, or the malocclusion can happen. But we only concentrate on our teeth, and then we think, okay, because of this malocclusion and because of this teeth, the pain or the swelling happened into the TMJ. No, you have to think that because of this also this can happen. So thorough checkup is very needed in this type of cases. This displacement already discussed again by Dr. Shaswat, so I will not go much deeper in that. This displacement is like with reduction, without reduction. The capsular pain same happens because of the trauma, myalgic or tendon pain, because muscles are joined to the joint through the tendons, and any changes into or any pathology in the tendinous area can cause the tendonitis, and it can be the cause of TMJ pain. And combination I have already told you guys. So we will go further into the etiological factor, what and how this can happen. So etiological factors are many, like a local trauma. In the local trauma, it will be the direct trauma, indirect trauma, macro trauma, micro trauma. I think all boys and all people know that how Anil Kumble got the ball on his jaw, and then condyle got broken, and that was a local trauma. Then deep pain input. So deep pain input is actually the central excitatory effect. Because of that, the referred pain be there into the temporalis TMJ area. So you have to understand that. Emotional stress. Emotional stress can happen because prolonged exposure. It is a scientific study shown that prolonged exposure of the emotional stress leads to chronic upregulation of autonomic nervous system, and because of that, it produces change in level of neurotransmitters like adrenaline, cortisol, or oxytocin, and that can be the reason of the pain, TMJ pain. Dr. Divya also told you guys previously that the post-traumatic stress disorder are susceptible. These kind of patients are susceptible to the pain. So you have to take history thoroughly. Is there any emotional thing happened in their life when this cause or this pain started, like a death or any child abuse or any kind of abuse? So we have to take in consideration these kind of factors also. Occlusal factor I will elaborate in further slides. Then the significant orthopedic stability also I will elaborate in further slides. We will go to the next slide, that is the regional factors can cause the TMJ pain, and that is like cervical myofascial pain, cervical spine pain, centrally mediated pain condition. All these theories are because of the effect, like a centrally excitatory effect, or that convergence theory is applied in this kind of area. You have to understand one more thing, that brain pain in the cervical spine area, or pain in the cervical myofascial region, like a trapezius or neck pain, can refer to the pain in TMD. Like a spinal disc disarrangement also can cause the pain in the TMJ area. Then there came the systemic factors, like coexisting disorders. If patient had previously had a pain type, this kind of pain that will cause the pain in like 2-3 years, this pain can again be felt by the patient. So you have to ask history of the similar kind of a pain. Then these growth disorders like aplasia, hypoplasia, hyperplasia can be the cause of the TMD pain. And then came the systemic factors like a neoplasm, systemic arthritis, or idiopathic condylar resorption can also be the cause for the TMD pain. So that is not the only cause. The occlusion cannot be the only cause of the pain. But some patients we come to across in our clinic that some patients do not have that kind of a pain. Even their bite is not in a proper occlusion or in there is no stability. Why this happens? Because every individual is different and they have the adaptability for the pain threshold. There may be a genetic factor, then biologic factors, hormonal factors, psychological factors, sleep quality factors, and other factors are also occurring in there. I will talk about the sleep. Sleep is the most important part in day-to-day life. And right now, what is happening? We are watching OTT. We are on all the time on more phones, and the sleep quality is getting decreased. And because of that, patient can feel the pain. And we are not getting enough time, or I will say the body is not getting the enough time to repair the whatever the pathophysiology happened in the muscle and or in the TMD area, and because of that the pain is persistent. I am having a patient who is lactating mother and her child is only 4 months old, and you know the lactating mothers has to breastfeed, and they have to get up every 1 hour or 2 hours, and they are not getting the enough pain. This kind of patient comes into the clinic and they say that, okay, I'm having this kind of pain. So you have to understand why this is happening with it, because they are not getting the enough sleep. You have to consider all these factors. Now comes this question: is occlusion related to TMD? It is, again, I will tell, highly debated hypothesis in the science of dentistry. Current scenarios or current literature does not support one occlusal scheme over another for preventing the TMD. You already know, guys, there are two types of occlusion positions, that is static occlusion and dynamic occlusion. Scientifically proven thing is like our teeth comes into contact in maximum ICP for only 0.2 seconds and for whole day. Average duration of tooth contact for mastication is only 17.5 minutes. So how come it can cause the TMD? Because of only chewing or for 17.5 minutes which we are getting in a contact? No, I don't think so. So still, Dr. Jeffrey IOPCON has elaborated two concepts for discussing how this can happen. So these are the two important concepts which are going into consideration, like the muscle disorder and the intracapsular disorder. Because of this, the occlusion can be related to the TMD. The muscle disorder, like a muscle hyperactivity, bruxism, and clenching. But in recent studies shows that it is bruxism and clenching. It is a sleep-related movement disorder and does not connect with occlusion. Actually, systemic factors are affecting the bruxism, like vitamin D deficiency is a major factor causing the sleep bruxism. You have to take in consideration why the bruxism is happening. And because of the bruxism, the occlusal changes are happening, like adhesion of the teeth, and the occlusion pattern is changing. So bruxism is, occlusion is not the cause of bruxism. It's actually vice versa. Then habits. Obviously, Dr. Divya also said in that habits and postures can make problems like forward head position while watching mobile all the time or working on computers, improper sleeping positions, then desk job, studying for the longer hours. We have that all these things give changes and the muscle contractions, and because of that we can have the pain in the TMJ area. Then emotional stress, I have already, I think, elaborated on how emotional stress can cause the TMJ pain. I will not go further in that. And then comes an intracapsular disorder. Like we say that forceful unilateral chewing, that patient is not having teeth on one side, so he's chewing on one side only. Because of that, this can happen. But this theory is also debunked by Dr. Jeffrey Occasion, and he himself says that there is a terms and conditions for this theory. The loading and the extra loading may be the cause of the intracapsular disorder. You have to take on attention to the word maybe. It's not almost the cause, and scientific studies and scientific articles don't give this much importance to this theory. Then comes into the mind, and even I will say that most of the people in the world have the habit to chew unilaterally. Even we chew unilaterally most of the time. We have the habit. So this cannot be the or the cause. But then in muscle disorder, why this comes into the mind. So if the crown is given in supraocclusion position, the high point is there, and then it can cause the acute change. And in this is the protective muscle co-contraction, and because of that we are having pain. But there is a theory like if we are giving a supraoccluded crown or crown in a supraocclusion, the EMG theory, EMG studies have shown that muscle gets relaxed, not co-contract. And the same principle is used in the deprogrammer, which we are giving in the anterior area. So other teeth are not occluding and it is giving the muscle relaxation. But after even why this pain then persists because of the odontogenic pain, because all the pressure or loading is coming on only one tip, and because of that maybe the pain is causing that tooth is getting pain, and we are feeling all kind of pain because of the convergence theory. So after adjustment of the crown, the symptoms resolve in the acute changes. But what happens into the chronic response if that is not changed and it is kept like that? It can actually alter the muscle engram, alter the jaw position, like moving the jaw to the side that the occlusion comes into the contact, and or may it alter the tooth position, like the tooth is getting mesially, distally included, or like that. And all these things can add up this type of a crown. Or if this is not happening, then masticative muscle disorder can happen. Then comes into the picture the why this intracapsular disorder can happen. So the theory is like if there is a premature contact or the crown in a supraocclusion, the neuromuscular system gets two choices: either change the joint position or either change the occlusion position. If the joint position is kept in stable, like there is no change in the joint, then occlusion only the occlusion will be in only one position or only on the one tip. Recently, 2 months back, I had a patient, a 17-year-old girl, she came into my clinic, and we observed that all her teeth was not in a contact, only one teeth was in a contact, which are RC treated and was given a crown, very like in supraocclusion. And when I asked her, is she having any kind of a pain or in muscles or in joint? No, she was not having any kind of a pain. So this kind of cases also come into our clinic. Then if the joint position is not in a stable, then and neuromuscular system thinks like, okay, I want the stable occlusion position, then the instability into the joint position can happen, and orthopedic instability it leads to the unusual movement and strain on distal ligaments, disc, and then it can cause the intracapsular disorder. But there is no scientific studies are giving thumbs up to this kind of theories. Here I have some publications done by Dr. A.G. Pullinger and Dr. Manfredini, who are the most respected orofacial pain specialists. They have done the studies
And they himself says factor in defining the TMD population. Certain features such as anterior open bite in osteoarthritis patients were considered to be the consequences of rather than etiological factors for the disorder. And same with the Dr. Manfredini, he also says the same thing, that occlusion is not the reason for the TMD. Myalgic pain, I will not elaborate that much because Dr. Divya, Dr. Kupravalli already told you about the trigger points. I will only say how this can be the convergence effect or the central excitatory effect comes into the picture. The source of pain is somewhere else, you can say, in the trapezius muscles, and it is going into the C1, C2, and the convergence is happening, and central excitatory effect is coming into the mind. And then the pain is causing into the TMD area and in the temporalis region also. So this kind of myalgic pain can be the cause of TMD. This is already discussed, like how the masseter, temporalis, and sternocleidomastoid can get referred pain into the TMJ area. Medial pterygoid, lateral pterygoid also, and the semisplenius capitalis muscle also comes into the picture for the referred pain. But is myalgia only the trigger points? No, not because of the trigger points or the co-contraction. Actually, the reasons are, major three reasons are the muscle ischemia. It either can be a quantitative or qualitative, or the overactive sympathetic nervous system, and depletion of energy source. In our day-to-day practice, we come across many women who are fasting for the longer duration, and there is a depletion of energy source. I came across a patient who was fasting almost for more than 1 week, and she was only on a fruit diet. And when she came into my clinic, and I asked her how many years you are doing all this kind of fasting, so 8 years of the history of fasting, and she was having a severe muscle weakness, vitamin D deficiency, B12 deficiency, all these things, and her muscle weakness was very, like we can see, there is a problem. So depletion of the energy source is the cause of the myalgia. Vitamin D, vitamin B12 deficiency are already discussed, ferritin. Then thyroid hormones, PCOS, PCOD. You have to ask this kind of question to the patient. Are they having this kind? They are having some problems. And monthly during this part, because of the hormonal changes or PCODs, patient can feel the pain. And women are more susceptible for this kind of pain. Then viruses like chikungunya, dengue, then chronic fatigue syndrome also comes into the picture. Then autoimmunity or autoimmune diseases. And there are certain drugs. There are some drugs, can also induce the myalgia. Sleep disturbances, emotional stress. Sleep disturbances is the major factor right now. We have to take into consideration. We have to ask patient how their sleep is. That can be the major factor causing the myalgia. So I think I have decoded the triad TMJ teeth muscle. I will talk a little bit about the teeth. The teeth are having odontogenic pain, non-odontogenic pain. But you have to consider that all these odontogenic, non-odontogenic pains have the referred pattern to the TMJ area. Like even the pulpal pain or peripheral pain, periodontal pain also give the referred pain to the TMJ. Then non-odontogenic comes into the myalgia, then neuritic, neurovascular, sinus, cardiac, then even glossopharyngeal neuralgia can refer pain to the TMJ and teeth. So all these things are there. So it is not about only orthopedic stability. It actually is a multifactorial approach is very important while considering this trial. So decoding the triad, it is a multifactorial approach. So conclusion, be diligent in establishing a differential diagnosis. Don't be in a hurry or start trimming the teeth. Reproduce the patient chief complaint, because many times the source of the pain and the site of the pain may be different. Systemic factors always take into the consideration. Always have a multifactorial treatment plan. If you want to refer patient to ENT specialist or MD medicine or rheumatologist or other kind of faculties, you should not hesitate to for that. Our aggressive non-reversible treatment or procedure, because you can go forward, you cannot go back, and that's why I'm telling, don't go directly for the trimming of the teeth. Observe treatment outcome. You have to always observe and have a holistic approach. Holistic approach is most important because show the empathy. Always patient is not like that is a psychosomatic pain and there is no such thing like that. There is no pain. Please understand the patient and have the empathy towards the pain. Explain why this is happening with the patient. Tell the patient how you can change your lifestyle and it can give even their eating habits. So you have to do that. And at the end, it is only a pain management. You are not, you certainly cannot say that, okay, I can cure you. It's a management. So thank you, Dr. Sonal and IOPCON for giving me this opportunity to give my presentation.
Thank you, Dr.
Thank you to my husband, Dr. Sachin Kere, and my lovely child who is always supportive.
There's a surprise here. Dr. Davis Thomas has joined us, and he was listening to your lecture. Dr. Thomas, Dr. T, are you there?
Yeah, I'm here. I just want to say hello to everybody. Fantastic program. Neelishri nicely presented. I was to the last half of it. I'm not yelling out because I'm on a ship still. It's still, we're on the cruise. So beautifully done. You know what? I'm so proud of you all. It's just, you guys have taken it to the level that I've seen in certain professional organizations. So beautiful job. God bless. I'll mute myself. I know you guys are all
Thank you,
in a
sir.
time
It means a
limited
lot to
fashion. So
me, the words coming from your mouth. Whatever we are having knowledge, is because of you. And I'm really happy that you saw my presentation.
Yeah, she was nervous yesterday night, Dr. T. So, and it was all like, because will Dr. T see my presentation or no? That was also a question in her mind. I'm glad, Dr. T, you
you're
were
a
here.
natural.
Oh, great.
Yeah,
And
you're a natural.
we have Dr. Chenna Singh with us now. Any questions can be answered in the chat box. Earlier speakers, please visit the chat box because there are many questions still there for Dr. Divya and Dr. Valli. So please answer these questions. And yeah, Dr. T, how was your evening yesterday when you joined us as a patron for our Congress, Dr. T? So what would you say? I know
was just
it
Go
was
ahead.
overwhelming that you could join us from your cruise. I can understand it was difficult for you at 5 a.m. in the morning. That's a kind of dedication we all want to have it in us. Like, you have already set the bar so high for us that we already want to become Dr. T. Like, at least get some part of what dedication you have. So how was your evening? I would want to know that, Dr. T.
Well, when I joined, I did not know, again, I knew I was presenting a short while, and then students meaning my students, your faculty, our faculty. But being the patron of this program, for me, it's not just like coming on for 5 minutes and then disappearing for the next 3 days. That doesn't work for me. So today, again, I have a lecture in 3 hours. Like I said yesterday, if I can do it, you can do it. I'm going to teach a bunch of physicians again on pain and sleep in the next 3 hours. I have a 2-hour session right now. They're all MDs from the US. So if I can do it, you can do it. And I think you are all at that cusp where you're beginning to really flower, bloom completely. I'm so happy when I'm seeing this. Let me tell you this, not many teachers will have this much fortune, that I know. I've known so many teachers and mentors. Not all their students are, presenting and lecturing. I was just so proud of you all, and sort of proud of myself too, that I led you through this journey from years ago to now. So, but thank you, by the way, making me a little patron of this. And I could not be there full time. I apologize for that, but it's a preset program that I have to. But if I was available, I would have been here. So I'll remain for a couple of more
Backbone,
hours.
the backbone, as I say. And we have a new nomenclature now. Dr. Maithili and Dr. Davis Thomas are the grandparents of orofacial pain now.
In India. Maithili was there yesterday, right?
Today, she presented today. So if you are
Today,
with us,
okay.
we have Dr. Chenna Singh today presenting our next speaker. Dr. Chenna, are you there?
Sure. I'm not sure if she's there, but I'm going to mute myself. Thank you. Sonal, I have to tell you, Sonal, you're muted now.
Yeah, Dr. We have Dr. Shrishti Todi, our next speaker. Dr. Shrishti, are you there?
Yeah, hi, I'm there.
Okay. Yeah, Dr. T, you were saying something. Sorry about disturbing you.
No, the level you've taken this online stuff is so you're one of a kind. So, and your organization, and yesterday I was talking to Ritin, right? Ritin is
Yeah,
somewhere
Ratin
here.
does. Yeah.
Yeah, so it's unbelievable, the level, and God bless you for that, and continue the good work.
Thank
And
you.
thank you. I listen in.
Yeah. So we have Dr. Shrishti Todi with us. Dr. Shrishti, can you switch on your camera? Yeah. And go on a presenter's mode. And please unmute yourself, doctor. Dr. Shrishti, please unmute yourself.
Yeah, just 1 second. I think there was some glitch in it. Okay. Yeah, now I think it's okay.
Yeah. Okay, let me introduce Dr. Shrishti Todi first. Dr. Shrishti practices in Mumbai and is a founder of Orofacial Pain and Sleep Clinic. She graduated from Nair Hospital, Dental Hospital and College in 2013 and completed 2 years postgraduate residency in Orofacial Pain and Dental Sleep Medicine from the University of California, Los Angeles, USA in 2017. Dr. Todi was one of the youngest diplomates to be board certified by the American Board of Orofacial Pain. Her practice is exclusive to pain and sleep patients, and she consults with eminent ENTs and pulmonologists in Mumbai. Dr. Todi has presented on orofacial pain in various conferences and has published articles in internationally renowned journals. And you were a part of our forum last year also, I guess, suppose. Yeah. Dr. Todi, welcome. And Dr. Davis Thomas is also here to listen to your lecture. So welcome, and the stage is all set for you.
Thank you. Thank you so much, Dr. Sonal. Hi, everyone. Good afternoon.
Hi.
Hi. So my topic today is psychology of pain management. So what I'll be discussing in today's lecture is, the mind and body connection, how pain is not just a physical experience, but it, sort of influences our overall state of mind, how we feel, how we behave, our thoughts, and the interaction between all of these different systems and how they influence the overall pain state. I'll also just be touching upon some of the treatment modalities that are commonly employed in the management of chronic orofacial pain. So I'm sure everyone has seen this definition of pain a zillion times. What is very important and very interesting to note in this definition is that pain is described as an unpleasant sensory as well as emotional experience. So it's very important to remember the emotional aspect of chronic pain. Because, in practice, we often see patients that have pain for, maybe months, sometimes even years, and they're going from doctor to doctor trying to get some answers. But most often cases, they don't have a lot of answers and the pain is just, continued on. And many patients are very emotionally distressed by this pain. It's not a, it's very different from having acute dental pain where, you have pulpitis, suppose in the tooth, and you go get a root canal done, and within a few days, you're feeling okay. When we're dealing with orofacial pain, very often it is chronic. Patients have, gone months and years without answers. So there's a very strong emotional aspect of the pain, and this influences the patient's life, what they do, how they interact, with whom they interact, what they eat. Now, food is such an important thing to all of us, and if all of a sudden now there's a certain category of foods, their favorite foods they can't eat, and for a long period of time, it can really affect how a person, lives. So it's very important to have this compassion in your mind and, a sort of know that you're dealing with patients that are, quite affected, mentally affected by the pain as well. So coming to the prevalence and impact of orofacial pain, it is a fairly common issue. It is not something that is, unheard of or not seen in very commonly. And the prevalence is higher for middle-aged women. And the impact that the orofacial pain can have on daily life can be physical impact where there's simply pain, emotional impact where a patient is stressed out or very frustrated with this unremitting pain. Socially, it can impact a person's life. They may not want to go out, they may not want to laugh too much, they may not want to eat certain foods. And economic impact because it costs to get treatment, and also because of work absenteeism, wherein the patient is not able to go to work and perform efficiently because the pain is so severe. Again, this is a very common diagram, the axis 1 and axis 2 of orofacial pain, and any book that you look at or read in orofacial pain will have this diagram, and it talks about the somatosensory input as well as the psychosocial input. So axis 1 is something that we're quite used to dealing with and thinking about. So it is a physical aspect of pain. So the physical conditions that actually cause pain. So it can be TMJ pain, it can be muscle dysfunction, it can be some nerve-related pain. And axis 2 is the psychosocial input. So any mental health conditions or disorders like stress, anxiety, which also affect the pain state. Now, when pain is more acute and not a lot of time has passed, there's a preponderance for axis 1 input. It is, more to do with the actual physical ailment. And as time passes, the chronicity of pain increases. We see a greater psychosocial input. There is more mental health contributing to the pain, and that leads to increase in suffering and pain behavior. So as time goes on, as pain becomes more and more chronic, the disease itself, which initially caused the pain, sometimes may even not be, contributing to it so much. Then pain stops being a symptom. Usually we talk about pain as being a symptom, but in certain cases, the pain itself is the disease. The pain is not a symptom anymore, and that is what we have to tackle with. And you have to talk to the patient and make them understand that you understand where they are coming from. Because a lot of time patients, they go to see doctors who aren't adept with dealing with chronic facial pain. They may sort of dismiss it, say, oh, it's in your head, it is psychogenic. But you have to make the patient believe that the pain is real. I mean, of course, there are rare cases where the pain is, in the head, but that is very rare. Most of the patients have a very true and real experience. And you have to, understand and empathize with the patient so the patient knows that they're in the right hands. And so you have to be aware of these conditions to have a proper comprehensive treatment plan for the patient and to, approach it from a multimodal point of view. So now this compares the old view, the 16th century Cartesian view with the modern view. Earlier, pain was thought to be linear. It was, directly related to nociceptive input, wherein, you touched fire and the signals went up to your somatosensory cortex and there was pain, and that it was just, it was perceived as pain and that was it. But now that we know that pain is not linear, it is it is complex and it is subjective, and it is subject to various pro-nociceptive and anti-nociceptive modulation. And the combined interaction of all of these modalities, our past experiences, our current mood, that is what produces a pain perception or a pain state. And any altered interactions in these can lead to pain chronicity. Now, these are the three main or the three most common mental states that, all of us know of: stress, anxiety, and depression. Stress, a heightened stress level can lead to an increased muscle tension, and it can cause inflammation, and it can exacerbate pain because now the muscles are more tense. Anxiety is basically when we're anticipating something bad to happen. That is what anxiety is, fear of the unknown. And when there is increased anxiety, there is increased anticipation of pain. You will feel more pain. And depression sort of leads to altered coping mechanisms, and it leads to lower pain thresholds. So as orofacial pain specialists, we should at least know the kind of, mental health states that can occur. We should be able to sort of identify them. We should be able to talk to the patient. We may, of course, not be able to handle all of them. If the patient has a little bit anxiety, regarding their pain, sometimes, how much you talk to the patient may be enough, but sometimes they may need more intervention. They may need a referral to a psychologist or even a psychiatrist. But you should be able to talk to your patient. You should be able to handle such a case. You should be able to, approach it in a way where the patient doesn't feel attacked. Because in India, we have to remember that mental health still is somewhat of a taboo. a lot of patients, are very resistant. They don't want to hear about it, or, sometimes the family is resistant to it. They may not, want the patient to go. They may, say that, oh, it's nothing like that. She's just overacting. And, usually it is a female, and, the males in the family may not want the person to get mental health. So you have to be aware of these things and handle it delicately. And that can happen if you know to recognize the signs and the symptoms and then tackle it with, ease. The kind of patient that usually has mental health, or is usually predisposed to showing these signs, is someone who has a very stressful life or a stressful job. If they have a history of tolerance or addiction to some medication, or they like to get treatments very often, or someone who likes to go to a lot of doctors, who people who do doctor shopping, these kind of patients are usually more likely to have some sort of mental health condition. And patients who are more dependent on family and friends, who need constant reassurance, who have lower self-esteem, or who have a more hostile attitude. So these are some of the patients that, you should be on the lookout for. And also patient types. So there are some patients, who have a very internal locus of, belief. So they believe that they are in control of their life. They believe that they can do something. They can take active steps to improve their pain. And these patients respond better to treatment, and they, they are more willing to try things. And people who have an external locus, they believe that, the external factors are responsible for their pain. They may not be very open to treatment, and they believe that, luck or just their fate is responsible for what is happening to them. And they often indulge in wishful thinking or catastrophizing. Wishful thinking is just wishing that, my pain goes away. I wish this pain didn't happen. I wish this didn't happen to me. And catastrophizing is, believing in the worst. You just assume everything is a catastrophe. Like, if they have a headache, they believe it's a tumor, something like that. So you have to see these kind of patients. Patients with an external locus are a little bit more challenging to deal with, and they require a little more delicate handling. Now, coming to how psychological factors influence the pain pathway. So we all know of peripheral and central sensitization. Peripheral sensitization is where, just the area around the site of injury is, the neurons there, the nerve endings there are recruited, and there's neuroinflammation a little bit more localized. But central sensitization is when, there is neuroinflammation that spreads to the central aspects of the nervous system, and even normal stimulus can cause pain. And psychological modulation is very important because, our emotions and stress and thoughts modulate how we perceive pain. Now, various brain areas are involved in pain perception and modulation. So the thalamus is responsible for relay of pain signals. The thalamus is the relay center of the brain. The somatosensory cortex interprets the pain, and it, sort of processes the intensity and the location. The limbic system is responsible for our emotions. So it is responsible for the emotional response to pain. And the prefrontal cortex deals with the actual pain-related behavior, what we do of the pain and how we, make a decision regarding the pain. Now, this is a diagram that just sort of shows how pain is modulated, what are the, areas involved, and how healthy and chronic pain fibers, how they sort of differ in their relay of emotions and thoughts. Another diagram which shows, how genetic factors, how microbiome, environmental factors like psychological stress, trauma, childhood adversity, and, neuroinflammation can lead to pain, chronic pain. So if the system is resilient, if all of these factors come together, and there is resilience, then pain usually resolves. But if there's some sort of vulnerability here, then it can lead to a chronic pain condition. And this could be because of HPA axis, that's the hypothalamus pituitary axis dysregulation. It can be some sort of pathway issue. So now coming to how, coming to more scientific evidence of relation between pain states and mental health conditions. So if you see the neurotransmitters involved in pain conditions and mental health conditions, there is almost a 100% overlap. So serotonin, when the serotonin and norepinephrine levels are high, there is decreased pain and the mood is good. And similarly for dopamine and GABA, and glutamate increases pain. So there's a high level of glutamate. It's a pain, it upregulates the pain. And serotonin, norepinephrine, dopamine, and GABA involved in, keeping us happy, keeping us in a good mood, and also with lower pain levels. Similarly, when we look at the clinical implications, we see the medications that we use. For many chronic pain conditions, we may give patients SNRIs or tricyclic antidepressants. So even though they're antidepressants, these medications also act in chronic pain conditions because they're regulated by the same neurotransmitters. So this is other empirical evidence that, pain conditions and mental health conditions are very intimately related. And it's impossible to separate one from the other. When we treat one, we are automatically treating the other. And it leads to, overall the patient feeling better physically also and also mentally. So it's always, important to keep this in mind when you're prescribing drugs to patients. Now, these are two screening tests that can be very easily and quickly used in any clinical setup. It's the Beck's anxiety inventory and the depression inventory. Each has around 21 questions, and the patient, just circles the questions from mild, moderate, severe. They circle and you scale it from 1 to 3. And, it comes with and then you just sort of interpret it. And it gives you minimal, mild, moderate, and severe levels of anxiety and depression. This is just to be used as a screening tool. If you administer it to your patient, they fill it out. And if it comes up and you feel the patient requires, some intervention, then you can at least speak to them and you can show it to them and sort of explain to them what the test means. This is by no way diagnostic per se, but it's just, screening tool to have. It's a good idea to have it in your clinical armamentarium. Now, coming to the pain cycle, as we can see, when there is a disease pain, there's increase in muscle tension, there is more stress, there's fear and anger related to the pain, which leads to depression, which leads to more fatigue, which leads to more disease pain. So it's a very vicious cycle between pain and stress and depression and fatigue, and it's important to break this cycle. Now we come to the biopsychosocial model. This is a very important model when we are dealing with chronic pain states, because there is just not one factor that is responsible for pain, but it is a multimodal involvement. So as you can see, nociception to pain is a biomedical model of pain control, where there is damage to the tissue and there's pain production, there's pain perception and pain response to nociception in the brain. But the biopsychosocial model of pain says that there are many factors that influence our pain response and our pain experience. So biological factors include the actual tissue damage, any medication, any surgery, our genetics, history of prior injury. Psychological factors include things like your personality, if you're anxious, if you're depressed, what is your locus, is your locus internal or external? And social factors include family support, your socioeconomic status, what sort of work you have. So, certain patients who have a lot of family support, or certain patients, like the attention that they get. So this is called secondary gains in a chronic pain patient. So secondary gains may be someone, who's gaining from the pain, they're gaining attention, they're gaining maybe like some job benefits by having the pain. So these patients will not let go of the pain, and they like to continue with the pain going forward. Now coming to the overview of psychological interventions for pain. There are three commonly used interventions. One is cognitive behavioral therapy, one is mindfulness-based stress reduction, and the other is biofeedback. Cognitive behavioral therapy focuses more on, challenging and replacing negative thoughts and behaviors. And mindfulness-based stress reduction, it involves mindfulness meditation and sort of being present in the moment and improving pain management. And biofeedback is, you learn to control physiological responses like your muscle tension or your breathing, and, sort of influencing the pain that way. Now, CBT, it's very common, something that you hear of a lot these days, because, that is the it thing in mental health. So the cognitive model involves a situation. We have thoughts regarding a situation, and we have emotions, and the thoughts and emotions sort of interact, and there's behavior. And, the CBT involves modulating our behavior, modulating our thoughts, so that we can better manage our pain. So it's essentially equipping a patient with better tools to regulate their thoughts, feelings, and behaviors, because each of them influence how we respond and basically influence the other two aspects as well. So cognitive restructuring, for example, it's identifying and substituting negative thoughts. So, a patient who thinks they will never get better, It has to be replaced with I am learning strategies to manage my pain and improve my quality of life. And if the patient thinks this pain is ruining my life, it has to be replaced with something like, I can adapt my routine and make my pain more manageable and not go into a very negative way of thinking. Behavioral strategies, there's a lot of avoidance behavior that we see in patients that have chronic pain. So we have to encourage patients to sort of engage in light activities and hobbies that can distract from the pain, and certain things that they, work through the pain. Like, for example, if someone has a lot of TMJ pain, they aren't able to open a lot. If they will display avoidance behavior where they never open their mouth and they don't want to challenge themselves at all. It's very difficult for it to resolve. So you have to tell the patient to, slowly, very slowly work their way through the pain. You can give them the trigger point injections. You can give them, arthrocentesis, but there's still that fear of pain. There's still that, muscle spasm that won't fully resolve unless they start doing exercises lightly. So you have to, sort of explain to the patient why you're asking them to do that, what to expect. As I always tell my patients, pain recovery is never a straight graph going up. There will always be ups and downs. There will be dips and there will be, ups. So you have to be prepared for that. But as long as you're seeing, improvement overall, that's a acceptable outcome. And then you have to equip them with some pain coping skills. You have to teach them techniques and give them tools to, sort of relax themselves when they're getting worked up or stressed out about the pain and that it's never going to resolve. You have to teach them how to sort of let go of these negative thoughts and indulge in some mindful relaxation or maybe some guided breathing to reduce the stress. So now, for example, if you have a patient that has persistent jaw pain, the thought will be, this pain is never going to go away. They may feel hopeless and they may feel frustrated and they'll isolate socially and they'll avoid eating and laughing. So you have to replace the thought with, I can learn new techniques to manage pain. You replace the emotion with then empowerment and reduce stress because you teach them the pain management techniques and you teach them light exercises. You teach them to do physical therapy at home. So they feel more empowered. They feel more in control of their situation and of their pain. So they feel more hopeful. And then the behavior changes as well. And then, they will start practicing relaxation techniques. They will start going out. They will, attend appointments and they're more likely to start feeling better overall. And once they're mentally happy, the pain doesn't bother them that much. And gradually there's an overall reduction in pain levels as well. So there have been numerous studies. And most studies show that CBT is very effective in chronic pain conditions. It's medically proven, and it's in certain cases it's even accepted as the first line therapy for pain management. So some of the relaxation techniques that you can use is deep breathing, progressive muscle relaxation, and guided imagery. You can always send your patients, some YouTube links, and there are all these apps you can download on your phone, like Calm and mindfulness apps that can sort of Headspace, and that sort of helps them indulge in these techniques whenever they feel more stressed out. Next is biofeedback. Biofeedback is a non-invasive technique and it teaches patients to regulate their physiological functions in real time. So basically what this includes is a setup like this, where there are numerous leads attached to the patient. You may have like muscular leads and attached like a EEG lead. And there's a screen in front of the patient, a monitor. And the monitor will have like a audiovisual display. And you'll have a pulse ox attached to the patient. And that will be shown on the screen as well on the side. And it can have something like, a black and white image. And then the patient is given instructions to, sort of take deep breaths and slow their breath down, activate the parasympathetic nervous system. And suppose the parameters are set. So the parameter could be set that, once say the heart rate is below 75, for example, the image will start filling with color. So it could be a black and white image. And as the patient breathes, practices deep breathing and the heart rate slows down, color will appear on the screen. So the patient is taught this. So they can see that. They can see as their breath is slowing down, there is, color filling up. And then that's how they learn to sort of, regulate their own physiological functions. They can be taught how to relax their muscles and they can see it on the screen. So that is biofeedback, because the screen is giving you feedback about your muscle tension and your heart rate. So it's again a very useful technique for patients who are very hypo and who have a hard time controlling their breath. Mindfulness, again, it's one of the hottest things in mental health currently. So mindfulness is being aware and being present and accepting your thoughts. It is not allowing your mind to well, it is allowing your mind to jump around, but not dwelling on where your mind is going, trying to center yourself, trying to do, what you're doing. So mindfulness even includes something like mindfulness eating. So if you're eating your food, you just eat your food. You don't watch a TV, or you don't watch TV, you don't read a book, you don't look at your phone. You're just present in the moment and you focus on what you're doing with your full attention. And if you have any thoughts and feelings, you're non-judgmental about them, they enter your mind and you just let them float away without engaging in it. And you accept the experience as it is. Some days you may be able to indulge in mindfulness more successfully, some days not so successfully. And that's okay. So this is just a little, chart on mindfulness where you minimize multitasking, focus on one thing at a time. You spend some time in nature, you live in the moment, and you have a very non-judgmental approach. And you can meditate on that also. And again, in meditation, very often, patients say that they have a hard time concentrating. They feel that the mind is wandering. It's very difficult to keep the mind steady. But mindfulness allows that. It says, don't be judgmental. Just don't engage in the thought and bring yourself back to the present if your mind wanders. Again, some exercises to teach your patient is just, mindfulness body scan where they breathe deeply and they, focus on muscle groups and gradually relax each. And 5, 4, 3, 2, 1, it's a senses exercise where, you sort of go from the external, from seeing things to things you can taste. So from an external, sense to an internal sense, and that centers us and brings us back to ourselves. Now, it's important to integrate mindfulness into our dental practice because, it helps us to communicate more efficiently with our patients. There's more mindful communication. We have more empathy, and it helps in better pain management. It, creates a calm atmosphere, and it's overall very good for us. Most of us lead stressful lives, so it's good to integrate it into our daily practice, and even personally, for ourselves, it's a very good, practice to develop. Now, just some benefits of psychological intervention. It's a more holistic approach. You have improved outcomes. Patient will report a better, better pain control. They will have reduced medication use. And again, most patients want to go off medication. They don't want to, continue with medication long term. So it's very effective in these settings. And there is absolutely no harm or no downside to having, a psychological approach to what you're doing. And you should always collaborate with mental health professionals. An interdisciplinary approach is very important, especially with patients with chronic orofacial pain, because you can't handle all the cases. You can't handle a very complex case. You can't handle someone who's having pain because of a past trauma or because there's so much going on in their life. So you should have an open channel with a mental health professional. You should have someone you can trust, someone your patients can trust, and you should come up with a plan that takes care not just of the patient's physical well-being, but also the mental well-being. Because as we saw earlier, both interact, both interplay, and then we experience life. None of us experience life in just one dimension. All dimensions come together. So similarly, in our patients and people who are having some sort of disease need to be taken care of in a well-rounded manner. And lastly, you don't have to control your thoughts. You just have to stop letting them control you. That is very important. You'll have a thought, just let it go and do something more progressive and something that's very effective. So thank you for having me. And thank you, Dr. Sonal, for this opportunity. It's been great. Thank you.
Thank you, Dr. Shrishti. In fact, your lecture is something, forget about being an orofacial pain specialist or a patient. This lifestyle, if everybody adapts to, we will have healthy homes, I would say, mentally healthy homes also. So, Dr. Thomas was listening to your lecture. Dr. Thomas, any words for Dr. Shrishti?
Oh, nicely presented. As I was saying yesterday, this is my topic today, but at a little bit more deeper level because my co-lecturer is a professor of psychiatry, and I'm talking to physicians here on the ship. So from this, you take up to psychiatry and pain, psychology of pain, medications that can affect both pain and psychiatry, plus pain, psychiatry, and sleep. That'll be a nice little adjunct to this as well. Nicely presented, Srishti. I've never met you, but I've seen your name on this circuit. So great, nicely done. Very nice job. Yeah.
Thank you, Dr. Srishti. It was pleasure having you. You can check the chat box in case if there are any questions for you.
Thank you so much.
Next presenter is our very own Dr. Chenna Singh. She had some technical glitch. So, welcome, Dr. Chenna, and yeah, please go ahead with your presentation.
Very good evening, and sorry for this technical glitch.
That's
and
okay.
For,
Happen with all of us.
thank you, ma'am. First of all, I would like to thanks to Dr. Nural sir and Sonal ma'am for again giving me a chance. I am joined with these two people from past 3 years. I am a part of NHA from past 3 years. Thank you, sir. Thank you, ma'am. Now I am starting with my presentation titled Unrevealing the Real Orofacial Pain. Why I have chosen this topic? Because I have seen in my college, in my department, I am from Department of Oral Medicine and Radiology in PGI Rohtak, and I am practicing here the orofacial pain. And from the time I am in contact with Dr. T, he is my mentor. He is a very good person, very humble, and I see most of the patient is coming to my department with passing through a lot of circus, tooth got extracted, having the pain, but the things remain undiagnosed. So I have put a little bit of effort in giving for making them pain relief so that they may be happy and they can live their happy life. So starting with my presentation, these are my contents. First, I will start with the pain definition, related definitions, classifications, old and few TMD's criterias, myofascial pain, related cases with feedback, then a temporomandibular joint disorder, related cases, neuralgias, and headaches. These all cases has been diagnosed by me in collaboration with the neurology department because according to the protocol of our college, I alone can't give them medications. So I have diagnosed and referred the patient to the neurology department for the further interventions. So according to International Association of Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in such of terms of such damage. In 2020, it was revised as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So this is a classification I got from Bell's Orofacial Pain 7th edition, in which they have categorized the musculoskeletal disorder, neuropathic disorder, neurovascular disorder, primary headaches, and the mix. So I need not to again and again explain about the what is a trigger point, how does they form, because Valli ma'am and Divya ma'am has very well explained about these things. So early it was known as the myofascial pain distress syndrome. I don't know why it is known as the syndrome, because syndrome is the combination of many diseases. But if we follow the DCTMD criteria, it is well to diagnose on the base of these criteria, that is local myalgia, myofascial pain, and myofascial pain with referral. Local myalgia is pain to a particular area in a muscle. Myofascial pain in a same muscle to the multiple area, and myofascial pain with referral, pain here and the patient will pain here. So the source and the site will be different. So it will be beyond the anatomical area of a particular muscle. Then we called it as a myofascial pain with referral. This is a trigger point chart that I got from Travel Simons and Simons, which is a Bible for the myofascial pain or the trigger points. This has already been explained by my earlier speakers. I'm showing this chart because this will give a little bit of glimpse about how I have diagnosed the patient. So don't rush if you see a patient in a pain to a particular. First, just listen to him or her calmly, and then take a step in diagnosing it and thus for the treatment. It is not so the patient is coming for the pain and yes, I will do. No, just sit and listen to them. They are suffering from the pain so many years. They have a lot of pain, stress. So they all are related to increasing their pain. So please listen to them. Don't irritate from them. Then listen to them. You will reach to a diagnosis possibly. Then the key point should you have in your brain when you see a muscle, how to palpate a taut band. Okay, they are different method. Ma'am has already explained that is the flat palpation method and the pincer method. The type of needling, wet and the dry needling, methods of ticket point injections, which needle to be used and where to be used. Oh, we have two needles, hypodermic and the filiform needles. So to the vital structure, we should use the mostly the thinnest needle, large gauze needle, so that the vital structure could be prevented. And what could be the contraindication, precautions, and the main thing, what can be the reasons for the failure of the trigger point injections that you should have in your brain. It is not mandatory, it is not compulsory. You are giving a trigger point to a patient, it will be relieved. No, because in that case systemic factor should come in your brain. It is not that local factor because of that muscle is coming to that side. If the patient is not really, don't get stressed, take the systemic factors into your brain and then start with the cases. So here I am sharing few my cases which is treated by me because of the guidance of my mentor, my guru, Dr. T, who without whose effort it was, I have not even thought about कि ये भी कोई speciality हो सकती है. Fine. So people are not aware from this 12th or to be specialty.
Dr. Chenna, you can reiterate what the patient is saying.
Okay, here the patient is complaining of pain to the masseter area locally and the lateral pterygoid, and you will not believe this patient is suffering from 2 years from the pain and taking the treatment from the ENT for the pharyngitis, but no relief. After passing through this whole of circus, he came to our department. When I saw, it was a local myalgia to both the areas and bilateral local myalgia to the masseter and myofascial pain with referral from the bilateral middle pterygoid. No adenoids was enlarged. I inspected everything. No tooth was tender. I inspected everything. So it was also, he was also diagnosed with the temporal tendonitis, and I injected to the temporal tendon, giving to injections without adrenaline. I did the wet needling. Then he was relieved. So after the, can you imagine 2 years of pain is how much we can't even tolerate a single ant bite. How he is suffering from the 2 years of pain, and he got relieved after coming to our department. So what was the mystery in this? The mystery was that he was suffering from the pharyngitis from past 2 years and taking the medications but not relieved. But I raised the curtain from the diagnosis, and diagnosis was this. This all three things were the diagnosis, and he is relieved and he's still on the follow-up. Then he was telling some itching to this area and the pain to the preauricular region. He got treatment from ENT specialist and was relieved for that. And he complained of pain, he complained of pain to this area. Even though he got treatment from some ENT, okay, earache was relieved, but still the pain persists. Then he came to our department. Then we gave injection to the temporal tendon because to the respected area temporal tendon was temporal tendonitis was present, and that was referring the pain to the temporal region. What is temporal tendon? It's a muscle, they are attached below our zygomatic arch to the neck of your coronary plexus. Okay. Then the third case is this was the patient came from the OS department. He got a roadside accident and got fracture into the right temporal area, and he didn't want to go for the surgery. Moreover, the oral surgeon advised it was a hairline fracture, so need not to operate it, let it be for the onset on healing. Then they were suspecting the post-traumatic headache or some migrainous pain. Then he came to our department. He can't be a migrainous pain because no earlier pain was felt in his life till the date. From the time of his pubertal to the present till date, he was not suffering any headache. So migrainous pain was out of, it can't be, although it was in differential diagnosis when I first saw him, but no, it was not my provisional diagnosis. Then I inspected all the muscle, the the masseter was tender, then that's why he might have a pain to the respected teeth and the alveolar ridge. Then maybe the pain to the preauricular region, referral pain from that area. Then I diagnosed it as a right temporal tendonitis and local myalgia in the right superficial masseter. Then how I injected to the temporal tendon, you see I have placed the finger laterally, not on the molar region. I have rotated the finger and little stretch it and delineate the coronoid process and injected into that area. The pain was relieved, force was reduced, and I injected the temporal tendon, anterior temporalis, because I want to target both source and the site, because the patient was in much pain. So I blocked followed the source and the site, because first you have to reproduce the pain, the familial pain for which the patient has come to you for the main complaint. Then you have to locate the source, and then you have to see the site. Okay, these are the three main pillars through which you will help in diagnosing the orofacial pain patients coming to your clinic. Then this is the fourth case. This is the referral from the neuro department, from our department only. The patient complains of pain in neck and the ear region from 2.5 years, on medication but was not released. Moreover, he was taking the medication for the cervical spondylitis also. Then he was referred to our department for the diagnosis and the further intervention. How I treated him is the way. Sorry. We have to hold it very intelligently, because many vital structures are present to that area. Carotid, in our external carotid artery, external jugular vein, internal jugular vein, because then they join to the cercosophilia, then to the heart. So very careful. So the was reduced after that, and patient was very happy because he suffers from this pain 2.5 years. And my diagnosis was right sternocleidomastoid myofascial pain with reference, because he was telling the pain goes to this area and the back of my ear, post-auricular region. So I diagnosed this as a myofascial pain with reference, which was not diagnosed even by the neuro department. So they referred us to me for the further diagnosis. So can you see how this robust education given by my mentor have helped me to release the pain? So patients are suffering from pain 2.5 years, how much that they have gone under the stress. And I'm here, touch wood, God grace, I'm treating the hair patient very happily, and patients give me blessing. I feel very happy. I can eat the food very happy. See, today I have treated the patient, that's all. Okay. Then I will share about few cases about the temporomandibular joint disorder. See, these cases are although a direct one. So there is no any confusion in that until unless you are not aware how to diagnose it. So patient is telling she is relieved. She was complaining of pain whenever she clenches. No muscle was tender, nothing was there. Only to the particular area she is tell the pain. So I injected to that area intraarticular injection of Canacort 10 milligram. She was relieved. I have given him a anterior repositioning, so should not impinge to the retrodiscal area as it was already inflamed. So I recalled the patient and she was relieved. Then another case of the capsulitis. She was complaining the pain while earning. Nothing pain was, no lateral tertiary movement, nothing pain was there. She complained of pain was there. Only give her the deprogrammer to that area. Rejoint was given as it has the glycosamine glycans, which is the part plays a very good role in the joints mobility. And this was the ADD with reduction. So the question may be asked here, ki the patient have a clicking, so no need to give the treat. Yes, I agree. I send the patient after assuring, so you need not for any treatment, nothing. You don't need anything whenever you complain pain. But as you can see, he's a young. He was more aware from these sounds. He told some tuck tuck sounds come from my seat. So I don't. Yeah, it is clicking. It was deviating. Okay, then. I advise him a soft occlusal spleen just as a placebo, okay, so that he can have a mental relief. He is getting some treatment, and put him on the rejoin, and he was relieved from that. You can listen.
Dr. Chinna, the voice is not audible, so maybe you could reiterate what the patient is
Okay,
saying.
ma'am. Okay, I will give him orthotics and even rejoin and the adjuvant therapy of moist heat fermentation as it was a chronic, so he was relieved. Okay, let's move to another case of ADD without. This is with reduction and this was the ADD without reduction. This the pain was suffering from 8 to 9th month, so it's a chronic. As more than 3 months, our book says occasion, our Bible it's a chronic. So here the patient complains of 2-finger weight. Patient was not able to open the mouth more than 2 fingers. So definitely translation was not done by the joint, was not going properly. Moreover, he was complaining of pain to the masseter, middle pterygoid, everywhere. So these were the trigger points marked and was injected properly. But he little bit of pain was relieved, but not as that much I was expecting in this case. So now the question may be asked, why didn't you perform the arthrocentesis in this case, as it was the ADD without reduction? Patient was not ready. She was have a needle phobia, so she refused. She refused, but she want to be fine. That was a very difficult situation for me because I know ki arthro is the should done in this case. It will give him a very good result. Prognosis will be good, but it was very difficult for me. Then I tried the Prolo also. Should go for the Prolo. Okay. She was not ready because again the needle phobia. Somehow I convinced her for the trigger point injection because she gave the history of stress also. So I didn't want to give her more stress. So I advised him a deep repositioning spleen. So OPG was done. So you can see this is the condyle and this is the fossa, and you can see this is the your open mouth and this is your closed mouth. See in the closed mouth, condyle and the fossa is the both are in the position in the closed mouth, and you can see it has been it has no translation is there, but translation is there. Although it is beyond the anterior to the eminence, so the chances maybe the patient have a subluxation or hypermobile. So she also complained of pain into the neck region when she flex and extensibility was there. So in that case, I gave him some the injection to the posterior occipital muscles, but she was little bit of 1 to 2% of she was relieved. But at the back of the brain, I was somewhere suspecting the cervicogenic pain also. So I advised the C1 and the C7. In the meantime, I also advised for the vitamin D and it came low. So I put in the patient on the vitamin D sachets and all on the dead. And I advised the C1 in C7. She basically diagnosed for the cervical spondylitis. The pain she was suffering from 8 to 9 months in that area. She was it came to be a cervical spondylitis, and the other pain she was relieved from taking the medications and mouth opening exercise and the deprogrammer, all the adjuvant therapies I have to give her because she was not ready, very stubborn for the arthrocentesis. But I try my best and patient was relieved. This is the feedback from the patient. 2 months. Yes, he was complaining earlier pain was high. Complaining of pain here. Trigger point injection was given. Isometric exercises was given. She is 50% relieved. So now I came to the neuralgias. We all are aware from the neuralgias, but the pain is So paroxysmal lancinating, that is intolerable to the patient, and 26% will commit suicide as a result of the severe pain. That's why it is known as the suicidal disease. This is the classification, okay, given by the ICHT. They have given trigeminal neuralgia with paroxysmal pain, trigeminal neuralgia with the concomitant pain. So this is a pain. The patient in this have a pain on the right side from 5 years, taking medication from the general dentist for same, but was not relieved. Then she came to our department for the proper diagnosis and the intervention. She was complaining from the V2 region, was not able to speak, was not able to even eat the chapati. She is telling, she is complaining of pain like the electricity socket, electricity come, light ka current. So I got a clue that she suffers from the, it was the concomitant pain, no paroxysmal pain. She was not even able to drink the water. No drink, no eat from 5 years. Can you imagine how the patient was surviving? See. Now she is able to eat 3 chapatis, she told me. I was so happy for her. Okay. Then this is the pain. First I will explain. Sorry. This is the patient came to me. She referred from our adjacent center, as our center is the tertiary center. So the peripheral centers used to refer the patient to us for the orofacial pain. PBS Khanpur Kala Sonipat. So this patient suffers from 25 years. Even she has gone through the extraction from that area, and you will see the edentulous area in the pictures from that respective region. And even the alcohol block was given, and after the alcohol block there was the ulcer-proliferative region. Although it is a common side effect of that, ulceration to the site of injection is a common side effect for the alcohol. But that when I saw that ulcer, it seems to be like a ulcer-proliferative region. Send the patient for the exfoliative cytology, plump nuclei came. I was also suspicious about, they also wrote on the reports. I will show the reports also. They show they have to put the patients on the follow-up so that it will not convert into any malignant ulcer. So listen. Sorry.
Doctor, you'll have to reiterate. We cannot hear anything from the patient.
Okay, this the patient suffered from the electric shock-like pain from 25 saal, 25 years of pain. Okay, she came 2 times to the oral surgery department. Okay, they did the neurectomy. Okay, they did the, sorry, not the neurectomy, they did the extraction from that respective site. Okay, it may not be the neural origin, it may not be the trigeminal neuralgia, maybe because of the teeth, because you have the carious teeth. Okay, she got extracted from that. Okay. So the medication was giving carbamazepine, Pregap, and the mucopain was given. So the every pain that transferring to the cortex was cut down so that she will be relieved. Okay. So this is the reports. You can see the plump nuclei. Okay, it may be secondary to the inflammation also. So I sent the patient, but as instructed, as guided by our mentor, we have to go for the blood investigation every 2 to 3 weeks, or it is given into the bucket, which is the Bible for me, as I am an oral diagnostician. So when what I saw, the platelet was decrease in that case. So I shift the patient. You can see I have written here as the changes in the blood parameter. So changed of the CBC was done. I had to put the patient on Pregap, gabapentin, because all the other parameters were normal. So this is the healing area that I am talking about. Here she came after the alcohol block. It's have a typical ulcer-proliferative lesion, but because there were the 2 sources of pain, one was this ulcer, another was a neuralgic pain. So you can imagine the pain intensity, because in neuralgia the pain intensity may be 9 out of 10, and this ulcer was also contributing into the pain. Can you see? Can you think about it? How much of pain she was suffering? But now she is happy. She is fine. Okay. Then we come to the neuropathic pain. If the patient came to me with a burning mouth from past 3 years, and in our medicine, to the PGI medicine one, they diagnosed it as the anemic glossitis. But my diagnosis was the burning mouth syndrome. As I sent her for the hemoglobin, her hemoglobin was 13 grams per deciliter. It was fine. No history of GERD, nothing was there. So even though the vitamin D was also normal in her case. She have a glossodynia. Okay.
Doctor, we cannot.
She's fine. She is fine now. Okay, I have given her a soft glycerin because I saw the indentations along lingual indentations along the lateral border area. I thought कि someone's tooth is compressing, hurting. Either the tongue is enlarged or the mandible is constricted. So I gave just act as a barrier between the hard tissue, which is the teeth, and the soft tissue, which is your tongue. Nothing apart from that. Okay. She was happy, treated. Okay. Then I come to the headaches of cephalgia. I have treated only 2-3 cases of headaches. They come under migraine, cluster headache, chronic paroxysmal hemicranias continua, and the SUNC or SUNA also. Okay, this is the patient came to me. The pain on the left side of face and the neck from past 1 year. The pain was gradually evoked. Frequency duration last all through the day. The VOS was 7 to 8. It was chronic progressive aching type of pain, aggravating or increasing the movement, tilting the head, relieving from the analgesic. And she has passed through she has a bundle of prescriptions with her to show me ki, as it was undiagnosed case. She is taking the paracetamol and she is taking the aceclofenac, chlorzoxazone, everything she is taking. Okay, she was taking. Then other associated factors was heaviness on the left maxillary sinus region. But at that, when I see her, at that time I was not in the sir course, Dr. T course. So it was just I thought, okay, she is suffering from the maxillary sinusitis, as every dentist think. Okay, because on the bending she was having the pain into this heaviness into this area, in this area. I thought she may be suffering from the cervical spondylitis. This is not our department case. Okay, then she suffered from the COVID in 2020. FES was done, took medication, and she didn't come to me back. But after 2 years, when she came back to me, at that time I was done with my fellowship. Okay, when she came, then I was little bit near to the diagnosis. Then I palpated the upper trap. It was tender, and this posterior cervical muscle was also tender. And she has pain to the preauricular. That typical inverted question marks areas of targeted areas were referral areas were there. Then I gave two diagnoses of the myofascial pain with referral in relation to left and right upper trap muscle. Okay. Then the trigger point injections were given both the sides and the posterior cervical muscle, and was reduced. Then she was on the follow-up. She was relieved with the physiotherapy and everything. Then she again came after the 2 months of follow-up, but still having the heaviness in the right maxillary sinus region. And the pain quality changes from aching to the lancinating type. And I thought how what it could be. Then again addition of laterobulbar pressure, photophobia, phonophobia, barophobia, nausea, relieving factor stepping out from the room. Then a differential diagnosis of migraine came to in my brain, but which hindered me not to be diagnosed as a migraine was stepping out from the room in the open air. She always says when it comes, the pain and everything is there, I feel very suffocating. Okay, then I thought it can be sympathetic pain, but one at which thing lead to me the diagnosis was the stepping out from the room in the open air. Okay, what to do now? I give the intranasal topical lignocaine injection and the pain was reduced, but still heaviness and the retrobulbar pressure was there. Then I gave it as a cluster headache. The patient was referred to the neurology department. They also diagnosed it as a cluster headache. But back of the brain, the differential diagnosis were typical migraine, maxillary sinusitis, and the trigeminal neuralgia. But I progressed is as a cluster headache. Aerobic exercise as alone was advised. Oxygen inhalation 5 ml for 10 minutes was applied, and sumatriptan, and she was relieved. Then she could not come. Then I talked to her telephonically and she sent me this feedback. Then this is a one more case. The pain on the right side of face from past 25 years. See, all the cases are chronic. 1-2 cases is acute, more than 3 months. Otherwise, all the cases is of 25 years. This is the patient is taking me treatment from me for the pemphigus vulgaris. Biopsy was done and was histopathologically proved pemphigus. One day, she told me she have a every month pain, phonophobia, photophobia, every month. Make her from till he got the menarche, till the date she's suffering from this type of pain. So one thing was clear, yes, it can be a migrainous pain. But every month coming near to the periods, that leads me to the diagnosis of perimenstrual or the premenstrual migraine. So the tab sumatriptan was given for 2 weeks, but she called me and tell, madam, I feel nausea. So I have to change the route of the administration of the drug. I give the nasal spray, which is available as the Suminet name of the under the trade name of Suminet. I called him after the 2 weeks. She was very happy. There is a one more case of migraine that I have diagnosed recently. Patient came to the chief complaint of clicking sound to the ear, but no pain was associated. So I assured the patient and said the patient, because I don't treat the patient if we have a clicking sound, because 60 to 80% of Indians, even we all have a clicking sound. So that is not but yeah, it is a pathognomonic of the further problems that we should assure the patient. When have pain and this, you come to us, then we will treat you. Okay. Then she told me the clicking sound present, mouth opening normal, temporal tendon, trap was tender. Okay. Then injection, trigger point injection was given. She was relieved. Okay. Then she told, madam, I too have few other symptoms, because you were telling to the headache. Then I asked, do you have irritation from the light, irritation from the high pitch or the sound, pressure as the environment changes, or you come here there? And sure, yes. And the duration was very particular, 3 days. Okay. Then I diagnosed first is as a migrainous headache. Then I send the patient to the neurology. You can see this is the OPT done in our department, and then the patient was referred to the neurology department. They too diagnosed as the same. The patient was suffering from 10 to 12 years. This is the feedback from the patient.
Doctor, you will have to
Yes, ma'am. She is complaining pain to this region and heaviness to this region and this region. Okay. Then we injected to this area and the temporal tendon, and the pain was relieved. But in addition to the other clinical features given by the patient, then we came to a diagnosis of temporal tendonitis and the migraine. So I would like to suggest all the dentists, my colleagues. So until unless you don't have a knowledge what is the orofacial pain, you will not able to treat the patient efficiently. So if you want a good prognosis, you have to treat patient efficiently. You should have a full grip on the subject, and that can be only possible with the good mentor. I'm lucky to have sir in my life. You should have good couple of books, because for everything sir has provided us a list of books. LELA for the headache, occasion for TMD, orofacial pain, Simons, and other books. So sir also used to give us. Yes, and we are going through that books also. So if you have a knowledge, you will reach to a diagnosis, and yes, a very good treatment that can change the life of a patient. Just imagine the intensity of the patients suffer from 25 years, 8 years. I'm daily seeing the patients suffering from the 25. Even patient cry when he used to tell his or her history. I'm in pain. I'm in pain. Okay. Even though other family members think though they are just doing the drama and all that. They came whenever they accompany the patient. ये तो ऐसे ही करती है, इसको कोई दिक्कत नहीं है. But I always listen them calmly and harmony, because I have read the what is a pain, so I can feel what is a pain they are suffering from 25 years. Okay, so the eyes do not see, but the mind does not know. So if you will not have an impression of books, what it can be, ये क्या हो सकता है, diagnosis क्या हो सकता है, you will not able to diagnose it. Okay, so these are my bibliography, and education give you humbleness, so be humble, Never be egoistic. God has given you a chance to heal the patient. You are lucky enough. Okay. Pain changes people. Some become rude, and as in case of the cluster, and some become silent, as in case of the migraine. Last but not the least, I would like thanks to Dr. T, my mentor, my parents, my husband who always stood with me, support me and take care of my child in my absence. And yes, thanks to my PGs who always help me in clicking the photographs, recording the videos. Thank you. Thank you, NHA, for giving me a chance again. Thank you very much.
Thank you, Dr. Chenna. That was a lovely collection of cases. And next time, if you could just type in those prescriptions and all what you have submitted. And we have a format, right? We follow a format for mnemonics also,
Yes,
Dr.
ma'am.
T format. So if you present that case in that format, it will be, everybody will can relate to the case very well in that situation. But a
Okay,
very
ma'am.
well collection of cases, a beautiful collection of cases. And congratulations on treating so many patients.
Thank you,
Dr.
ma'am.
T is also here. Dr. T, do you have any remark for Dr. Chenna, your old student?
Yeah. Hi, Chena. Nicely
Hello,
done.
sir.
Like I said, like Sonal was also saying, you have a nice diversity of cases. What I have noticed in you, one thing that see where you've grown from when you started the fellowship a couple of years ago,
Because of
right?
you, sir.
No, it's God's grace for you. This is bound to happen. Everything really happens for a reason. You came into the class in first module fellowship, wondering what the hell am I doing here, right? Here you are now in mastership and about to complete the same. I'm very proud of you.
Thank you,
I
sir.
know initially, first time, the language issues I thought you had, it's just a lot of that is all taken care of. I think you're observing more and reading more literature, and that's so fulfilling. More than anything, the empathy you have for patients, that is not a character I see quite often in so many people. So that every time I heard throughout your presentation that, can you imagine the pain of this patient? Can you imagine this? Can you imagine how the patient survived? See, I'm used to so many international programs, right? Hundreds of them. Right now, we're doing it on the ship here, right? For so many physicians, but only a few of them impress upon me as empathy. And the second thing I noticed is what we call in Sanskrit samprasidati, which is the content, not happy, not glad, not just satisfied, content that you have in giving these patients and they are not just boasting about it. You're so humble and being content. These things are very rare. You don't realize it until someone like me brings it up and says, "Hey, thank you, Lord, for this student." And the last thing I will tell you is this: our 100 hours is going to start in June.
Okay, sir.
I'm going to mentor you because you're going to be in the mastership program. We're going to reset these cases, same thing as Sonal said. We're going to take, let's say, 10 or 12 slides per case, and I'll let you present it. Not all of them,
Okay,
that's too many, but the 100 hours will be all cases only. It'll start in June, and there'll be pioneers. So I'm going to have you present it to our pioneers. Let's say at least 3 cases, but I'll mentor you.
Yes,
I'll mentor
that is
you to
important.
10 to 12. Jeff is going to be there. Everybody else is going to be there. Okay. June we start because you've set your goal so high, and here you are presenting to this large group. So great job. I'm going to finesse it, and then you're going to present it even higher.
Thank you,
And
sir.
these people will listen to you. The pioneers will listen to you. But I'm going to interact with you. I'm going to guide you. I'm going to hold your hand, and then you just fly away from above my level.
No,
This
sir,
is the
with
minimum
you.
level.
Under you, sir.
And then
Only, not beyond you, sir.
above level,
No,
you
sir.
fly high. But thank you, greatly done.
Thank you,
Sonal,
sir.
I'm done.
Thank
Thank
you,
you,
sir.
appreciate it.
Yeah, thank you, Dr. Chenna, and really appreciate Dr. Davis Thomas really putting in great efforts and inputs. Dr. Thomas, we have our next speaker, Dr. Sayukta Srivastava, and I am seeing her for the past couple of years. She is some person who is diligently and with very great effort. She's just trying to make TMD easy for common dentist. She, what with her videos and with her practices and the case she's been presenting on social media also, one thing that has come up is what you spoke about, empathy and understanding the patient's need. She is the one person who is also understanding the dentist's need, that they need to understand this concept very well. And I congratulate you, doctor. Not many have this caliber to put your fellow dentist at par with the education what you have and impart them. And we have one person with us, Dr. Davis Thomas, who's always eager to teach, and you are one amongst them who is always eager to teach students, and that too without any hassle. I mean, I have seen the passion with which she is making her videos, and it is really commendable. Dr. Srivastava is a bachelor in dental surgery from Indore, and she's trained in temporomandibular disorders, full mouth reconstructions, and on natural dentition and on implant dentitions. She is a DTR. She is mastered in DTR technology, aesthetic veneer restorations, and smile designing, and she is practicing in general dentistry since 2010 with special expertise in treating orofacial pain problems. She has trained many dentists in managing full mouth reconstructions and treating orofacial pain problems. And I would urge everybody to check her channel, because I also saw it just recently and I was quite amazed. And she is really doing a good job mentoring, making TMD simpler, is what I would say. Is that is Dr. Sayukta for you. Dr. Sayukta, can you switch on your camera is already on. Can you unmute yourself, dear, and speak?
Yeah, I am unmute, I suppose. Can you hear me?
Yes, yes. Welcome, Dr. Sayukta, to our International Orofacial Pain Congress. And can you start sharing your screen, doctor?
Yeah. First of all, thank you, Dr. Sonal. Thank you, Dr. Thomas, for making me a part of this. Though I have not reached up till now to a level where I can be at par with you people, but I am on my way to understand the orofacial pain as a complete in its entirety. But at present, I have managed to treat temporomandibular disorders specifically. And I have treated around more than 500 patients now of temporomandibular disorders. And I've been that is how I've been learning. So the topic that I chose to speak on today is intracapsular disorders, because those are the disorders that I have been dealing with since last 7 to 8 years most often. So it's a very big topic. I hope I'll be able to make justice to it in 40 minutes, just giving an overview of everything in this short period of time. So the intracapsular disorders are the disorders that are actually related to structures inside the temporomandibular joint capsule. So we divide them into derangement of the condyle disc complex, structural incompatibilities of articular surfaces, and inflammatory disorders of the temporomandibular joint. So there are a number of disorders, the clinical presentations of each of which are very different from each other, and the treatment protocol is also very different from each other. So it is important to understand each disorder with its clinical presentation to be able to treat them efficiently. So first, understand the derangement of the condyle disc complex. So when these are characterized by positioning of the disc away from its normal position inside the joint. So what's the normal position inside the joint? Disc is a biconcave structure which is positioned inside the joint in a resting joint state, such that the condyle rests at the junction of the posterior thick band and the intermediate zone. And when the joint is moving, the condyle moves from the junction of the posterior thick band and intermediate zone to the intermediate zone, completes rotation, and then the condyle disc assembly move forward to do the translation and open mouth to a range of around 40 mm, which is considered a normal average mouth opening. Okay. So this is how it looks on an MRI, where we can see the external acoustic meatus, the head of the condyle, and the disc. When they're closer together, this is a closed mouth position. And when the patient opens the jaw, the disc has its anterior thick band touching the condyle and the condyle moving away from the external acoustic meatus. So this is how a normal joint looks on an MRI. This is the normal positioning of the disc. Now, what keeps the disc in its normal position? So we would think that the ligaments would keep them in normal position, or the superior elastic tissue, the retrodiscal tissue keeps it in position, or the superior lateral pterygoid must be the positioning muscle for the disc, but that is not the case. The disc anatomy itself and the intra-articular pressure together work to keep the disc at its proper position. So when the intra-articular pressure is proper, the condyle is held against the fossa with the posterior thick band interposed in this space, such that this pressure is such that the superior lateral pterygoid cannot pull out the disc through this narrow space. And the superior lateral pterygoid has a constant anteromedial pull, but the intra-articular pressure keeps the disc squeezed between the fossa and itself and positions the disc there. The intact disc anatomy maintains this position of the disc over the condyle. So if you, it is very logical to understand that if you disturb the anatomy or you disturb the pressure, then the intracapsular disc derangement disorders would start. And what would disturb this? An increase in intra-articular pressure happens in parafunctions, especially in clenching and in bruxing. So whenever the intra-articular pressure is increased, the disc gradually thins down. When the disc above the head of the condyle and the condyle, keeping it there, not allowing it to slip in the narrow space, is lost. And that is how the disc starts getting deranged. Once the disc starts getting deranged, then the disc derangement disorders start. Now, macro trauma is another important factor which can thin down the posterior thick band of the disc or lengthen the ligaments and allow the disc to move more anteromedially under the anteromedial pull of the superior lateral pterygoid muscle. There is another factor which is distalization of condyles. Some people, when they are at rest, the mandible is relaxed, and when they start closing, they hit the anteriors first, maybe the natural anteriors or over contoured anterior restorations done in as a part of their smile design, and they close to their maximum anticipation by taking the condyle and pressing it on the posterior thick band, which can thin down the disc. That is why class 2 div 2 occlusions are often blamed for developing temporomandibular disorders. But that is what I want to make it clear, that not all class 2 div 2 are responsible for development of temporomandibular disorders. Only in people who have this hit and posterior slide accompanied with parafunction will have a chance of developing temporomandibular disorders. Still, if their adaptability is fine, nothing will happen. Okay. The next factor is CR-MIP discrepancy and parafunction. A lot of importance has been given to this posterior hit and slide occlusion. But in my opinion, and in the opinion of literature, occlusion is not one of the most important factors. You need parafunction to be present there with occlusion to be of any effect to cause any temporomandibular disorder. So what happens as a cause, more important causative factors for any of the intracapsular or extracapsular disorders are actually parafunction, trauma, prolonged stress, and deep pain input. Occlusion is to be thought as the last contributing factor, okay? So when all these factors act, and there is stretching of the ligaments, which happens in macro trauma or wide opening mouth procedures like third molar extractions, ligament laxities, it causes the disc to move more freely, to be thinned out, and to move outside the fossa and start the disc derangement disorders. So once the disc derangement disorders start, what happens is the disc starts coming out of the fossa in resting joint state, and it lies in front of the condyle. The condyle now starts functioning over the retrodiscal tissues, and that is what causes pain when the system is destabilized. When the patient tries to open mouth, the condyle jumps over the posterior thick band, and that produces an opening click anywhere on the opening cycle, depending upon the speed of opening and the anatomy of the disc. When the patient opens the mouth to the full extent, the disc is still over the condyle, and as the patient closes the jaw, the disc slips again in front under the constant anteromedial pull of the superior lateral pterygoid muscle, and that produces a closing click. The two clicks, the opening and the closing click, are together called as reciprocal clicks, and they occur at two different interincisal openings. The opening click occurs anywhere in the pathway while opening, depending upon the anatomy of the disc and the speed of opening, and the closing click occurs mostly near the intercuspal position. This feature is helpful in distinguishing it from structural incompatibilities of the articular surfaces and some other disorders like adhesions. Okay. So this is how a disc dislocation with reduction looks like on an MRI. So the disc lies in front, and when the patient opens, he recaptures it and closes again. Now, most of these patients are aware of a clicking joint, but they don't have any pain. Since their adaptability is intact, these patients will report deviations in their mouth opening, but I request everybody not to pay a lot of attention to deflections and deviations. They are just fun to watch, and they're not diagnostic of any particular intracapsular or extracapsular disorders. So when there is no pain, there is no treatment, but the patient is made aware that since it's a progressive disorder, if the patient develops pain around the joint, or if the patient develops a progressively decreasing mouth opening, then he should come back and get treated. Okay. The clinical examination will help us feel the 2 clicks on our fingers when we palpate the joints, and it would help us see the deflections towards the affected side. The treatment goals is pain-free function. It's not repositioning, because we have already understood that the position of the disc can be maintained by intra-articular pressure and disc anatomy themselves. Once the disc anatomy is gone, even if you touch the disc at the back of the condyle, it's going to slip again when the attachment gets elongated. Okay, so the treatment plan includes, if there is pain, repositioning appliance for 15 days, only nighttime wear so that the patient does not develop any myostatic or fibrotic contractures. Then we place the patient on a permissive appliance and adjust the permissive appliance every 20 days. What it does is that it reduces parafunction and controls it. Since every time you adjust the appliance, it causes a change in peripheral input to the central nervous system, which puts down parafunction as a protective reflex. The appliance also produces optimum occlusal conditions, but they are secondary in importance in treating these disorders. It typically takes 3 months for the disorders to be treated, and once the patient is completely out of pain, we withdraw the appliance gradually. Usually, you do not need anything more than this to treat a disc dislocation with reduction patient. If the pain reappears again and again, you have to think about a cause that is recurrent. And the recurrent cause most often is parafunction. Parafunction secondary to stress, primary parafunction that has its origin in central nervous system, parafunction that is secondary to apnea or to GERD. Okay, or sometimes some drugs like antipsychotics, antidepressants, drugs given for attention deficit hyperactivity syndrome are responsible for increasing parafunction in this patient. So you have to work on the definitive causes for the pain to disappear. Fine. If the patient does not get it treated, what happens is the disc still lies in front of the condyle, and as the condyle tries to jump every time over the posterior thick band, it stretches the ligaments and destroys the anatomy of the disc further. Now the disc does not become capturable. So what happens is when the condyle moves out of the fossa, this disc is pushed right in front and it is never recaptured. So the clicking is gone, but since the condyle moves and pushes the disc, it produces crepitus, which is felt over the joint when the patient is palpated by us. The mouth opening initially is restricted to 20 to 25 mm with coarse crepitus on palpation, and gradually as the ligaments lengthen, the mouth opening becomes normal. We see deflections towards the ipsilateral joint in initial stages, which are gone when the mouth opening is almost normal. So this is the disc that looks on an MRI like being pushed by the condyle while the patient is trying to open mouth. It is never recaptured. And if you can appreciate, the anatomy of the disc is completely destroyed. Fine. So the patient typically comes with a history of sudden reduction in mouth opening when the patient got up in the morning with a lot of pain, or a history of restriction in mouth opening when the patient was biting on something hard. The pain is coming from the retrodiscal tissues, which is the seat of the condyle now. And this pain, if prolonged, leads to secondary central excitatory effects, which are typically described by the patient as an inability to touch the scalp or comb, a feeling of swelling on the same side of face, teary eyes, stuffy nose, dry eyes, or puffy eyelids. So a number of symptoms may follow if the disc dislocation without reduction is not treated and the source of pain is constant and coming from a deep structure and causing central sensitization. Okay. Now, the acute management of the disorder, if the disorder has been reported within a week by the patient, you need to recapture the disc and ask the patient to be on the repositioning appliance for continuously for 3 days to a week for us to be able to relieve the symptoms fast and to recapture and lock the disc there so that the patient is out of pain. Plus, there's a chance of reversing the disorder this way. Once the patient has worn the repositioning appliance, and now this repositioning appliance has to be worn for 24 hours for 3 to 7 days, then you can shift the patient to a permissive appliance and continue it. In chronic stages, if the patient has had this dislocation without reduction for more than 2 weeks, the disc will most probably will not be captured, and even if recaptured, it will slip again. So it's prudent to place this patient on a permissive appliance, physical self-regulation, and NSAIDs. And if needed, arthrocentesis can be done to remove inflammatory exudates and to improve the mouth opening. Okay. Now let's talk about the structural incompatibilities of articular surfaces. So these are either anatomic variations of the normal joint or surfaces that are not smooth sliding, that do not like each other and keep sticking to each other, producing intracapsular problems like adhesions, adherences, or disc derangement disorders. Okay, so these are of the form deviation of the form of the condyle, fossa, or disc, adherences, adhesions, subluxations, and spontaneous dislocations. So talking about deviation in form, these are just coincidental findings on MRIs or CT scans. So there's nothing to be afraid of them. They happen because of either a developmental problem like a bifid or a trifid condyle, macrotrauma, surgery that produce hemarthrosis, and this hemarthrosis leads to bony remodeling, and that changes the structure of the surfaces that are gliding over each other. Or it can be due to microtrauma secondary to parafunction. Now, they may look like, they may present as a bony spicule on the condyle, or sometimes a bifid or a trifid condyle, or some structural variation of the condyle and the fossa. Since they are painless and they always are present in the patient since a very long time, the patient reports that there has been some clicking sound or some deviations and deflections in mouth opening, but it is completely painless. The clinical characteristics that helps in distinguishing between structural incompatibilities and derangement disorders is that the clicking in these structural incompatibilities is always at the same interincisal opening, whether the patient is opening or closing the jaw, and they are painless completely. Since no pain, there is no treatment. If the patient reports pain at all, it is usually due to an increase in loading of late. So you can place the patient on a permissive appliance, physical self-regulation, NSAIDs, and the patient will be fine. If the pain does not subside, especially in cases which happens in cases like bony spicules or disc perforations, then surgical correction is definitely needed. Now we talk about adherences and adhesions. So adherences are temporary sticking of the disc to the fossa or disc to the condyle. So when the disc sticks to the fossa or the condyle and the patient tries to open mouth, he tells typically that in the morning, it's difficult to open my mouth till I click once, and then the entire range of movement is fine and there is no clicking at all till I resume a closed mouth position and load my joints again. The adherences develop again, and then after a prolonged period of static loading, the patient clicks again. So in these patients, the clicking is not reciprocal and it is only once till the movement is occurring. The adherences, the treatment of adherences, why do the adherences develop? They develop due to static loading, like clenching, which exhausts the weeping lubrication inside the joint, and it causes hypoxia, reperfusion injury, which dissolves the hyaluronic acid that is covering the articular surfaces. And when they become rough and sticky, they stick to the disc temporarily. So the treatment is to decrease the joint loading, which can be with the help of a permissive appliance and physical self-regulation. And arthrocentesis does improve the movement of the joint, but usually it is not needed. Now, in case of if you do not relieve the adherences quickly, or in case the patient develops adhesion post-trauma, post-surgery, post-IMF, when the patient did not move the jaw for a very long period of time, then the disc can go and stick to the fossa or to the condyle. So if the disc sticks to the fossa, then the patient is able to open mouth only to 20 to 25 mm, and there is no clicking and there is no crepitus also. Now, how do you distinguish this from disc dislocation without production? One way to distinguish is through an MRI. The second way to distinguish is with a deprogrammer. If you place a deprogrammer in a disc dislocation without reduction patient, it will load the retrodiscal tissues and increase pain. In this patient, it will actually place it on the intermediate zone and there will be no increase in pain, and the load test will be negative. So in superior joint space adhesion, the patient complains that the mouth opening is restricted to 20 to 25 mm. Initially. Later, what happens? The ligaments get lengthened as the patient tries to open mouth fully. But then the patient reports that earlier it used to be a reduced mouth opening. Now I can open my mouth to full, but I can't close it normally. I have to deviate my jaw and make the condyle sit on the proper place over its place while chewing. This is diagnostic of a superior joint space adhesion that has been long standing. Okay, so the cause of adhesion is increase in intra-articular pressure and static loading and development of fibrosis. So if you give this patient a stabilization or a permissive appliance, the loading is reduced. You have to institute physical self-regulation. You will need arthrocentesis to release the adhesions between the disc and the fossa, or the disc and the condyle. And in some cases, arthroscopic surgery to actually release those adhesions is required. Talking about the more common subluxations and luxations in our clinical practice. So subluxations are actually the condyles coming out of the fossa at the terminal stage of mouth opening. So these patients actually present as people who produce a loud thud when the mouth opens, with a depression on the side of the face, because the condyle jumps out of the fossa and you can see a depression where the joint is. So usually these are painless complaints and the patient is just embarrassed about the sound. So you have to explain the patient that it's an anatomic variation. You don't need to worry about it. And if the pain comes, that's usually from the capsule and due to over opening of the jaw. So they have to restrict their mouth opening. There can be other causes of the subluxation as well, which are capsular weakness and ligament laxity, where the condyle can come out of the capsule again and again, which happens in edentulous patients because they are habitually closing their jaw forward. It can also occur in people with elongation of ligaments, like after trauma due to excessive mouth opening during intubation, in general anesthesia, in dental extractions when the dentist has opened the mouth to full extent, and forceful hyperextensions. It can also be drug-induced, like in phenothiazine use, and it can also be due to spasm of the inferior lateral pterygoid muscle. It can also be due to dystonias, which are repeated spasms of the inferior lateral pterygoid muscle. So usually it is due to an anatomic variation where you see that the posterior surface of the articular eminence is really short and steep, and the condyle just completes rotation, and to open mouth further, the condyle jumps out of the fossa and produces a thud. So depending upon the etiology will depend the treatment. So if the etiology is an anatomic variation and capsular laxity, you have to place restricting elastics on the teeth and limit the mouth opening to a range which does not produce thud. As an adjunct, you have to do autologous blood injection in the capsule, around the capsule, for capsule to fibrose and limit the mouth opening. Typically, you have to use restricting elastics for at least 2 months, and the injection can be given once in 3 months. This does the job. But if the etiology is actually inferior lateral pterygoid muscle spasm, the Botox is the treatment of choice. And Botox has to be administered in inferior lateral pterygoid muscle, which stops the spasm and stops the problem. If the drug abuse is the problem, you have to replace the drugs. And if the ligament laxity is the problem, again, restricting elastics with autologous blood injections will work. The surgical methods are used only if your autologous blood injections and restricting elastics don't work and the patient is embarrassed with the third sound. So then you do eminectomy so that the condyle now moves out of the fossa and inside the fossa frequently without producing any sound and interferences. Spontaneous dislocation is also a subluxation where the condyle comes out of the fossa and gets locked there and then. So this is a very common clinical presentation. Now, if the condyle is coming out of the fossa, it can trap the disc in front or at the back. Depending upon all this, either you can relocate the joint of this patient. You can close the open lock with your thumb pressing it and the mandible swinging. If the disc is trapped in front, it will be automatically closed. And sometimes if the disc is trapped at the back, you will actually have to physically push the jaw and close it completely. Okay, so the etiology again is anatomic variation usually, where the post-articular eminence is very steep and short, and it traps the condyle in front, or it can be an inferior lateral pterygoid muscle spasm or dystonia. So it's important to distinguish between these two, what is causing the patient to go into an open lock again and again. And depending upon the etiology, you treat it initially by reducing the open lock. And then if you think anatomy is the cause, you place restricting elastics and do autologous blood injection. If you think inferior lateral pterygoid muscle spasm is the cause, you give Botox in the inferior lateral pterygoid. Okay. The surgical methods will be, again, eminectomy that will help patient not get locked again and again. Okay. Now, talking about the last class of disorders, that is the inflammatory disorders of the temporomandibular joint. They are basically disorders which are characterized as synovitis, capsulitis, retrodicitis, arthritis, and inflammatory disorders of the associated structures like the stylomandibular and sphenomandibular ligament. So, synovitis and capsulitis, the cause is usually a spreading infection from the temporomandibular joint. Retrodicitis, we already know the cause is usually trauma or parafunction. The arthritis, joint loading is the cause, and the inflammatory disorders of the associated structures, usually muscle hyperactivities, are the cause. Okay, so the characteristics of the inflammatory disorders of the joint is a continuous deep pain that originates in the temporomandibular joint. The typical feature is that the patient puts his finger exactly over the joint and tells you where the problem lies. Since it's a deep source of pain and if continuous, it causes central sensitization, and that leads to referred pain, hyperalgesia, which is typically described by patient as an inability to comb hair or touch the scalp, allodynia, which is sensitivity to touch, protective co-contraction, which is reduction in mouth opening, trigger point pain development, which on stimulation produce headaches, and autonomic effects, which is actually a feeling of swelling on the same side or runny or stuffy nose on the same side, or a dry or a red eye on the same side during the episode of pain. Okay, so the treatment depends upon etiology. Besides treating the etiology, you have to put these patients on time-bound NSAIDs, not SOS NSAIDs. Sometimes corticosteroids will also be needed. Physical self-regulation and appliances will be needed in retrodicitis and osteoarthritis, and management of central excitatory effects will be needed in patients in whom the pain is chronic. The treatment of etiology will be indicated in synovitis and capsulitis as antibiotics. In retrodicitis, you have to manage the disc derangement disorder. In osteoarthritis, you have to manage the joint loading. So that completes the entire range of intracapsular disorders, and you can see that there are a number of disorders that have different clinical features, and you need to know the clinical features of each to be able to properly diagnose them and treat them. So until unless your mind knows, your eyes will not be able to see it. So you need to know it to see it. So that's my request to everybody, to be thorough with the theory and then only do your hands-on on your patients. Thank you, Dr. Sonal.
Yeah, lovely presentation, Dr. Sanyukta. I think you have summed up the disorders in a very nice way. And Dr. Davis Thomas is here. Dr. Thomas, do you have any?
Good evening, sir.
Hi, Samyukta. Where do you practice?
So I practice in Gwalior, which is in Madhya Pradesh, Central India.
Madhya Pradesh. Okay. No, nicely presented. I belong to a group, and the principles that we usually follow is AAOP, American Academy of Orofacial Pain, and IASP, International Association for Study of Pain, also IHS, International Headache Society. some of these topics might be a little bit controversial if we follow those guidelines. So, but people like me, I'm open to looking into any of those treatment or management modalities, and we welcome all types of management modalities and treatment types. By the way, there's a difference between treatment and management, obviously. So, I would love to look at the literature on some of those things that you mentioned, but the principle are absolutely fantastic the way you presented. You're a great presenter as well. So congratulations on the same. What is your primary post-graduation? Are you post-graduated?
No, sir.
Oral
I am,
medicine or?
no, sir. I am a Bachelor of Dental Surgery only.
Okay. And then you've taken your additional courses, right? That's what you did.
Yeah.
Okay, great. So yeah, nicely presented. And then at some point, I would like to pick your brains, and you can pick my brains on some of these concepts as well,
Yes,
between the two of us.
sir.
Right? Nicely done. Thank you. Appreciate it.
Sayuga, there's a question for you. If can you answer it in the chat box? And Dr. Chenna, you please get back to the chat box and answer the questions which are already presented to you, for you. Okay, Dr. Sayukta, please enlist physical self-regulation that you
Yeah.
mentioned.
Physical self-regulation it includes 4S and 1R and 1L. So it is just a minute. It is having soft diet, smaller bites, slower chewing, and stress reduction. So these are the 4S of physical self-regulation. 1R means restricting mouth opening to painless range. So pain promotes pain is the principle. So when we say that you have to restrict mouth opening, that does not mean that the patient has to keep the mouth closed. He has to function within a painless range and not give any painful impulse to the central nervous system, because that induces protective co-contraction and further reduction of mouth opening. And the fifth thing is lips together and teeth apart. So that helps the patient recognize that he has to not make his teeth meet and load the joints all the time throughout the day, because that is what some of the patients don't know at all.
Okay, great. Thank you, Dr. Sayukta. Thanks for joining us. And yeah, with that note, I'll call in our next speaker, Dr. Vijay Asrani. Yeah, Dr. Sayukta, you can stop sharing your screen, dear.
Thank you.
Sonal, let me just take 1 second to say hi to Brijesh. I see him on the screen. I don't know if he sees me. Hi.
Dr. Brijesh, can you unmute yourself?
Brijesh, how are you?
Hi, David. How are you?
Good, man. I'm on a ship, so I'll go on and off a little bit. I'm doing a presentation for physicians on pain and sleep and all that stuff. So
Nice.
bear with me, but I just want to acknowledge you. Thank you.
Thank
Hi.
you, David.
Now I'll mute myself.
Great. Okay. Now our next speaker, Dr. Vijay Asrani. Dr. Vijay, can you say hi? Hello?
Yeah, just a second. Hello, everyone. Hello, good evening. Hi, Dr. Brijesh. Good evening. Hi, Dr. Davis. It's really wonderful to see you, Dr. Brijesh. Yeah.
Hello.
Good evening, Vijay.
Yeah. Good evening, Dr. Davis. Yeah.
Dr. Vijay Asrani is founder of HEAL with 2 question marks ahead. So you'll have to explain me that also, doctor. And Orofacial Pain and TMD Clinic, and he is MDS gold medalist from Civil Hospital, Ahmedabad. He's completed his PhD and fellowship and 10 plus years of experience in TMJ and orofacial pain expert. Mini residency from University of Connecticut and arthroscopy workshop, Nexus Salt Lake City, Uttan. A member of American Headache Society. Others, please mute themselves. And pioneer in Gujarat for exclusive care in TMJ disorder and orofacial pain. So Dr. Asrani, the stage is all yours. And yeah, start with the way you have presented your clinic name. We'll start with that and then we'll go ahead. So what does it mean?
Thank you so much, Dr. Sunal, for your wonderful introduction. Actually, it's Heal Me. Me is in Hindi. So it's probably that might it have
Maybe
appeared
that's
as a
why the font
question
came
mark.
that way. Yeah, it
Yeah,
came.
that because the Hindi font sometimes it doesn't comes into the message. So Heal Me is probably my everything. And the basic concept is provide the environment, and we provide the environment, and the patient heals itself. Probably it is one of the quote which I have read in much of the textbooks around, that patients heals themselves, doctors just provide the environment. So I'm trying to do my best with the support of everyone around, and let's see what we'll be having today towards this wonderful topic. Uh, I have been attending the lecture since morning and in and out, and I'm seeing wonderful presentations. And I think Dr. Ruchika also joined. So I really like to say hi and thank
Yeah,
you,
one
Dr.
word
Ruchika,
for
for.
Dr. Ruchika, because she wanted you to join this forum, and she suggested your name. I think twice or thrice she mentioned that please call him in, and I said I am tracking him, but he's traveling abroad. And Dr. Ruchika, hello there, and happy birthday to you. I think she can hear us, but okay, Dr. Asrani, you can just continue.
Yep. Sure. Happy birthday, Dr. Ruchika, and thank you for the same. And this is the second time probably we are presenting here. So this is a wonderful thing. Yes, nothing can dim the light which shines from within. So whenever I start my presentation, I always like to quote Jack Ma or MS Dhoni, because I feel that they are the one who have got a good amount of EQ, that is an emotional quotient, which is required a lot nowadays in the entire aspect. And for all the dentists out there who are attending today's this wonderful conference, the very important thing you should have is patience. That starts from the way the patient enters the clinic and during the history taking and everything, because it happens certain times that the symptoms while change, the patient will say something else. On the other point, he or she will be saying something else, but you should be calm throughout the experience which the patient will be having. So this was me, as Dr. Sonal just said. I got an opportunity to do a mini residency from University of Kentucky under Dr. Jeffrey B. O'Casey. I did my MDS in oral medicine and radiology. So it'll be just going back in time, that how did my this journey started. This is a picture from 2014 around. I did my graduation and postgrad from civil hospital. So there was a senior of mine, Dr. Bhavik. He's not in this picture. I tried to find it. One fine day in the 2014, he asked me, Vijay, we see a lot of cases of suspend tumors, but what about chronic pain? Do you have something related to chronic pain, or are you able to manage chronic pain? So it's like speechless at that moment. I didn't have any answer to that specific thing. So at that point, it became a kind of a kick moment, we can say, that we are not having any good ideas about how to manage chronic orofacial pain. So then somehow this was the thing. We started dealing with a lot of cases of orofacial pain in my postgrad. And I started a CBCT venture in 2017, and I went to University of Minnesota for an interview. And then I joined a college at Ahmedabad, at Gandhinagar, Karnataka School of Dentistry. And then COVID hit hard to everyone. So somehow the COVID phase was going on. And finally, in 2022, I was able to open one of the finest clinic, that is, for me at least, that's Gilme Orofacial Pain and TMD Clinic. So this is the clinic's location. Since July 2022, we are exclusively doing orofacial pain and TMD practice here. It's at the riverfront. I would like to thank both of this wonderful colleagues, kind of me. One of them is doing orofacial pain in United States, and one is doing oral surgery residency. This is something, yes, I follow him in each and every aspect of my practice. I follow him since my postgrad days, Dr. Jeffrey P. O'Casey. This was my wonderful, excited phase. After this, last year, December, we conducted a mini residency in orofacial pain and TMJ disorder. And this was my wonderful colleague also, and a practitioner from Australia. He practices in Australia, so he had an insight about this. This was me again in this May when I visited AOAP and as well as Utaha for the arthroscopy workshop, TMJ arthroscopy. And this we conducted a workshop in June, where me and Dr. Srishti were able to educate a group of dentists from Gujarat and even from Mumbai and even from Pune. This was the hands-on workshop which we conducted. This was me this year, first time to the headache conference. And these are the two wonderful doctors, Dr. Joseph Cohen and Dr. Stiles. I had an opportunity to meet them and discuss certain aspects of orofacial pain and TMD. And this was me at the Mayo Clinic. So, coming to the wonderful aspect which most of us are covering from the past 2 days is it's a lot of things besides the disc. So there are certain amount of capsules. Certainly, there are a lot of capsules around the joint. There are nerves around the joint. There are vessels around the joint. There are muscles around the joint, and there is a disc. So most of the topics have been covered, suggesting the other disorders or other aspects which affects the DMJ. And my basic focus would be how we'll be able to differentiate muscle versus disc disorder. Only the two classic presentations, that is muscle and disc. So there has been a lot of thing going on about occlusion in TMD. So I'll just share you some concepts about it. So there are a lot of cases type of this in Indian population. Probably everyone of from the India might agree to this. Now, many times this type of patient doesn't complain of pain. They don't have any pain. Even the complete edentulous patients rarely they complain of TMJ pain or even a muscular aspect of pain. Because as we see that TMDs are more prominent in younger population nowadays, again, there has been a thought of class 2, deep 2. Yes, there are certain correlations we find, but certain times this type of occlusion also doesn't comes with a complaint of pain. And many times we are just with a thing of like, oh, what's the thing happening around? Why it is so that occlusion was called to be one of a prime factor in PMDs. So more of the time, the ideal occlusion cases, class 1, also complaints of pain. So many times in the initial aspect, we and along nowadays, I feel that most of the dentists is facing is okay, what is happening around? What is going around? They are not able to exactly know what is happening. So the etiological aspects of PMD basically focuses on major things, occlusal factors, trauma, emotional stress, deep pain input, and parafunction. The one of the thing is most important, which everyone says in PMD is adaptation. That how does the joint adapts? So if the joint adapts well, I don't feel there are any patients who are complaining of pain. But nowadays, due to a lot of factors, the adaptations of patients' TMJs decrease. I personally feel excessive use of investigations, improper diagnosis, improper management, and excessive use of medications are responsible for decreased adaptation to a certain aspect. So let's see, focus on the important aspects of muscle and disc. This is just a brief about how the sequelae of TMD is working. It's protective muscle splinting, that is co-contraction, which usually happens first, followed by local muscle soreness, muscle spasms, myofascial pain, disc, which includes with reduction, without reduction, perforation, and finally degenerative joint disease. So these are the key points for differentiating muscle pain from disc pain. One of the foremost is clinical history, mouth opening limitation and feel, eccentric movements limitation and opening interferences, acute malocclusion, joint loading, investigation, and diagnostic blocks. I heard today afternoon, probably Dr. Divya was wonderful in explaining that most of the cases are muscle. Yes, majority of them are muscle, but there are few characteristic disc cases also. So yes, when we start and when I see the patient, what's your complaint? So patient is, doc, I feel I have a TMJ. So my first common response is, okay, I have two. Oh, yes, most of the time it's happening around that patients are like this, they have got TMJ, but it's actually referring to TMDs, that is temporomandibular joint disorders. And this is me with a kind of a house view. I hope everybody remembers Dr. House. So the history, the characteristic important point in disc disorders is the patient will characteristically say that he or she has complained of pain over this point. See, that's why in articular, that is the disc position, it's marked just a point. And in muscle pain, the patient will say it's spinning here, it's spinning here, it's spinning here, it's spinning here. We need to ask about from origin to the present status, history of trauma, chewing efficiencies, and joint sounds. Most of the disc disorders in which there has been a history of trauma, if you try to get to a point, you'll be able to recognize that the patient might have history of trauma to a chin by either opening a bit during his or her open mouth, which will directly impact the disc. Yes, joint sounds, we must ask for them. So the sequelae again goes with the popping sound, clicking, popping, which is usually an initial subluxation, Later on, it's going to double click or reverse click, which is likely this displacement with reduction. And finally, it's a jaw lock position. That is, the patient is not able to open the mouth. Yes, mouth opening limitation, as we have gone through the anatomy and the normal movements. Initial 20 mm is the rotation, followed by rotation plus translation. So usually, if it's very low, that is, if the mouth opening is in the range of 15 to 20, and many times you ask the patient to open a bit, patient will try to open, and the mouth opening will get back to a normal range. And in cases of disc disorders, the patient's mouth opening usually get locked at around 25 or 24 mm, and when we try to open it, it doesn't open. I will show you the video demonstration of it. Yes, as it's shown that this displacement without reduction, it's usually 25 to 30 mm, while in muscular pain, it's usually less than 20 mm. Probably in United States, mouth opening aspects are different. But for Indian populations, we have usually seen the normal mouth opening ranges from 35 to 45 mm in both the genders. I prefer male. I usually keep male 40 to 45 and females in the range of 35 to 40. Yes, and hard end feel. This displays without reduction. You'll try to open it and it won't open. It's totally hard. Okay, and in the muscle, it's a soft end feel. You will try to open the patient's mouth and it will open. There are certain cases where it's both the things, that is, the muscle is also involved and the disc is also involved. So it's important to differentiate it and probably target both of them. So this is a video of a patient. See how she is opening right now. I'm asking her to open and she's not able to stretch that much because she is in bit amount of pain. Now what I'm doing is I will feel it that how it's going. It's a hard or a soft pen, and then we'll see how it's working around. See, this was the normal which she was able to do, and then it's a soft end feel, and I'm trying to open and it's getting open. Right? Yep, this is a bit of a normal. So it clearly suggests that that was a case of soft end feel, that is likely a muscular spasms. Now I am showing you a hard end feel. See, this is a hard end feel. I'm trying to open, but that's not opening. It's stuck at 2 fingers. I'm again showing you the hard end feel. See, this is a hard end feel. Patient is not able to open. And the jaw was also displaced towards right side in her case. Yes, eccentric movement limitations and opening interferences. Now, whenever there is a disc displacement without reduction, there is a deflection of the jaw towards the same side. That is, if the left side disc is displaced anteriorly and it's not reducing back, your jaw will shift towards left while opening. One of the characteristic point which I believe is ask the patient to take the jaw towards the opposite side. That if you ask the patient to take the jaw towards the right, patient won't be able to take that much to the right, and the patient will complain of pain towards specifically towards the left side. One more thing which I usually follow in my practice is asking the patient to take the jaw forward. And when they take the jaw forward, the jaw shifts again towards the same side. The deflection one, which is like it goes into this and it opens this, that is more likely a presentation of a muscular cases. So here again, I'm showing you a wonderful case with this displacement without reduction. She's trying to open and she's not able to open much. The jaw is deviating towards the right side. She's not able to open much wide. Sorry about this, the blue picture thing. Say it says 2 fingers. She's she's not able to take the jaw towards left a bit, and she has also complained of pain on right side while taking the jaw towards left. Right. It's deviating a bit towards the, yeah, it's deviating a bit towards the right. See? See, that's a disc pain. She is exactly pointing towards the disc. So again, that's come a point that the disc pain, the patient will characteristically say it's paining set right exactly near the ear. This is what I have found in many patients, that high point while chewing. That's likely a muscle. When a masseter muscle is tender or in spasm, you will feel that the teeth at that region are contacting first. And many times when the disc is displaced a lot, and we feel that there is a space while chewing on the same side, that is a sign of disc displacement. Joint loading, a wonderful tool to evaluate and differentiate TMJ muscle issue with a disc issue. So what you have to do is take a stick, a bread stick, and or ice cream stick, whatever you can call it. You keep it on the, suppose if you want to check which joint is affected specifically. So you ask the patient to bite it on the right side. And if the patient bites on the right side and it start paining exactly at the opposite side, exactly towards the left side, and the patient points towards the joint, then it's likely a disc issue towards the left side. And when the patients bite on the same side and it pains on the same region, then it's most likely a muscle issue. Say increasing pain on the opposite side, that clearly suggests a disc displacement thing. And ipsilateral pain, that's a muscle pain. So here also I'm showing you a wonderful case. See, when I'm asking the patient to bite on this point on the right hand side, see the patient is able to tell it's paining towards the left hand side. So what are the investigations which you like to go in this type of cases? OPG, TMJ, OPG, EMJ, that is electromyography, MRI, CT, CPCT, arthroscopy, or muscle injections. Frankly speaking, OPG to rule out any dental pathology, and most of the time I'm seeing referral cases. So patients have undergone either OPG or TMJ OPG, and they bring with all those things to me. But I prefer, if you feel on the clinical examination it's a muscle issue, and on the clinical examination there are no carious teeth or no other abnormality, what extra information will be getting by getting an OPG done? So, because if many times I feel that dentists say that if you are feeling that I need to see the joint, so joint kisa yani, matlab, is there a erosion or abrasion or erosion of joint specifically? So I always ask them during the presentations and many times that firstly it would be the disc. Initially, before that, it would be a muscle. So muscle and disc both are not going to be seen on OPG, even on CT or even on CBCT. A lot of craze is increasing in India about CBCT and TMDs, but I still don't prefer that because MRI is a valuable tool for ruling out less pathologies, which is always the case. So let's see how it goes. Yes, to rule out any odontogenic cause, operate caries is there in this teeth, you can go for an OPG. Again, TMJ OPG, closed mouth and open mouth. The more information, the maximum information a TMJ OPG can give us about the movement of the joint. So whether the joint is hypermobile or hypomobile in open mouth position. So that's the information you can come out. The disadvantages, many times due to certain other causes of trismus, the joint won't be moving. So if you directly commit that it's a disc displacement without reduction, just by saying this, it's not going to help. EMG, I personally don't prefer in my practice, but definitely to rule out muscle disorder, you can do these things and you can have a good idea. Yeah, the gold standard MRI. See, in India and in Indian population, in India specifically, MRI is accessible to most of the cities, specifically in Ahmedabad and probably in many other places. I have a good amount of clinical aspect that if I say it's this displacement of without reduction clinically, it's likely to become on the MRI aspect. But for the patient explanation, it becomes a good thing. And I know that in the United States, it's not that easy to go for an MRI. It's variable, but I always prefer to go for an MRI in most of the disc displacement cases. And I love to see the scan myself, and that is the DICOM data. The reason is because most of the time, if I don't see the DICOM data and the radiologist has just reported it, and the radiologist will report it as a disc displacement without reduction, but the clinical presentation would be disc displacement with reduction. Because the patient might not have opened the mouth during the MRI investigation, and it might have been a painful too to him or her. So that's an important thing. So this is a wonderful disc. We know the disc anatomy, and most of people are speaking on TMJ disc and anatomies also. So I just to show you, this is a wonderful disc. This is an intermediate zone, anterior band, posterior band, and the retrodiscal tissues on this aspect. I say the 12 o'clock position. 12 o'clock is a line going from the condylar center point just above straight to the articular eminence and above, just above to this point, which is at the junction of intermediate band and posterior band. So that position I usually call it as a 12 o'clock position. And same in the open mouth, I draw a line from the center aspect towards the eminence. The condyle has to be near the eminence, exactly at the near the eminence. The intermediate zone in between. Again, this is also referred to as a 12 o'clock position. So when the disc is displaced, usually the position which was I talking about, that is 12 o'clock, it comes to at around 10 o'clock or 9 o'clock, 9:30 or 10 o'clock. That is this point, we draw a straight line from here and one line connecting the intermediate zone and the posterior band junction. So this is coming at a position of around 10 o'clock. This is a closed mouth and this is an open mouth, which I feel that it's exactly normal. So the important aspect is sequences. We usually prefer proton density weight or T2 sequences. Dynamic MRI is going on. Yes, many people are preferring dynamic MRI. We can use to see, but many times it's misleading also, and also
ಅಷ್ಟೇ
it's painful too
ನಾನ್
to a certain amount of
ತೋರ್ಸಿರೋದೊಂದು ನೀವು
patients.
ಮಾಡಿರೋದೊಂದು ಏನು ಹೇಳ್ಬೇಡ ಅವನ್ ಸುಮ್ನೆ ಮಾತಾಡ್ತಾನೆ ಇದು ಅದು ಇದು ಅಂತ ಏನು
Dr. Sonal,
ಹಾ
someone's
ಓಕೆ
lips connecting. Okay. So again, an important aspect. This is the section which just shows about the disc, and this is anteriorly displaced. We also see coronal sections in most of the cases. As we know, the most common displacement is anteromedial because of the attachment of the lateral pterygoid. Most of the time, the disc is anteromedial displaced. Yes, I have seen few cases where it's anterolateral displaced, and probably only 2 cases in which the disc is posteriorly displaced. So it's the important aspect that you need to get DICOM images and you should be able to interpret it. And please don't rely on just on the basis of the MRI reports, because most of the time radiologists have not seen the patient clinically, so and they don't have much knowledge on this aspect. But nowadays, due to increase in TMD cases, even MRI centers are also getting good amount of TMJ exposures. This we can claim as anterior disc displacement without reduction or a stuck disc. You can see that the disc is displaced and there is thinning of the disc is also noted. Even in the retrodiscal tissues are thin. And this is an open mouth, no movement of the condyle. The disc is getting stuck at this point. So you can reclaim it as this displacement without reduction and even a stuck disc. Yes, one of a nice tool where to differentiate diagnostic block. You feel it's muscle, inject in the muscle. You feel it's a joint, it's a disc, keep an auricular temporal nerve block. Be cautious whenever you're doing any of these procedures, and please explain the patient nicely that there might be a chances of transient palsy and transient Bell's palsy specifically. So you'll be safe. And we already had a wonderful discussion about trigger point injections. This is a nice case I would like to show. It's a protractive co-contraction. You can see that I'm not pressing the mouth opener much. That is a histogram. You can see the patient's jaw is contracting. The starting of this case was deep pain input. She had a traumatic lower left 8 extraction. And after 7 or 8 days, she developed reduced mouth opening. And the pain and the complaint started with this protractive co-contraction. Then it went to a myofascial spasm case, and finally we were able to manage from there. This is a nice case. Very few cases have been seen by me, and I hope everybody will agree with me. This characteristic case. I will just play it and then we'll discuss. See, the patient is able to open the mouth only a bit. She is not able to take the jaw towards left side. So we can clearly make an idea that the right joint is affected. And see, what should we do? She will just press it near the ear and she is able to open the mouth wide. See, again, it's getting locked and she will press at this point and it will open. The mouth opening is probably 37 or width in this case. So a characteristic case of anterior disc displacement with reduction with intermittent locking. I was able to get the scan in all the 3 positions, that is closed mouth, the lock mouth, and the open mouth. This image I have reconstructed for better visualization of the disc. You can see in the lock mouth, the disc is getting stuck at this point and it's displaced. And in the open mouth, the joint is getting subluxate and the disc is a bit back. This is a wonderful case which I'd like to share you about as a procedure of arthrocentrosis or a block, auricular temporal block, starting with that, and arthrocentrosis typically indicated for anterior disc displacement without reduction from my side. This is the MRI findings. This is a patient and the clinical examinations. A deflection of the jaw towards right, reduce movement of the joint towards left. When the patient tries to take jaw forward, it deviates towards the right. Auricular temporal nerve block, the standardized one. These are the points. Sorry, got completed. And we had a good post-op mouth opening. I will just try to fast forward it. I don't know why it's there. Yeah. It's near to 2.5 months, and the patient is under follow-up and she's doing good. So finally, to conclude, and for everyone around here, the dentist specifically who want to gain insights on this field. So the basic questions is, do ask these questions during your history and do you feel pain in your face, jaw, or temple areas? Do you have pain when you open your mouth, yawn, or chewing your food? Do you know if you clench, grind your teeth? Do your face and jaw hurt when you wake up in the morning? Do you have painful clicking, popping, or grinding sounds in your joint? See, most of the time, the dentists are trained initially to aspect to, and they're focused in the practice basically on the teeth. So, as an oral medicine, with an oral medicine background, I always prefer and I always ask to check from outside and then reach to inside. And Dr. Chaina probably said a wonderful thing. It goes vice versa. The mind cannot see what the eyes doesn't know, and I also prefer the eyes cannot see what the mind doesn't know. It's something like that. So the basic recommendations: soft diet, nothing crunchy, moist, heat or cold. Both works. For muscle, I prefer usually a cold. I most of the time prefer cold. Use of NSAIDs or muscle relaxants and refer to a specialist for further management. This was a wonderful quote which I got to know this time, and I always believe on this philosophy. When you cut through a pain sensitive structure, chances are good that you may worsen the pain. To conclude, yes, some say focus on management rather than diagnosis. Many say focus on diagnosis rather than management. What I believe is focus on etiology and rest will be taken care by itself. My PG guide and I always like to thank her. No two patients having same disease will present with exactly same complaints of pain. My probably second or third day in early 2014, and she was, which I always remember that even two pulpitis patient, irreversible pulpitis patient won't complain of similar type of pain. Special thanks to yes, Dr. Jeffrey P. Oketson sir for all his insights. He's my brother, Dr. Mukesh Kiasani, with the same background of oral medicine, and probably he's the reason I'm into dentistry and oral medicine. Special thanks to my patients. Probably the number have increased, but I'm not able to add the pics of all of them. Yes, lastly, before people can begin something new, they have to end what used to be and unlearn the old way. So thank you. And probably this is a nice read which we are sharing nowadays, and we are trying to educate people a lot. And this is just about a posture. So let's see how it goes. The audio is not visible, I feel, but it's early in the clinical aspect. We see that my assistants and my associate staff are having the neck forwards and they come and complain with the neck pain. So I'm like, when you see the phone like this and when you are using the laptop like this, it's less like more likely to pain. We just try to correct over the days, and yes, it gradually improves over the aspect. And after 21 days, probably we are able to correct that habit. The rule of 21 days works on. This is my contact information, my email ID, my Insta ID, clinic ID, YouTube, and websites, and even the contact number. If there is something, anyone can pinch us on the same numbers or contact us on the same. And yes, we are coming up with a workshop next week and also a mini residency in January. So if anyone is interested, please pinch us on the same contact information. So thank you so much. Thank you, Dr. Sonal, and thank you, IOPCON. Thank you, Dr. Ruchika ma'am, for having me here. And it's really my pleasure to speak on this platform. And I'm open to questions. And if there are something else, we can discuss. Thank you.
Thank you, Dr. Vijay, and it was really an insightful, in-depth share. And there are a few questions regarding specific MRI protocol that you follow. They would want to know. So if you can type it in the chat box, so or just quickly mention it, so everybody will be.
Usually we ask them to take a proton density weight and a T2 sequence in which we are able to see the disk very nicely, and ask them for a DICOM data. There are usually two positions, open and close. And if it's an intermediate locking, you can ask for the third position. It's nothing more.
Okay. Dr. Thomas is still here, so I would like Dr. Thomas to say a few words for Dr. Vijay Atsrani.
Yeah, Vijay,
ma'am.
nicely presented. I have
Thank
to
you.
say only one thing. Yeah, very nicely presented. Regarding the imaging, the problem in the US with is not that the patients have difficulty in accessing MRI or any other imaging. The fundamental question here in the US, and I'm not in the US right now, we're going to reach there, is that what is the necessity for imaging? So in all my courses, everything that we do, every patient, every university that I teach, I ask my students the fundamental question: justify your imaging. So let's say I have access to a panoramic, a CD, CT, a 3D pan, a CT, an MRI, a functional MRI, a PET scan, a SPECT scan, and anything in between, ultrasound. When I'm ordering it for a patient, I need to, number one, justify the imaging. When I justify the imaging, what I mean by that is the AAOP guidelines, American Academy of Orofacial Pains guidelines are there. AAOMR guidelines are there, American Academy of Oral and Maxillofacial Radiology, and AOMF, Maxillofacial Surgeons just came out with their, so there are three, I would say, recommendations, guidelines, and sometimes a standard of care. So what do you expect to get from a CT or an MRI that you don't know now? So you and I did a thorough clinical examination. If it's ADD with reduction with intermittent locking, what are the chances that when I put that patient through an hour of MRI with $3,000, $4,000, $5,000 of expense to them or to the coverage, because I'm on the insurance company panels and a couple of insurance companies, IME panels. So if I'm going to allow that, I'm going to ask the clinician a question: what information do you expect to get? And more than that, how does that benefit the patient? So it's just like, a classic dentist, general dentist getting a panoramic, so machine in them, and having a panoramic machine in your practice is not an automatic check mark for someone to get a panoramic. Every patient coming in gets a pan. So because that type of a message, if I give that to my students, then what will happen is they will take a pan indiscriminately for everyone. And if there's a question regarding if your differential diagnosis is muscle and musculoskeletal pain, there's absolutely no indication to irradiate the patient for a panoramic, right? So it is not the accessibility to care or access to care that is a problem in the US, is the justification and the reasoning behind, let's say, a clinician asking me, can you approve me this MRI for this patient? I ask them, what is your initial diagnosis? What are your differential diagnoses? How will this patient benefit when I'm allowing our $3,000 or $4,000 or $5,000, and now with contrast, it's an added risk, right? The contrast we use, gadolinium, other contrasts are not very kind to the kidneys nowadays, right? So there's a lot of controversy on that too. If you ask Mel Muparapu, who is the AAOMR's biggest person in UPenn, University of Pennsylvania, he has gone away from entirely taking, with contrast. So that way, I really agree with the radiologists in India when, previously I used to think, why are they asking me if we find anything without contrast, then we'll put the contrast in. I used to think the other way around, but I'm talking to a couple of good radiologists and, all the instrumental science and stuff, I understand what they're saying, right? You cannot indiscriminately order it. So what I wanted to do is to have clinicians think, justify your imaging, what will you benefit from it for the patient's sake, and ultimately, what will the patient benefit? In other words, ADD with reduction with intermittent locking, am I going to just confirm that with an MRI at an additional expense, or a CT or CBCT with contrast, or CT with contrast? That's putting that patient to increased peril, radiation,
Definitely.
money, and
Definitely.
effort.
So
So that is the difficulty in the USA.
So that's one thing I would like to add. The same
but
protocol probably I follow. I usually don't advise in with reduction, even at the without reduction case. And so the thing is, I'm getting more of a referral patients. So I never go for CTs when I feel that even its bone has been much amount of restricted, until I feel that it's a rheumatoid arthritis or a old age patient with a severe destructive and a crepitus sound. What I do is I get an MRI and I get a CT cut. So I have a good terms with the radiologist and they don't charge extra here. So the thing with the Indian patients is basically it becomes a good thing to explain them. So that's why we get this investigation done at the stage when I want to undergo some treatment for him or her. And after a proper clinical diagnosis only, I go for an MRI. And I never go just so because I have wrote an article, it was back in 2017 that why we are shifting towards an era of chronic orofacial pain because patients come to me with all kinds of investigations, CTs, CBCTs, and probably MRI brain, CT brain, cervical spines, and still with no results. So this becomes a good thing on the patient aspect that yes, they will be able to understand it. And luckily, it's not that much costly here. It's approximately 4,000 or 5,000 bucks in INR. And so people are able to spend because they want a diagnosis. And I listen, OMR, I always believe that there should be a diagnosis first and then the treatment later on. Thank you.
Sure, I strongly recommend we all look at those three guidelines. The AOP would have updated it, time and again, then the AOMR and the AOMFS. Okay, all right. Great presentation. Sonal, I need to go to my presentation on the ship. So if I get out of this meeting, that's because of that. But thank you. And I'll keep my video
Your friend
mute.
itself, Chandwani is going to be presenting. Dr. Abhay has a question for Dr. Asrani.
Yeah.
Just a second, Dr.
Sir, good evening,
Dr.
sir.
Davis Thomas, you can wait because the next presenter is your friend itself, if it is possible. Otherwise, Dr. Brijesh is presenting the next, he's the next presenter. So if
Oh,
possible.
Brijesh is going next? Okay,
Yes.
I'll stay.
Okay.
I'll stay. Okay, no problem.
Okay. And Dr. Abhay, can you just type in the question in the chat box if it is possible? Dr. Vijay will be happy to help you on the chat box. Okay, with that note, I will like to invite our next presenter, Dr. Brijesh Chandwani. Dr. Brijesh was here itself, right?
Yes, I'm here.
Yeah,
I'm trying to
I see
share.
him.
Hello, sir. And when
Okay.
when we are talking about orofacial pain, we cannot miss somebody who is Dr. Brijesh Chandwani, who is also an executive council member of American Academy of Orofacial Pain. And it's a pleasure to have you, doctor, and honor to be sharing screen with you. Dr. Brijesh Chandwani is a board-certified orofacial pain specialist who did his DMD and orofacial pain residency in Tufts University. He has been in faculty at the Craniofacial Pain Center at Tufts University since 2006, full-time for the past 5 years, and currently is an associate clinical professor. He has lectured internationally and co-authored scientific programs, papers and on headache, complementary medicines, and TMJ disorders. And Dr. Thomas will talk more about his friend, and then Dr. Brijesh can start his presentation. Dr. Davis, you wanted to talk about your friend, right?
We've known each other for years. We are both on the publication committee, and he's part of our 100-hour webinar series. He was kind enough, and he will be part of it in June as we start our new one, case-based. So Brijesh, I won't take much of your time, but thank you. If I
Thank
have to
you.
put it off, that's because I'm going down to
Yeah,
my
yeah,
lecture
go ahead.
hall. There's a bunch of physicians. Thanks,
Totally,
Brijesh.
totally.
Thank you.
Go ahead.
And thank you, Sonal.
Welcome, Dr. Yeah, Dr. Brijesh, your slides are visible and the stage is all set for you, Doctor.
Thank you so much for
Welcome to
inviting me.
International
It's a
Orofacial.
pleasure. And so I'll go dive a little bit into a bit of against the grain. I'll talk a little bit about some of the previous lectures, why things are done differently in US, and maybe that's where we need to go even in India. I've known Vijay for now a little bit of time, so great presentation. The presentation on trigeminal neuralgia was great. It's exciting time to be an orofacial pain specialist. There's more recognition. It's a dental specialty since the last couple of years. And things are changing, which is amazing. And we'll talk about what's changing. And I did my dentistry back in the 90s in India, did some private practice, worked as an assistant for a couple of years. Also, before I worked as an assistant, I did private practice in Bhuj. Everybody knows Bhuj from that earthquake, which was very impressive. When the earthquake happened, I was, as you see at the bottom of the screen, that's the general hospital. I was driving right across there. So things change in a moment. So cherish all the moments. Did a residency in orofacial pain. And then since then, I've been working full time in orofacial pain. It's been good times. And I enjoy teaching undergraduates, graduates, and I'm lucky to have a nice balance in my professional career. So, and of course, this is my son, my daughter, and my nephew. It's all about living in the moment, okay? So, orofacial pain is a new specialty, and there's actually more and more data coming out that it has more to do with neuroplasticity rather than anything else. And I'll make a case of how things are changing. Some things are not changing, okay? Acute pain management, we're still doing the NSAIDs, occasionally the steroids also, muscle relaxants. Chronic pain management, we're doing tricyclics, antiepileptics, other antidepressants, other antihypertensives, at times antipsychotics, and we're pretty good at pharmacotherapy. All right, so what has changed? Role of occlusion, okay? In the 60s, 70s, they talked about how occlusion is so important for function, parafunction, pain. And now it's, Vijay put it nicely about really edentulous patients. Data really doesn't show edentulous patients have more problems. Even particular type of occlusions have more problems. The only data there is really some small cross-sectional studies, okay? Whenever you look at studies, you got to look at, are they longitudinal studies to show kind of a trend? And causation is really difficult to prove, especially when there's multifactorial occurrences, okay? This was a really good systematic review looking at malocclusion as a risk factor of TMJ disorders, and they really didn't find any correlation. So small associations, but not really robust data. And that's been replicated a couple of times, okay? Now, you will find, so this was another study which talked about that there is an association between temporomandibular disorders and malocclusion. But if you look at the type of studies they looked at, they're cohort, case controlled, no longitudinal studies, and that's a problem, okay? So the quality of studies, if it's the selection criteria is not optimum, you can extrapolate conclusions which may not be valid. So again, always take critical evidence-based medicine with a grain of salt, okay? So this was a really good paper, okay? Anybody who does orofacial pain, I would argue to look at Orbach's paper. This was done with the National Institute of Health. They took about 2,000 odd patients before they had any problems, okay? And they looked at different factors. This is just one of the publications of the OPRA study. And they followed patients for years, and they found that, does occlusion play a role? Yes, definitely. But in the scheme of things, the role that it plays is really small. And a couple of speakers before me spoke about adaptability, and that's probably why. You get a filling, you could have pain, but I would kind of use a number, 80 to 90% of patients, maybe 95, 97% of patients adapt over time. How long does it take for people to adapt? It can take a long time. So there's some data which I'll present. It can take up to 6 to 12 months, sometimes even 18, 24 months for people to adapt. So just how weather changes can make us sick, I think there is a role for occlusions. It's just very, very non-specific, typically insignificant. Things like posture, also, it's a much smaller role than we thought. Again, I practiced for 20 years. The first 5-7 years of my practice, I used to put more stress on it. I still put a stress on it, but it's definitely, when it comes to diagnosis, its influence is much smaller than we initially thought. Psychological stress, the influence is definitely more profound. And there's actually a study from UConn. Matt Litt did this study, and he kind of showed influence of somatic factors is clearly much higher than bruxism, than occlusion factors. So in the scheme of things, you should definitely be paying attention to what actually amplifies pain, what kind of makes sensitizations. Okay. Now, unfortunately, people who seek dental treatment, okay, so there's studies showing that around 10% of patients develop orofacial pain. Majority of them are self-limiting, but when you're going through orthodontics or you're going through prosthodontics or really any kind of dentistry, if you do suffer from orofacial pain, there's definitely going to be some sort of a predisposition. So it's really important to identify those patients. This was a recent article, and they looked at about 10 to 20%. I think it's in females, it's close to 20%. In males, it's like 10% of patients who are seeking orthodontic treatment have temporomandibular disorders, and most of them are not kind of, they have signs rather than they have chronic illnesses, but still something to consider when a patient walks in. temporomandibular disc displacement, again, this is where I'll respectfully not agree with Vijay's inference that MR is a valuable tool for diagnosis or kind of patient education. I think it's no different than some of the other objective tools. It can really brand a patient as having a disorder where I'll show you literature where this displacement without reduction by itself is really asymptomatic and requires no treatment, okay? And this is important because once a patient understands that they have a disc displacement, okay, and if they think it's a disease, it changes a frame of mind. It's no different than somebody finding out they have diabetes. It actually, diabetes is a progressive condition which needs to be managed. Otherwise, there's consequences to the heart, could be to the brain too, and other metabolic functions. Temporomandibular disorders, as you could see these 3 papers, sorry about the small prints. So the paper on the left is really looking at anterior disc displacement without reduction, what happens with time, okay? Long-term outcome of non-surgical treatment, actually. So the paper on the left talks about treating them with occlusal appliance. Paper in the middle looks at natural course, no treatment for disc displacement without reduction. And people on the right, there's discectomies, which was done in patients who had disc displacement. And if you look at outcomes, I'll go with the middle one. 6-month outcome, around 35% get better with regards to symptoms, okay? Range of motion is better, even sounds are better. At 12 months, 50% are better. And then at 18 months, close to 68% are better. 70% patients get better with time with no treatment. I think that's a really good study, especially a longitudinal study showing that no treatment, you can make patients better. Now, in these patients, you do an occlusal appliance or a disc displacement, you most likely you will have a good outcome. But it's not because you're correcting something. It's really because you just giving patients time to heal regardless, okay? There's actually a small chance that you could have side effects with an occlusal appliance or with a surgical intervention and cause a real problem. And if these patients get an MRI from anybody, at times it's stuck. We are all different, unique individuals. It's unclear what bothers each of us. So it's really important to almost think of the worst case scenario. If you think I am obsessive about something and you give me something to obsess about, you're creating a psych issue which could have been negated by just not doing an objective test, which was clinically insignificant, okay? So that's my argument against imaging, okay? So where was that? Okay, for some reason, okay. So internal derangement, as Davis said, history really is diagnostic. We don't need MRIs. We don't need CT scans. It could be disc displacement or disc displacement without reduction. History is really remarkable. And with clinical exam, you could diagnose it. Auscultation is helpful sometimes. Imaging, I look at MRIs when I'm suspecting a soft tissue tumor, a severe joint effusion. And of course, if I'm thinking of joint procedures, I'm getting an MR to make sure there's no anatomical variations in the soft tissue, hard tissue. So, and then CT scan, I'm thinking when I'm suspecting a degenerative joint disease. So that's kind of my protocol. Other objective tests, things like JVA. I know there was a talk on JVA. There's face pose. There is EMG studies. They're just fancy tools which have no clinical relevance. Okay. Having said that, do I do some of it? Currently, I don't. I have an ultrasound, which again, I got it for academic purposes. So occasionally I use it for educational purposes to patients, but at the same time, it's really not diagnostic. So, and it doesn't give us clue with regards to treatment. For patient education, it's pretty good, but at the same time, it's not worth the investment, and you have false positive like joint vibration analysis. There's more negative data than positive data when it comes to pain, when it comes to prognosis. Things like Facebook, things like EMG studies, things like occlusal analysis, again, good patient education tools, but the time involved sometimes is just too much, and I don't think there's enough clinical relevance to that. A note about incidental findings when you do imaging. Okay, so this was a really good systematic review, and it showed around about 20%, 20 to 30% have incidental findings. So the fact that you have, just yesterday, I had a patient where I did a panoramic and patient who was suffering from pain for a while. And the patient on the anterior aspect of the condyle, there's a 1 to 2 millimeter area of loss of cortical margin. And it's really on the anterior inferior aspect. I don't have the image, but I think it's an incidental finding. We'll repeat the panoramic in the next 6 months. Actually, it was a tomogram to make sure it's not changing, but it's very common. Even in my practice, I would say 30 to 40% is incidental finding. Do I image again in 6 months to make sure it's not changing? Absolutely. But I'm kind of aware that atypical findings do happen when you image so much. Physical signs are not always relevant. Some people who have clicking, malocclusion, bruxism, again, there's more and more data coming out, but most of the times they're not causative. Okay, when you think at bruxism, it definitely is a predisposing factor. There's good data on that. Okay, but there's a pretty significant number of bruxism patients who are clinically okay, which don't require treatment. Okay, so why do we talk about that? I think the power of visibility, like pain is invisible, and at times it's comforting to patients and us, really. So if you're treating something which you cannot visualize, it's just harder to treat. So there's a pretty significant stigma in treating everything with no objective basis. So that's the reality of it. So what I do with my patients is I tell them there's more that we don't know, which is okay. Medicine does this quite well. At times, it's easy to convince patients too when you have an MRI showing disc displacement and say you need an occlusal appliance, or you need a joint injections, or you need arthrocentesis. Patients would take it as a priority. So, but that's more a business model rather than really a clinical care model. So there's more and more data showing that physical signs are often at times irrelevant, which is okay. Okay. How about occlusal factors in bruxism? Okay, let's look at that. this was Ramford's paper from the 60s, I believe, is often cited as, if you balance the bruxism, EMG activities go back to normal, but that was in the moment. That study, they didn't look at what happens over time. And Okerson did this study where he showed that EMG activity at like 2 weeks period goes back to kind of pre-adjustment. Okay, so he did it with appliances, so it was not a irreversible treatment, but a lot of changes happen in the moment which are not sustained over time because adaptability. A lot of times it's hard to adapt. So occlusal adjustments for treatment and preventing temporomandibular disorders. There's robust data that should not be done. Okay, so if occlusal adjustment should not be done, so this is again going back to the 90s, 96, there was an NIH consensus meeting. Till today, in the US, unfortunately, there is a small subset of people who are still doing things like this. So I don't know if you're familiar with this big lawsuit about this anterior growth guidance appliance, which talked about expanding the maxilla for improved occlusion, where there's a bunch of patients where their life is wrecked. It's a sad story. This was in major press last year in the US. It's happening, and I just hope it doesn't happen anywhere else. Okay. These are the concepts that have really evolved. Occlusion has very little impact on clinical decision-making in orofacial pain, although they can impact function. So I'm not denying the function part. I just feel for when it comes to pain is a lot more complicated. Our central nervous system has a lot to do with neuroplasticity rather than structure. We have people who are tall, we have people who have leg length discrepancy, and they all often at times they don't have symptoms because our muscles, our ligaments are good at adaptation. Unfortunately, we can't study which individual is good at adaptability, which is not. So it's really, again, when you have a patient, it's good thing to consider adaptability, but you can't study adaptability. So is the patient not getting better because of lack of adaptation? Is the patient not getting better because of sensitization of the nerves? Is the patient not getting better because of some immunological conditions? Is the patient not getting because of structural issues? Is the patient not getting better because of emotional issues? We can't separate these kind of variables. That's a big deficit in this field. So again, a specific diagnosis is often difficult to attain. That's where we are. Okay. But we know occlusion plays a very insignificant role. Does it still play a role? Yes, but still not something that needs to be corrected because things can go wrong. That's okay. Again, occlusal analysis, phase pose. This was a paper by Christensen on the top right. A lot of people seek, as you could see, the fourth sentence in this, the seeking of orthodontics to improve my bite, okay? Not for function, not to eat, improve my bite. And that has more to do with bruxism, more to do with temporomandibular disorders, at least from a patient perspective, not from a dentist perspective. So treatment planning is much more complex when it comes to adults than adolescents. So we need to be careful when we are changing occlusion because things could go wrong. Another of my topic, which I really enjoy, I think there's a big value in myofascial pain, understanding role of muscles in orofacial pain, trigger point injections. Okay. whoever does orofacial pain, somebody mentioned muscles are really the main reason why a lot of patients do have pain. Janet and Travell book, I would highly recommend. They show these muscle pain referral patterns. We're learning that it's, again, not so reliable with detecting these trigger points, okay? Again, because it's not reliable doesn't mean it's not clinically relevant. It is still relevant. It's just difficult to study, okay? So this is a known issue, but it doesn't deny that these muscle pains exist, okay? There's a lot more that is unknown rather than known. That's the only thing. Jay Shah has done a couple of wonderful studies at the NIH. He's a physiatrist. And he's shown data that when you have these trigger point injections, there is a big central nervous system component. There's increase in the CGRP, substance P, and other neurotransmitters, which are typically heightened in chronic pain. So there's local ischemia. Is it due to muscle contractions, or is it really due to chronic pain? We don't know, okay? I suspect the later, but really we don't know for sure. So that's there's really no good data about that it's really muscle activity, okay? If there was a second paper I would recommend after the first Orbach's paper, this is the paper, okay? The Lundberg paper, which talks about peripheral sensitization and its overlap with central sensitization, okay? Acute pain, when does an acute pain become chronic pain? Vijay mentioned about postural stress. This definitely physical pain, mechanical pain, emotional factors, sleep disturbances. So you got to when you're taking in history, you got to identify where this patient is that I'll take an example of jaw clicking. Where in this cartoon does that patient fit in? If the patient has peripheral sensitization, pretty much anything you do is going to help because it's a self-limiting condition. But the same clicking patient, if it's on the right of your screen, has comorbid psychiatric disorders or has just a lot of somatization, pretty much anything you do would not work and may make things worse. So that's the challenge in managing orofacial pain. So you got to think of diagnosis and then prognosis. So somebody who has significant prognosis, because they have somatization, a difficult prognosis, you can make things worse, okay? EMG, again, there's a big value in behavioral therapy models, but EMG with headaches, temporomandibular disorders, there's almost no relation between muscle activity and pain. So again, and that's been replicated in a number of studies. So when you're thinking temporomandibular disorders, okay, don't just think the diagnosis, think of the whole picture. What's peripheral sensitization, central sensitization, etiology? I would argue it's not as important. If a patient's mouth is open for too long and they develop a muscle strain from that, is the muscle strain developing because of extended mouth opening? I would argue not. I think it's the extended mouth opening is causing the muscle strain, mainly because either the patient didn't sleep well or they have a better function. So it's a interplay between multiple variables. So that's why the etiology at times, it's not easy to understand. So what may seem like an etiological event may not be one. So that's and the third paper, and I promise you, this is the only other paper which I would suggest. It's also from the Oprah study, which you should really read in detail. This talks about factors associated with onset of temporomandibular disorders, and this is really another longitudinal study, long-term, 5-7 year study, where they looked at patients and they saw that patients who had self-reported oral parafunction, so not really tooth wear, self-reported. If teeth wear is very common, it may be insignificant, but if they catch themselves clenching, grinding, or the spouse says they grind, that's a much stronger predictor that they may develop temporomandibular disorder. So if they have trouble opening, the range of motion, again, is a much stronger predictor rather than clicking or deviation, okay? As you could see, the third point, clicking, teeth wear do not predict kind of onset of temporomandibular disorders, okay? So treatment of temporomandibular disorders, again, the gist is conservative treatment. There's a lot more that we don't know than we know, okay? And sorry for the small slides. I think anybody who needs just my PDFs, please email me and I'm happy to share them. It often at times, treatments depends on who is treating it, okay? And this is an Indonesian study, but the trend seems to be, even in the US, if a dentist treats it, they often treat it with occlusal treatments still today, compared to if an orofacial pain person or a neurologist treats it, it tends to be more pharmacologic or occlusal appliances. So when it comes to treatment, I always tell my residents, you got to think of, does this patient need a bottom up, so peripheral to central treatment, or does it need to be top down? So if somebody has extremely poor sleep, poor energy, daytime fatigue, or has psych issues, you got to think of top down, even if they have jaw locking, or doesn't matter the clinical symptoms, compared to if the patient has really good daytime energy and has the same problem, you could do bottom up, you could do an occlusal appliance or trigger point injections. So tailor your treatment according to the patient rather than according to the diagnosis, okay? Botulinum toxin has been getting a lot of press in US, and I could see even in India. Data is not really that strong. Does it mean I don't do botulinum toxin? Absolutely not. Every week, I do probably about 2 to 3 patients with botulinum toxin. But I explain to the patients, listen, there's a bunch of host of other treatments which are comparable, maybe even superior. And of course, some of these patients have failed those treatments. Some patients are just more receptive to botulinum toxin. But I educate the patients about what's the right treatment with regards to data, okay? When it comes to headaches, things have evolved a lot in the last couple of years, okay? The biggest thing that's happened in the last 2-3 years is the CGRP receptor kind of modulators. They've changed the headache medicine paradigm significantly. They have extremely great value. I just don't know if in India the CGRP modulators are present. I think they are. I use a lot of headache medicine treatments for chronic orofacial pain, trigeminal neuralgia with a reasonable success. And in my practice, I see a fair amount of headache patients also, typically migraines, but in my last 5 years, I've seen one cough headache, one Suna Sankt, I forget what it was, one paroxysmal hemicrania. So on rare occasions, I've seen some other idiopathic headache disorders, and it's fun. not fun for the patients, but at least for me, it's stimulating to see those patients. I'll kind of finish with, whenever you are doing your treatment, okay, you got to think of the level of evidence. Where does something that you're doing fit? Okay, so if you think of botulinum toxin for bruxism, data really shows it's more negative rather than positive. And I'm happy to share some of that data. There's a bunch in my presentation, but I have a lot more which I can share. Botulinum toxin for orofacial pain, it's kind of in that gray area. Maybe it is positive, but maybe not. It is neutral. So it's kind of similar to normal saline. I have patients where I just show this light to patients, and I'm able to convince them to do just local anesthetic with kind of in the muscles that we would inject botulinum toxin, and I've had good results. So modulating the pain with local anesthetics versus botulinum toxin, it's a possibility. Okay, I'll hopefully have questions. Thank you. Let's see if there is any questions in the chat box.
Dr. Sonal, are you there?
Yes, I'm there. Thank you, Dr. Brijesh, for this wonderful lecture. And actually, the theme for this Congress was setting some standardization for treatment planning. And I think your lecture has summed up, and we have some pathway now. And since it is a 12th specialty in US, orofacial pain has been considered as 12th specialty in US. Indians, we are still following the lead, and I'm sure in years to come, we will have some standardization formula, because what is happening is, sir, the students and the clinicians are still not oriented about the treatment plan of protocols to be followed. And your lecture was an enlightening session, wherein I'm sure everybody is going to go back and check those references and the papers what you have submitted up now. And I'll just check if there are any questions for you. Dr. Davis has mentioned he has to leave, so he left.
Yeah, that's fine.
Yeah, and then pharmacological approach for treatment for TMD, doctor. That's the question for you.
Okay, so again, it all depends. So if somebody has acute pain in, say, masseters or temporalis, but they're sleeping well, their daytime energy is good, a muscle relaxant is a reasonable thing. If somebody has pain associated and a comorbid trouble falling asleep, okay, and it's important, poor sleep, you can classify it. If somebody has trouble falling asleep and pain, again, a muscle relaxant may be a good modality. But if somebody has severe pain and trouble staying asleep, often at times I utilize something like gabapentin or even a low dose of nortriptyline, 10 to 25 milligrams, because that can improve the sleep architecture, so the quality of sleep. And then chronicity. So if somebody has been having pain for like a year and a half, or they have jaw pain and have a pelvic pain disorder or a back pain, there might be value in going through a nortriptyline or desipramine. Patients who have, say, sinus headaches, sinus problems, and jaw pain, I like desipramine because it has an antihistaminic component, even though it's an antidepressant. So I'm a big fan of tricyclic antidepressants. One, there's decent data in chronic pain. And second, it's easy to wean patients off. I am thinking, whenever I'm picking antidepressant or an anti-epileptic, I am thinking 3 to 6 months of therapy. Compared to muscle relaxant, I'm thinking 2 to 4 weeks of therapy.
Yes, doctor. And Dr. Brijesh, it was really overwhelming to have you on our board this year around. And
Thank you.
I would like to extend my welcome for the next year also. So next year when we have our Congress, I would like to invite you right away. So please take
Sounds
this
good.
invitation and please join us next year also. And by that time, we will have more and more insights. Since this is an evolving field, as you rightly said, we are still, the learning curve is still there for everybody in this field.
Same here.
So we need more and more guidelines and more support system wherein we have like-minded treatment plans also to for us to standardize it.
So and I'll tell you, even though everybody always thinks US it as the forefront, just as you saw in the lawsuit that was in the press last year, there's more overtreatment that happens here, unfortunately, than in other countries. There's actually data on that. So even though from literature standpoint, US is ahead, but if you go to the main street in day-to-day practice, I often see patients getting, like yesterday, I saw a patient who had literally disc displacement without reduction, has had pain for like 8 months, goes to the dentist. The dentist said, you either do orthodontics or you do Botox. And both are invalid for a disc displacement without reduction and a muscle pain. And this is a dentist who is an affluent dentist. I've known him for 20 years. He's a good dentist, but he's not trained in orofacial pain. And that's the unfortunate piece. It's very common. And I'm glad you're doing this so that we can spread the right message. Thank you.
Yes, doctor. The plus point that India has is population. So the number of cases that we will have around is really commendable, and we have conditions wherein deficiencies has been always the factor that has influenced our treatment plans. So be it vitamin D deficiencies or any kind of deficiencies. So doctor, it was a pleasure having you and an honor having you on board this year. And please extend as I already have invited you. So I'm taking into consideration that you are there as a mentor next year also.
Would love that. Thank you.
Thank you so much. And with that, I would like to invite our last speaker for the day, Dr. Sanjeev Kumar Sharma. Thank you, doctor.
Hello, am I audible?
Yes, doctor. Dr. Sanjeev Kumar Sharma is renowned pain medicine specialist working in Jaipur. And he is affiliated to reputed C.K. Birla Hospital and Hospital, Jaipur. Also runs his own private practice in the name of Dr. Sanjeev's Pain Clinic in Jaipur. He has done his MD PMR fellowship in pain medicine and certificate course in Essentials of Palliative Care from AIMS Delhi. And he is mainly interested in interventional pain management, that is radio frequency ablation or nerve modulation regenerative medicine. The topic what Dr. Sanjeev is going to be touching base is nerve interventions for facial pain, a very debilitating pain condition, I must say. And Dr. Sanjeev, the stage is all yours. You can start with sharing your screen, sir.
Hello, all. Is my screen is visible
Yes,
to all of
yes,
you?
the screen is visible. You can go to the presenters mode.
Yeah. Okay. Wait. Okay. Am I audible and my screen is visible?
Yes, sir, your screen is visible, but just, yeah, now the screen is visible. Go ahead, sir.
Okay. So first of all, thank you, Dr. Nurul, Dr. Sonal, and team IOPCON 2024 for giving me this opportunity to share my views as a pain physician on peripheral nerve interventions in facial pain. So thank you for the lovely introduction, Dr. Sonal. So as we all know, the orofacial pain is it is a bridges gap between the medicine and dentistry, and I love presenting my views on the orofacial pain. with my fellow colleagues. So in orofacial pain, neuropathic orofacial pain, it is caused by the pain which is caused by the lesion or disease in the somatosensory nervous system, either continuous or episodic. In continuous neuropathic pain, the patient presents as a constant dull aching pain without any fluctuating intensities of pain. But in cases of episodic neuropathic pain like neuralgias, the patient is having sudden, severe, episodic electric-like shooting pain, which could last for a few seconds. The examples are trigeminal neuralgia and glossopharyngeal neuralgias. So if we see the classification of orofacial pain published by International Classification of Orofacial Pain, published by International Headache Society in 2020, there are multiple causes of this, but the orofacial pain which is attributed to the disease of the cranial nerves is the trigeminal nerve and glossopharyngeal nerve related pain. If we see if the patient is having unilateral episodic orofacial pain, it could be trigeminal neuralgia or some trigeminal autonomic cephalgias. Rest other types are continuous pains which are usually not related to the nerve causes. So in cases of management of neuropathic orofacial pain, the management is multidisciplinary. The patient has to be seen by a dentist or primary physician who will refer to the patient. If the patient is having neuropathic pain component, the patient can be referred to a pain medicine specialist or neurologist or neurosurgeon if some compression of cranial nerve, like trigeminal nerve compression due to some tumors or intracranial space occupying lesion is there. And sometimes we need a role of clinical psychologist also who will help in counseling the patient and help in alleviating the psychological factors like fear, like anxiety, sleep, depression, all those things. So coming to trigeminal neuralgia. So if we see the classification, it was classical trigeminal neuralgia, which is usually idiopathic, and sometimes it is associated with a chronic vascular compression of trigeminal nerve at the root entry zone of the brainstem. Some secondary painful trigeminal neuropathies conditions are also there, which are due to some identifiable structural lesion like multiple sclerosis or neoplastic condition in which there's a definitive nerve damage is being seen, or sometimes iatrogenic due to some surgical procedures or even due to some ablative procedures also, the patient can develop some trigeminal neuropathy. So the pain of trigeminal neuralgia, it presents like an episodic current-like paroxysmal pain, but in cases of trigeminal neuropathy, the patient have some continuous pain associated with abnormal features like the dysesthesias, paresthesias, abnormal sensations like that. So classical trigeminal neuralgia presents with a unilateral sharp electric shock-like sensation in the distribution of trigeminal nerve, and 68 to 98% of patients have spontaneous pain, but sometimes the patient have little bit amount of continuous pain also. So if we see the extracranial branches of trigeminal nerve as it comes throughout the skull and enters into the face, it divides into three divisions. That is the V1, V2, V3. V1 is the terminates. It is the ophthalmic branch which terminates into supraorbital and supratrochlear nerve, and we can see the supratrochlear and supraorbital distribution of the symptoms. Okay, and infraorbital, second is the maxillary nerve, which terminates into infraorbital nasociliary and these branches. And the third is the mandibular nerve, which terminates into the mental nerve and auriculotemporal nerve branches. So if any patient complains of trigeminal neuralgia, usually all of us start with the pharmacological management. Usually the first choice drug is carbamazepine or oscarbazepine. A new drug that is eslicarbamazepine has come up. So usually with the single drug, we start and gradually titrate the dose up unless the patient gets relief or patient has some side effect. Usually monitoring of the liver toxicity or depression of the decrease in the blood counts has to be seen in these patients. So if the patient have a good amount of relief, then we continue with the medicine. Otherwise, we add with some other medications like lamotrigine, baclofen, and also the third choice drugs like gabapentin or pregabalin or topiramate. Also, in some centers, botulinum toxin is also being injected in the peripheral nerve branches. If the patient is having no response with the three medicines have been given with adequate dosing, or if the patient is having adverse drug reactions or relapse, then pain intervention has to be considered. So medical management is the first line according to the Indian specific guidelines. If carbamazepine is unresponsive, then we can add baclofen or TCAs, or can also be combined. But it has been found that tramadol and other opiates are not effective, or effective in very less quantity in these patients. So if the patient is not responding, then we can go for gastric ganglion blocks or RFA, which is our first line treatment. If the not, we can also go for peripheral nerve block, that is second line treatment, if the patient is not affording or not candidate for RFA. So how we make the decision in this trigeminal neuralgia treatment? So when should this intervention should be considered? If the patient is having failure or side effects of the medical therapy, or there is a frequency of acute exacerbations are there, or patient is having long duration of symptoms which are not completely in control with the medicines. Which intervention should be considered? If we want to decide between the peripheral nerve interventions versus gastric ganglion interventions, then age of the patient, health of the patient has to be taken care of. In case of fragile patient, elderly patient who are not who are not medically ready, fit for the RFA interventions or the gastric ganglion interventions, then we can go for peripheral nerve blocks. Willingness to accept facial sensory loss. Some female patients or young female patients who are not ready to accept facial sensory loss. So in those conditions, gastric ganglion interventions are not suitable for that. So peripheral nerve intervention can be done in those patients. If the patient have already got the previous intervention for trigeminal neuralgia and it is not successful, then the choice of the patient for the procedure changes. Invasiveness of procedure, like peripheral nerve blocks are less invasive, gastric ganglion procedures are more invasive. And along with that, desires of patient, cost effectiveness and experience of surgeon or with these procedures are important. So some red flags where we should not do interventions is that abnormal neuro examination is there, that already the patient is having motor sensory deficits are already is there. Then ideally the patient should be referred to a neurologist who will test all the cranial nerves and find out any other specific cause of this pain. If the patient is an abnormal oral, dental or examination, then the patient should be referred to a dentist or to an ENT specialist, so that any other cause of this pain is there, we have to find it out. If the age is less than 40 years, then we have to get the MRI brain with the Fiesta or CIS sequence to rule out any intracranial space occupying lesion or vascular loop or compression, multiple sclerosis. Because in less than age 40 years case, surgical decompression of trigeminal nerve at the root antizone gives very good, long-lasting, good results. But the same surgery doesn't give good results in an elderly patient. If the patient have a bilateral symptom, it suggests multiple sclerosis or demyelination, we have to rule it out. If the patient is having dizziness or vertigo, it could be a brainstem or posterior circulation involvement. Patient is having hearing loss, visual changes, so that is also one of the red flag we have to see. If the patient in the pain in trigeminal neuralgia cases last for more than 2 minutes, then we have to rule out the atypical facial pain. So in my experience, what I have seen, if I do radiofrequency ablation or PBC, percutaneous balloon interventions or gastric ganglion interventions in cases who have atypical facial pain, the patient has suboptimal relief, and later on he or she attributes all his further future symptoms to that procedure. So to prevent marriage of you with your patient, better not to do these procedures in cases of atypical facial pain or the patient having some psychological issues. Last red flag is pain outside of trigeminal distribution. Now coming to peripheral nerve blocks. So peripheral nerve blocks can be done in cases of for supraorbital and supratrochlear nerves. Infraorbital block can be done. Mental nerve and auriculotemporal nerve can be targeted. If we want to target the trigeminal nerve V2 or V3, it can be targeted through the coronoid notch. It can be done under landmark guided also and through ultrasound guided also. The advantages of peripheral nerve blocks is that they have a diagnostic value as well as prognostic value as also, because if the patient having good relief with the peripheral nerve block, it suggests that the diagnosis is correct. Also, the patient will benefit with future advanced interventions like RFA. Second advantage is it is either landmark or US guided, so it is easy to perform and it is easy for the person who is doing that thing. Third is this may be followed by cryoablation or RFA. It is OPD procedure and cost effective. Disadvantage, it is having short-lived or medium-term effect. High rate of recurrence is there. I can say more than 50% patient recur within the next 3 to 6 months. Late differentiation pain can occur if you have made needle trauma to the nerve. Now coming to indications of peripheral nerve blocks, pain persisting in spite of pharmacological treatment, tolerance or no response, heavy adverse drug reaction with the going on medicines, diagnostic to make the diagnosis of trigeminal neuralgia and to relieve the acute pain. Secondary cause, refusal of surgery or poor medical health. Now, if we see the anatomy of the supraorbital notch where the supraorbital nerve vessels arise, so we can say that the supraorbital notch is present at the eyebrow level. So it is present at the middle part of the eyebrow. We can palpate a supraorbital notch and accompanying supraorbital vessels. Infraorbital foramen is located at the cheek area, which is present at the level of midpoint of pupil. If you join the line, vertical line joining the midpoint of pupil, then at the upper brow area, we can find out a supraorbital notch. At the cheek area, we can find the infraorbital foramen, and at the jaw level, we could easily find out the mental foramen through which the mental nerve comes out. Along with that, auriculotemporal nerve is located just 1 centimeter anterior to the tragus, and we can easily palpate it and do the intervention. So as we have seen in this picture. So before going for the procedure, we have to get the written informed consent from the patient, and vital signs have to be monitored. Usually for ultrasound guided nerve blocks, we use a linear probe. But in cases of heavy or bulky face, we have to use the curvilinear probe for mandibular and maxillary nerve block. Local anesthetics like lidocaine or bupivacaine, drugs like triamcinolone or phenol if you are going for neurolytic injections. Usually in non-malignant cases, we don't go for phenol, but in cases of trigeminal neuralgia secondary to some orofacial malignancy, which is causing the trigeminal irritation or pain, then we can go for phenol neurolytic block. Needles, usually we use a 25 gauge, that is brown 1.5 inch long needle, or either we can use a spinal needle, that is 22 gauge. In case of using the RFA, we use a 5 mm active tip cannula and probe. In case of cryoablation, this is a new technique in which we can use 1720 gauge cryoprobe. So coming to supraorbital nerve block, as we have seen, the sensory innervation is the upper eyelid and forehead area, forehead and anterior half of the scalp. So we have to place our USG probe over the brow area, in which we can see a bony depression over this area at the corrugator supercilii muscle. And this depression, we can put the color Doppler and we can see that there is a arterial pulsation over here. So our needle has to be brought in from the in plane approach and targeted over this area. So we can go from lateral to medial approach. In case of infraorbital nerve, we have to place our probe over the cheek area, just below the pupil, just in the line, same in the line of pupil, and we will see a depression in the bony floor, and this we will place a color Doppler and we will see the infraorbital vessels, and that is artery and vein. Then we can, through the lateral to medial approach, we can put our needle in plane and target this nerve. Coming to mental nerve, for mental nerve injection, so in that thing, we will place our probe in a little bit transverse to little bit oblique plane at the lower end of the angle of mouth, and then we will observe a depression or break in the floor of the bone, and we will see that there is a we will see through the color Doppler some vessels flow there, and then we will target in plane like this we have seen in the picture. So this will if the patient is having pain, especially over the lower lip area or the chin area, that it will target. auriculotemporal nerve. In this auriculotemporal nerve, we will place our USG probe in the transverse fashion, just anterior to the tragus area. And what we will see at the depth of around 0.5 to 1 centimeter, we will see some arterial pulsation. Okay, and just along with the arterial pulsation, the auriculotemporal nerve will be there, and you can target through the ultrasound approach. So the innervated area will be the posterior part of the skin, and the temporalis area will be there. So we can target for the pain of over this area. Maxillary nerve. So maxillary nerve, as we have seen, the V3, that is the foramen mandibular nerve, it comes out of the skull through the foramen ovale, but our V2, that is the maxillary nerve, it comes out through the foramen rotundum. So this this nerve comes out and it goes into the pterygopalatine fissure. So we have to target this maxillary nerve at the level of lateral pterygoid plate. This is the lateral pterygoid plate, the anterior superior part of the lateral pterygoid plate. So how can we target it? So we can target by ultrasound approach. In this, we will place our probe in the transverse view over the coronoid fossa, okay, between the just anterior to the tragus, and we will see some musculature over here, and at the depth of around 4 centimeter, we will see a bony landmark, and we will bring our needle from lateral to medial, lateral to superior-medial, basically superior-medial, and then we can target the nerve over here, that is the anterior superior end of the lateral pterygoid plate. So the maxillary nerve distribution, if the patient is having pain is the maxillary nerve distribution, then it will always be covered in this thing. So if someone is not having ultrasound approach, then we can go for a landmark guided approach also. So through the same mandibular notch, we can just go perpendicular to the skin and hit the lateral pterygoid plate at the depth around 4 to 5 centimeter. Then we have to withdraw the needle and go little bit superior medially towards the what we call root of the nose. Okay, and then at the level of around we will feel the patient will feel paresthesia over the tip of the nose and the cheek area, and there you can, after aspiration, you can inject either steroid plus LA or phenol for neuralysis. Mandibular nerve comes out of the foramen ovale, and it goes in posterior to the lateral pterygoid plate in this way. So if you have to target the mandibular nerve, what you have to do, you have to place a probe over the same mandibular notch, and in the fashion of from medial, from anterior to superior and anterior to posterior, we will target it. The needle will go inside it and touch the lateral pterygoid plate, and then little bit posterior to lateral pterygoid plate, we will target the mandibular nerve. Mandibular nerve block can be done in the same fashion in the case in landmark guided approach also. In this, the needle will go strictly perpendicular to the skin and hit the lateral pterygoid plate, and then we will withdraw the needle and little bit tilt the needle a little bit posteriorly and downwards, and the patient will, soon as the needle touches the nerve, the patient will feel paresthesia, where we can inject our medicine. Now coming to complications, nerve injury or paresthesia, dysesthesia can happen. Late dedifferentiation pain can happen if the needle has been injured with your needle. The patient can have temporary numbness over the face, but in case of neuralysis or RFA, the patient can have long-term numbness over the face. Skin sloughing or fat necrosis is seen in cases of using the neurolytic agent like phenol. Swelling and localized hematoma formation can be seen, which usually subside easily by ice packs. Intravascular injection, hypotension, and allergic reactions can happen. In case of maxillary nerve block, intraorbital injection, if you are going too much superiorly, intraorbital injection, diplopia, ophthalmoplegia can occur. In cases of mandibular nerve block, if you are going too much medially, going more than 5 centimeter at depth, then you can penetrate the mucosa of the mouth and you injure the pharynx. Now coming to gastric ganglion intervention, these interventions are done at the level of foramen ovale or just proximal to foramen ovale, that is the ganglion in the Meckel's cave area where the gastric ganglion lies. So as we can see the structure of gastric ganglion is like this. So this is the trigeminal root, this is the trigeminal ganglion or gastric ganglion, and it divides into three parts. That is the V1, which is coming through the superior orbital fissure, V2, which goes through the foramen rotentum, and the V3, that is foramen ovale. Now, out of the three foramen which we are seeing, only the foramen ovale is so its size is so big, which can be easily accessible for these interventions. So what we do, we enter the skull through the foramen ovale, through the Meckel's cave, and for targeting the V3 area, we will target this area. If we want to target the V2, the needle will further go inside and target this area. If we want to target the V1, the needle will go further more inside and we will target the V1 area. But we have to be sure that we are in the right place. Otherwise, if you go a little bit more superiorly, then we can target the, involuntarily, we can target the sixth, that is the cranial nerve, and the patient could have diplopia. Okay, so three interventions which we are going to do, see is the RFA, glycerol rhesolysis, and PVC. So in trigeminal ganglion in procedure, so usually we give some fentanyl and midazolam for pain control and anxiolysis. Pre-operative antibiotics are usually given. If we see for the procedure, first of all, we have to make the patient lie in the supine position. We make appropriate views. For example, first of all, we will make some submental view around 30 degree approximately, submental view, and little bit oblique tilt. So what we see in this, we can easily see the foramen ovale lying between the maxilla and the mandible. So between the mandible and the maxilla, we will find a ovale-like structure, which is easily seen. So this will be our target. Now with the end-on appearance or with the tunnel view, we will enter our needle after local infiltration into this tunnel. And after that, in the lateral view, we will see that how much depth our needle has traveled. And in this, the main important point is that this is the base of skull. This is the hypophysis. This is the clivus, and this is the petrous part. So the angle between the clivus and the petrous part, this is known as clivo-petrosal junction or clivo-dural angle. So needle direction should be towards this point only. And we will, and the entry of foramen ovale is over this point. So our needle has entered the foramen ovale. So our needle can travel from this much distance to this much distance only. So this is around approximately 1 to 1.5 centimeter only, not more than that. So our needle should not cross the clivo-dural angle. Otherwise, we can enter into the brainstem. So in this picture, we can see the patient is having a tunnel view. This is the foramen ovale in which our needle is in the tunnel view, and we can see the needle hub and needle tip in the same line. Needle is in the foramen ovale. And in the lateral view, we can see the needle tip is entered into foramen ovale, and it is in the same direction at the clivus dural junction. So after localization, after introducing all these things, so we will do for sensory stimulation and at 50 hertz, and after motor stimulation also, then we will go for lesioning at the 50, 60, 70 degrees Celsius for 1 minute each. Now, coming to glycerol rhizotomy, usually nowadays glycerol rhizotomy is not so not done nowadays. Previously, it was done very much. So in this glycerol rhizotomy, we will approach the Meckel's cave or through the foramen ovale. Then after entering into the foramen ovale and Meckel's cave, we will put some dye and check whether we are in the right place. Then we will put around 0.3 to 0.5 ml of glycerol into that, and after which the patient is made in upright position with the head down position. So what this glycerol does, it causes glycerol dehydration and desensitization of the trigeminal ganglion. So the success rate of this glycerol rhizotomy was 95% with 50 to 60% recurrence in 24 months. So it has good success rate, but 50 to 60% recurrence was there. Complication was that patient had a good amount of patient had corneal hypoesthesia because of the diffusion of glycerol to the V1 area. Along with that, some masticated weakness was also there. Next procedure is balloon compression, in which what we do with the help of a 14 gauge 10 centimeter needle, we will insert the needle into the foramen ovale, into the Meckel's cave area, and then we will insert a Fogarty catheter. This is a Fogarty catheter which is being inserted, and then it is inflated with a contrast material, and we can see the balloon is seen as like a pear shaped configuration or dumbbell shaped configuration is being seen. And with the help of this compression of this trigeminal ganglion, with the help of this balloon, the desensitization of ganglion occurs, and the patient has having good amount of relief. But masseter weakness is seen in most of in up to 50% of the patient, but patient has good pain relief. Now coming to complication of these procedures, loss of corneal reflex, it is seen highest with the radiofrequency ablation and least with the percutaneous balloon compression. Motor deficit, that is the masseter muscle weakness, that is a V3 involvement. It is seen highest 66% with the balloon compression and least with the glycerol injection. So if also the patient is, if the needle is inferior in the lateral view, if you have seen, if the needle is going inferiorly, then it could lead to puncture of the carotid artery, and it could lead to hematoma, and cavernocarotid fistula can also form. Most common complication which is seen usually in these procedures are the cheek swelling due to hematoma, which is usually resolved with the help of ice packs. Retrobulbar hematoma is also seen if the we are going too much deep. Meningitis, that is infection, can be seen if you are not practicing the sterile guidelines. Brainstem anesthesia, if you are giving local anesthesia into the foramen ovale, and some numbness is also there. So comparison, if we compare all the three procedures, so pain relief is maximum is seen in case of percutaneous balloon compression, but good amount of pain relief around practical experience, I can see 80 to 90% pain relief is seen with the radiofrequency ablation also. Technical success is much more higher in percutaneous balloon compression, but radiofrequency ablation has also got a good amount of technical success. But complication, if we see, then motor deficit and facial numbness are seen much more in PBC as compared to RFA, and loss of corneal reflex is seen much more in RFA if you're targeting the V1 nerve root. So overall, if we see, the RFA has got a good amount of success rate, but some amount of facial numbness is also seen, and little bit of motor deficit if we seen if we targeting the V3 dermatome, V3 nerve specifically. PBC, masseter weakness, facial numbness are seen much more, and it is this procedure done in general anesthesia as compared to RFA, which is done under local anesthesia. So RFA procedure is much more preferred by the patients than PBC procedure. Now coming to glossopharyngeal neuralgia, if the patient is complaining of paroxysmal pain in the sensory division of the 9th cranial nerve, that is patient is complaining of shooting, stabbing, needle-like pain, pain in the ear, base of the tongue, that is the posterior part of tongue, tonsillar fossa, or beneath the angle of jaw, which is going into the pharynx area. And this pain is triggered by swallowing, chewing, talking, and coughing. So this pain is these features suggest the patient is having glossopharyngeal neuralgia. So irritation of glossopharyngeal nerve can be due to multiple causes, and one of the causes is a Stilge or Eagle syndrome, in which the calcified stylohaloid ligament is seen. Now, in these patients, after medical management has not been successful, or not adverse drug reactions are seen, we can go for ultrasound guided glossopharyngeal nerve block or radiofrequency ablation procedures. In this, first of all, we will mark by surface anatomy that is the angle of mandible is being seen. This is the styloid process which has been marked, and this is the mastoid process. So we will mark a line between the angle of mandible and mastoid process, and we will place our probe on this line and tilt our probe little bit superiorly. So what we will be seeing? So we will be seeing at one end, we will seeing the styloid process, and other end we'll be seeing the angle of mandible. Between the two, we will be seeing the submandibular salivary gland, and just below the styloid process, the glossopharyngeal nerve is over here only, but due to the shadow of styloid process, it is not being visible clearly. So how we will do the procedure? We will use the color Doppler signals to see the external carotid artery and IJV, and we have to just avoid injecting into the external carotid artery and IJV. And if we deposit the drug over this area, then it will result in glossopharyngeal nerve blockade. Usually, pulse radio frequency ablation is done for glossopharyngeal neuralgia because it is a mixed nerve. So in this pulse radio frequency, it was shown that it has 92% of patient had more than 3 months of relief, and no major complication was seen in these patients. So pulse radio frequency we can do in these cases. For clinical effectiveness for nerve block with lidocaine and corticosteroid, so they are preferred for short to medium term, that is 1 to 3 months pain term of, and only little experience.
Dr. Sanjeev, your voice is, I think your screen is also hanged, right?
Connectivity would be the issue.
It's not audible.
Yeah.
In relief as compared to glycerol rhizotomy, and patient with the IRF group has statistically significant higher risk of anesthesia in the trigeminal distribution, that is the numbness in the V2, V3 distribution, but that numbness is acceptable to some patients. That can be done. And patients in the balloon compression had statistically significant higher risk of masticator weakness. So these are points which has to be discussed with the patient prior to doing all these procedures. So quality of life, there's improved with the trigeminal neuralgia. So these are the reference.
Yeah, thank you, Dr. Sanjeev. And it was really enlightening because these factors are generally performed, this kind of procedures are performed in hospital setup, clinical setup. Very few people go into this kind of interventions. Thanks for enlightening the audience. And there is a question for you. Maxillary nerve block can be given also given through greater palatal foramen intraorally.
Yes.
Yeah, that is, I think he's suggesting it. So,
Yes.
thank you, Dr. Sanjeev, and thanks for your patiently waiting for us. I know we were delayed, and it's an online forum, so technical glitches and
Hello, madam.
yeah, Dr. Abhay. Yeah, I'm sorry that time I had to cut you
Madam.
short. Yeah, tell me, sir. Tell me, Dr. Abhay, you can speak.
Yeah, sir. Sanjeev, sir, good evening.
Good evening, sir.
Yeah, Sanjeev, sir, good evening.
Good evening, sir.
See, my question is, we are treating the cases of trigeminal neuralgia with
Yes.
routine drugs and doing all the investigations. But what is the problem we are facing?
Yes, sir.
During
Yes.
winter season, the controlled attacks are getting worsened, and the patient are not responding to the drugs to which they are responding during the routine protocol. So, do you have any specific this thing or observation like this, or anything can be done specially for this particular type of attack?
Wait.
Over from my side.
Much more pain during winter season. I'm right?
Yes. During winter season, the patient attacks are not getting controlled with the routine medications what we are using.
Yes.
And we are being able to control those attacks throughout the year. But in the winter season, the same medicine doesn't work, and the patient do have lots of complaint.
Actually, if we see that is this trigeminal system, it is a nerve is a sensory branch. And it has got multiple signals from the facial muscles also. Okay, so in cases of extreme weathers, I can say in cases of extreme weathers, in cases of cold condition, or if we say the facial muscles could go into spasm, and these could help in triggering this already sensitized nerve. So that could be one of the possible explanation. But I haven't got any specific written material on this. But I assume that due to this sensitization, peripheral sensitization, or muscle which has already been in the cold weather, the muscle goes into spasm due to this cold weather, and the patient could have these acute exacerbations of pain due to trigeminalgia.
Remedy for that. What is the remedy for that? I mean, how
I would
those
say
attacks could be
what I suggest
controlled? What
that if
should we do?
I usually in extremes of cold weather, or especially if you are going in the early morning or in the late night, I usually advise the patient to cover their face with a this muffler or some cloth-like cloth. So this is one of the things which I say to my patients. These are the mainly thing which we could do to the patient.
Yes, I think, Dr. Abhay, yeah, your question is answered. And thank you, Dr. Sanjeev, for this enlightening lecture. And it was really insightful because we at clinic level, we don't see such cases or we don't intervene in such way. We follow the more conservative approach. And thank you so much. And I'm sure all our participants who are glued up till now have been benefited. And please join us tomorrow also to listen to our other speakers speak.
Yes, ma'am.
Yeah,
Thank you.
with
Thank you.
that,
Thank you.
today we had around 19 speakers who were going to be presenting, out of which 2 speakers had them unfortunately they could not join us. So now we would be concluding the day 2 of our International Orofacial Pain Congress 2024, and I'll hand over the stage to Dr. Nurul. Before that, I would like to thank all the participants, all the speakers, and all the audience who are watching us through the website, through the Zoom link, and through the YouTube, for patient listening and being a part and making part of this event and making it success. It is not possible without, I always say, we can make best of the presenters can come and present, but if we don't have the audience or patient listeners, it's of no use. So mentors need students and student needs mentors. So it's a cycle of life. And thank you everybody, and thank you Dr. Davis Thomas. I know he's left for the day, and we had a member from ABOP, and we were blessed that we have blessings from all over the world coming up. And thank you all the speakers and for patient listening and the questionnaires that were asked. I'm sure the goodies have already reached the participants who have actively supported the chat sessions. And tomorrow, looking forward to you all with many more speakers. And tomorrow, it's going to be a marathon, again, a brain nerve tingling marathon that is going to really change your life. And it has changed my life. I'm sure it will change your life too. So, Dr. Nurul, over to you now.
Yes. Thanks, Dr. Sonam, for this marathon for today's there from starting beginning to the end. There you glued on your position and you keep single-handedly chairing all the sessions. It is really amazing, actually. I never seen. I did multiple webinars, seminars in my life, but how you single-handedly, moderated all the sessions till early morning from 9 a.m. Now we are having it's 7:30 now, so it's a very long 10 hours, I think, on your place in one place and chairing the session. Introducing your speakers, intervening in midway, asking questions. So it's we have a privilege that you are in our team actually to make such this thing happen and all. And we are really thankful to all our speakers. Some joined from US. We are thankful Dr. T again, Dr. Davis Thomas, who joined again, and we are hoping that he would be joining tomorrow as well. It is a great privilege that the mentor we have, he is available on day 1 as well as in day 2. We are wondering that because he was in cruise, so we thought that whether we would be able to, he would able to make this webinar or not, but we are very fortunate. We have a privilege that he is with us, he's interacting, he's guiding, hand-holding. And, I think our whole restaurants who are, because it's a peculiar actually, means that, the patients is not, the doctors is giving, different regimen, trying intervention, doing intervention. Those who are not specialized in orofacial pain per se, they are our medical colleagues and all. And the patients are suffering actually. So this is the emerging field, and we are hope that we would be able to relieve this facial and orofacial pain in future. And we have army of we are creating the army of dental experts who would manage the upcoming days. And this we have the leaders with us. We have Dr. Thomas, we have Dr. Brijesh, and we have other mentors who are joining. Dr. Sumit will be joining tomorrow from UAE, Dubai, and he is also pioneer in this orofacial pain and sleep medicine, and very well stitched by Dr. Sonal. He made the program, the flow of the event. Everything is well planned, and the speakers he is coordinating and bringing on place is really amazing and all. And we are really thankful, and I'm proud that we have a great team with us. And it's definitely even such a specialty. Orofacial pain is a very niche area, and if you are getting to 50 300 participants registering with this program is amazing. Actually, it's a very niche. Actually, it's not a broad general dental program that we are talking about any restorative treatment, endodontic treatment, or anything. It's highly specialized specialty. And we have fortunate, we have privileged that Dr. One, two, three of our attendants who are from very beginning. I have to praise Dr. Abhay Kulkarni. He is with us, and we are hoping that he would be in our team next edition onwards. And he is, very made this whole engaging and all. Keep on asking questions, engaging, exploring further with all our speakers and all. And tomorrow would be really a weekend. Sunday would be. We'll start with we'll do our breakfast, lunch, and maybe I don't know whether it would be go till dinner. So we will be doing the working breakfast, brunch, lunch, whatever tomorrow. And we have galaxies of speakers coming across globe, and they are the expertise. We talk about this whole intervention, conservative treatment, sleep apnea. We have a multiple specialists who are joining tomorrow. So we are really hopeful that we are getting mesmerizing sessions tomorrow, and with the same energy which we have spent last 2 days, day one on Friday and day two today. So tomorrow is an energetic day for us, and we'll join again. Anybody want to ask any question from our audience regarding anything, they can ask. Otherwise, we will signing off the day with the permission of Dr. Sonal Yarpode, our organizing secretary.
One announcement that we have the link on YouTube live. So even if you have missed any of your sessions, they are still available on YouTube. And National Health Academy has been kind enough to keep last year's presentation also. So you can see all the presentations for the past years also. So you have not missed anything. Even if you have some emergencies or something, you can always log into YouTube and check the sessions. And thank you, everybody. Thank you. And yeah, I missed Dr. Abhay, thanking Dr. Abhay, but Dr. Abhay, thank you, sir. And I think questions and all, now we have given our personal numbers. So I have given that also across. So any issues you have, so you can contact us anytime. And let's sign it off for today. And tomorrow at 9:30 sharp, we'll begin our session. And yeah, I'll be there only, Dr. Noodle. Don't worry. I'm sitting at the same place. My husband has tied me to the chair. Now he's like, don't get up from this place
I
now.
don't know how you are managing your household things. I don't know.
I have a fantastic team. I have a great, loving, caring husband who is passing me things from coffee. There's been 3-4 cups of coffee.
Let me do one announcement. It's a very amazing thing that Dr. Sonal has lost his father-in-law last week only, and he is not in town. Day before yesterday, like on Thursday, she is not she's not in. That was not a working day actually. She has taken off, but still she managed to prepare the introduction profile of all speakers and all. Her husband's lost his father just after immediate next day when they celebrated their 90th birthday. So it's really amazing that even after getting such a setback and all, Dr. Sonal is with us and doing her responsibility. Hats off to Dr. Sonal. really.
Actually, you got me overwhelming. Thanks for mentioning that actually. But it's the blessing of the elders that take us forward. And I'm sure even if he's not there with us today, he would have wanted me to attend this conference with the same zeal and enthusiasm. I'm sure of that. And thank you, Dr. Nurul, for mentioning it. And thank you.
We all hope that he will rest in peace and
It was his 14th day yesterday, so we have said our goodbyes. So, and everything is all the blessings of elders are always with us. So, thanks for mentioning it. You made me overwhelmed now. Thank you. We call it off. Thank you so much.
Thanks, Dr. Sonal. Thanks a lot. Yeah. Okay, we are signing off the day for. We'll join tomorrow 9:30 sharp. Yeah. Okay.